بسم الله. نبدأ التوبيك البيدياتريك ريفراكشن. دي الاوتلاين اللي حتكون معانا ان شاء الله: الكلينيكال اكزامينيشن والسيكولوجيك ريفراكشن والكونسيدريشن اوف ريفراكتيف بريسكريبشن ان بيدياتريك والconsideration for prescribing bifocal in pediatric. Introduction: globally about 448 million children and adults have refractive error. Early detection and appropriate management of refractive error help achieve optimal visual acuity and binocularity overall development. Objective refraction is usually used to determine refractive state in infant and preferable children. Great experience is necessary لأنك تتعامل مع فئة لا تشتكي ولا تتكلم معك ولا أنت عارف فيها، تعتمد على الإكزامنر بشكل خاص. الإيج جروب في البيدياتريك بوبليشن: عندنا الانفانت من شهر إلى سنة، وعندنا التولدر من سنة إلى 3 سنوات، والبري سكول من 3 سنوات إلى 6 سنوات، والسكول إيج من 6 إلى 12، والأدلت من 12 إلى 17 سنة. لما تكون عندك كلاسيفيكيشن واضحة بتعرف تتعامل مع أي جروب وتعرف النورمال رينج في الريفراكتيف ايرور. with age البريماتيور غالبا بتكون عندهم هاي مايوب، والانفانت مستلي بيكون هايبر متروبيا، والبري سكول غالبا بيكونوا ما وصل للمتروبيا او سمول مايوبيا او لس هايبروبيا. في السكول ايج بيكون اصلا هايبر ايمتروبيك او سكول مايوبيا، والادلت غالبا يكون متروبيا او مستلي مايوبيا لان التاسك بتكون معهم زياده. في البيدياتريك ريفراكشن عندنا اوبجكتيف اند سبجكتيف ريفراكشن. الاوبجكتيف عندنا كراتومتري والريتنوسكوبي والاوبثالموسكوبي والاوتو ريفراكشن او اوتو ريفراكتوميتر. الكراتومتري والفالموسكوبي بيعطينا استيميشن، تعرف ان البيشنت هذا او البيدياتريك هو ماشي على الهايبر او ماشي على المايوب. الريتنوسكوبي عندنا الستاتيك والديناميك والنير ريتنوسكوبي، وعندنا في الديناميك 3 انواع منها بتختلف على حسب البيشنت اللي تشتغل معاه. الستاتيك بيكون اصلا البيشنت فوكس في الديستانس، ويكون الاكوموديشن ريلاكس. في الديناميك بتكون الاكوموديشن ستيموليت. الكلينيكال اكزامينيشن عندنا الفيجوال اكويتي والميجرمنت اوف ديفيشن والاوكير موتيليتي والفندوسكوبي والكلينيكال ريفراكشن. والصوره هذه لو ملاحظين عندنا الدكتور الله يعطيه العافيه حاطط البيدياتريك او الطفله في الكومفورت زون، يعني خليها في حضن والدها، خليها مع اللعبه. لو شايفين قاعد يفحص اللعبه حقها علشان يشعرها بالامان. السكيلز هذه في العياده مع البيدياتريك لازم تكون معك موجوده. لغه التواصل مع الطفل اللي انت معه لازم تنزل كطبيب وكاستشاري الى مستوى الطفل، مش ممكن تخلي الطفل يوصل الى مستواك. كلمه بلغته اللي يفهمها، اتواصل معه، انزل الى مستوى نظره، حاول العب معه. برضو لازم تكون عندك في البيدياتريك ريفراكشن الكلينيك الالعاب والحاجات اللي هي اصلا، او عندك اذا عندك ملف بتسجل حاجات من هو الماي هيرو للطفل حقك. هو بيحب سبايدر مان، والله عندك سبايدر مان في العياده، او كلم ابوه جيب سبايدر مان معاك وانا بعطيه. هذه لازم سكيلز تكون معاك عشان تعمل جود اكزامينيشن او ريفراكتيف ايرور. الفيجوال اسمنت في هي اكزامينيشن كثيره في الانفانت، وفي من سنه الى سنتين، وفي من سنتين الى 3، ومن 3 الى 5، ومن 6 الى ومن اكبر من 6 سنوات. غالبا من البري سكول بتكون السميشن ما بتعطينا جود ريزلت، لكن احنا بنعرف هو البيشنت وصل كم، او غالبا هو بيشوف كم. من البري سكول حاولوا جدا انك تاخذ فيجوال اكوتي، ما تستعجل على حتى انكوبراتيف. هذه مشكله كبيره لانك ما بتعمل ديتكشن للامبليوبيا. سايكلوبيجيك ريفراكشن determine total refractive error during paralysis of the ciliary muscles. بعد ما تعمل انستليشن للسايكلوبيجيك دراكس. السايكلوبيجيك اللي بيعطينا الحاجه اللي ما هي مانيفست بالسبجكت ريفراكشن. عندنا برضو في الهايبرمتروبيا غالبا احنا عارفين انه من الانفانت غالبا هايبرمتروب. عندنا المانيفست وعندنا اللاتنت. فلوكيتد اند ابسوليوت. النوعين هذه مهمه جدا. اصعب حالات البيدياتريك هو عندنا في الهايبر، بيعطيك درجه وانت ما عارف هو شايف فيها كم. فالحاجه اللي بيغطيها الاكوموديشن هي الابسوليوت. طيب الانديكيشن فور سيكلوفيجيك، وهذا مهم جدا. عندنا الشلدرين اقل من 8 سنوات، بليز حاولوا تعملوا لهم سيكلوفيجيك ريفراكشن، حاولوا جدا، لانه نتيجه الاوتوريفراكتوميتر ليست التي نعتمد عليها، بيعتمد عليك اكزنر استرافيزماز في الاكسو والايزو، برضه في الفرتيكال، لكن غالبا بيكون اكسو وايزو. عندنا اللاتنت هايبرمتروبيا، وعندنا اليانج بيشنت اللي عندهم سيمبتومز ما عندهم سيمبتوم وما في سيجنيفيكانت ريفراكتيف ايرور. برضو عندما يكون عندنا فاريشن بين السبجكتيف والاوبجكتيف ريفراكشن ان كونستانت اند بوينت ريفراكشن، وصلت لحته انك اشتغلت ما وصلت اند بوينت انت راضي عنها، وحته السودو مايوبيا ودي مهمه جدا. عندنا السلكشن اوف سيكلوفيجيك دراكس، لازم نركز عليها، تستخدم اي دراكس مع المريض حقك. عندك الاتروبين اقل من 5 سنوات، وعندك الهيماتروبين من 5 الى 8 سنوات، وعندك السكلوبنتليت من 8 الى 20 سنه، وعندك التوبكراميد. لكن غالبا السايد افكت حق الاتروبين بنحاول افويد قدر المستطاع، الا في حالات اللي عندهم لارج استرابزماز ممكن نستخدم معاه، او عندهم سبازم كثير في الاكوموديشن بستخدم معاه، وغالبا بنستخدم السكلوبنتليت لان الريكفري والكومبليكيشن حقه او السايد افكت قليله. الكونسيدريشن عند برنسبل اوف ريفراكتيف بريسكريبشن ان بيدياتريك، غالبا احنا بنعمل ار اكس او بنعمل بريسكريبشن. لماذا؟ تو امبروف فيجوال اكوتي، انت لازم تعمل له كلير ريتنال ايمج، وتو امبروف بنكولاريتي. عشان تعمل له وصفه طبيه او او نظاره، لازم تغطي الحاجتين هذه. البنكولاريتي مهمه جدا، اذا فقد البنكولاريتي بتحصل عندنا طوالي اللي هو السبريشن، ويحصل عندنا الامبليوبيا. تو افويد ريسك فاكتور اوف امبليوبيا، لازم تركز عليها جدا، ولازم تبدا معاه في الاوكلوشن ثيرابي من بدري، وهذا يعتمد على القناعه اللي بتقنع فيها الوالدين وليس الطفل. بريسكريبشن في الهايبرمتروبيا من سنه الى 3 سنوات. عندنا اذا عندهم ايزو ديفيشن غالبا بنعطيهم فول سيكلوبيجيك ريفراكشن اذا كان اقل اكثر من 2 دفتر. اذا كان اقل بنعمل فولو اب وما بنعطي بريسكريبشن. في حاله النوديفيشن بنعطي بارشيال كوركشن اللي هو ثلثين البريسكريبشن. اذا كان عنده 6 بعطيه 4. في حاله من 3 سنوات الى 6 سنوات اللي هم البري سكول، اذا كان ايزو بنعطيه فول سيكلوبيجيك اذا كان اكثر من 1.5. اذا كان اقل بنعمله فولو اب وما بنعطي بريسكريبشن اصلا. في حاله النوديفيشن بنعطيه برضه بارشال اللي هو ثلثين اذا كان اكثر من 2.5. في اكثر السكول ايج من 6 سنوات اذا كان يزو بنعطيها الفل، والفل معنا فل يعني جاك 10 اعطي 10 ما عندك مشكله، اعطيه لانه عنده اكوموديشن بيصلحه وحيتحسن. ممكن يقول لك في البدايه ما شفت او كذا، الاطفال دائما هكذا متعودين، بس هذا بيعتمد لما يكون عندك فل سايكلوبيجيك ريفراكشن. ركز انه بعدين تختار لهم النظاره، ما يختار لك نظاره 5 سم وبعدين تقول له والله ثقيل على الانف او ما قدر يتحملها. والنوديفيشن غالبا بنكون عندنا وصلنا للسبجكتيف ريفراكشن ونعطيه الكوركشن ثلث اذا كان اقل من 1.5. في المايوب بريسكريبشن نفس الكلام، في من سنه الى 3 سنوات اقل من 4 بنعتبرها نورمال رينج، ما بنعطيه، بس انه بنعمل ايش؟ متابعه فلو اب. من اكثر من 4 ديوبتر بنعطيه في النير فول reduced by 1 and 2 diopter for nudifyation. في حالة البري سكول من 3 إلى 6 سنوات إذا كان أقل من -3 بعطيه فل. في حالة إنه كان أكثر من 1.5 ونعطيه فلو أب إذا كان أقل. إذا كان أكثر من 3 عندنا نعطيه جيف كوركشن وشك فيجوال اكوتي، لأنه هذا كريتيريا يعني عمر حرج من ناحية الامبليوبيا. إذا كان أكثر من 3 سنوات، إذا كان أقل من 10 أو -10 بعطيها الفول كوركشن. وفي الكوركشن بعطيه فل، ما بكون أنا خايف فيها، ما يتحمل. فالأطفال في هذا السن بيتحملوا وغالبا ما بيشتكوا أصلا. أكثر شكوى الأطفال بتكون إنه ما عجبت النظارة، هذه أكثر شكوى. أو الناس يعني حصل معاه تنمر في المدرسة، تنمر في أي مكان، فلما يجيك أبو الطفل يشتكي إنه ابني ما تقبل النظارة، اسأل. غالبا أنا بسأل في عيادتي الطفل عجبتك النظارة يا حبيبي ولا لا؟ من اللي قال لك مش حلوة؟ من نظارة من زملائك عجبتك؟ أكثر من 10 ديبتر بنحاول نعطيه أندر كوركشن. بالنسبه للبريسكريبشن فول استجماتيزم، اذا كان عندنا من سنه الى 3 سنوات اقل من 2.5 ديوبتر ما بنحتاج نعطي بريسكريبشن، ولكن بنعمل له فولو اب. اذا كان اكثر من 2.5 قف بارشيال كوركشن اند فولو اب في 3 الى 6 سنوات. اذا كان اقل من 0.5 اللي هو 0.75 نعطي النو كوركشن، الا اذا جاك بيشتكي في كومبلين. حتى لو طفل بيشتكي من هيدك، بيشتكي مش عارف ايش، لازم عنده مشكله في الفوريا، في الحاجات هذه ممكن تعطيها ال 0.5. اذا كان اكثر من 0.5 give full correction and reduce or reduce for adaptation. الادابتيشن حق الاستجماتيزم بياخذ وقت، ما زي الهايبر والمايوب، لان الاكوموديشن ما بيعرف يصلح الحاجه هذه، خصوصا في السمول ديجري. اذا كان الهاي ديجري الاكوموديشن بيظبط امور، ما عنده مشكله. طيب في حاله انه اكثر من 6 سنوات، اذا كان اقل من 1 نو كوركشن اند فلو اب. اذا كان اكثر من -1 بنعطيه جف في الكوركشن او ريديوز فور ادابتيشن. الاوبليك لازم نركز فيها. الاوبليك عندنا في 90 ومن 90 و180 20 درجه يمين و20 درجه يسار، هذا بنعتبرها اوبليك. يعني ما بعد ال 120 بعتبرها اوبليك، وما بعد من 10 من بعد من 1 الى 20 من بعد ال 20 اعتبرها اوبليك. الاوبليك استجماتيزم بسبب لنا ميريديال امبليوبيا. ميريديان امبليوبيا لان الاكوموديشن ما بيعرف يصلح. الاكوموديشن يحاول انه يعمل كوركشن للسيماتيزم وما بيقدر، لانه ما هو في الفيرتيكال ميريديان او هوريزونتال ميريديان. اذا كان في الاوبليك، اذا كان من واحد اكثر من واحد بنعطيه، بس بنحاول نعمل له بارشيال كوركشن. عندنا بريسكريبشن بايفوكال بيدياتريك. متى انا بعطي بايفوكال للبيدياتريك؟ اول حاجه عندنا الاكوموديتيف ايزوتروبيا والهاي اي سي. لما يكون عندنا هاي اي سي اي ريشو بحاول بعطيه، لانه عنده بيكون في النير كبير جدا، وبعطيه بعطي بايفوكال بيعمل ريلاكس. عندنا برضو الكونجينيتال افاكيا، بنشرحها ان شاء الله في السلايد الجاي. كونستانت ايزوتروبيا اند الترنيتد ايزوتروبيا، والسودو فيكيا شلدرن، والمايوبيا كنترول، والايزوتروبيا، والسيربترال بالسي، والداون سندروم. اللي عندهم مشاكل في الكنترول، في عندهم مشاكل او امراض نورولوجيكال، غالبا ما بيعملوا كنترول في الاكوموديشن، فبضطر اني اعمل لهم بايفوكال. طيب افاكيا ان سودو فاكيا، ايش اللي بيختلف معانا في الكوركشن في الافاكيا؟ انه الاي ستيل جروثينج، انت بتشتغل بيدياتريك لسه ما وصل مرحله المتروبيشن، وصل في النمو. وبرضه انه عندنا ريسك فاكتور اوف دبلوبيا، وهنا قسمنا النير اد will be given للبيشنت. اذا كان عندك اقل من سنه بعطيه بلاستري مباشره، اقل من سنه، لان الطفل في هذا العمر هو غالبا كله نير تاسك حوالي اليد فقط. من سنه الى سنتين بعطيه بلس 2 ديوبتر، ومن سنتين الى 3 سنوات بعطيه بلس 1. ونظرا للكوست العالي بتاع البايفوكال بضطر اني بضيفها في الكوركشن من الديستانس. بعطيه وصل عندنا وصل 18 بلس 18 بعطيه فوقها بلس 3 بتكون بلس 21. تمام. واذا كانت في من 1 الى سنوات بعطيه بلس 2، واذا كان من 2 بلس 10 وبلس 1. اكثر من 3 سنوات بعطيه بلس 3. لكن هنا وصلنا انه مرحله انه الطفل بدا يشتي يشوف التلفزيون، بدا يشتي يشوف الناس اللي خارج، بضطر امشي الاكسيتيف او البايفوكال او البروجريسيف ايا كان. ودي شكل الاكسيتيف بتكون عندنا عدسه مقسومه نصين، نص كامل ديستانس ونص تحت كله فورنير. عندنا الحاجات دي اللي ممكن تقابلنا في البيدياتريك. البانزم غالبا بيكون استجماتيزم مع هايبر متروبيا، والداون سندروم بيكون مع الهايبر عنده الضروري استجماتيزم، والماكروفثالميس بيكون هاي هايبروب اب تو 20 ديوبتر. عندنا السكرولوكورنيا او الكورنيال بلان بيكون هاي هايبروب، والكونجليتال ديفكت غالبا بيكون عندهم مايوبيك ريفراكتور غالبا. ثانك يو. اي كويشن.
شكرا جزيلا للدكتور. إذا في حد عنده أي سؤال. طيب بالنسبة للريفراكشنز اللي بيتكلم عنه الزميل، هو دائما أندر سايكلوبليجيك ريفراكشن في الأطفال. الأرقام هذه الذي أعطيت هي لازم تكون أندر سايكلوبليجيك ريفراكشنز. الأطفال دائما بيتقبلوا الايرور اوف ريفراكشن زي ما قال الدكتور، سواء كان هايبر متروب أو ميوب أو استجماتيزم. في الغالب بنعطي لهم الفول اتروبين كوركشن إذا كان في عندهم سكوينت، وإذا كان ما في عندهم سكوينت في الغالب في الهايبر متروبيا زي ما قال الدكتور بنعطي لهم حاجة يسموها الماكسيمم ادابتد بلس لينس، أكثر حاجة يقدر يتقبلها الطفل. بالنسبة للبايفوكال مهم جدا، لأنه في عندنا الاكوموديشنز كونفرجنس اكوموديشن ريشيو في الغالب أوقات يكون عالي، يكون عنده في الديستنس سليم النظر حقه بالنظارة، لكن لما يقرأ فبيحصل لهم غالبا إذن ايزوتروبيا، فهذا لازم ما يعطى برضو البايفوكال جلاسز. في الغالب الافريج البايفوكال ما بين بلس ادينج بلس 2 اور بلس 3 للديستنس ريدنج جلاسز. حد من الزملاء يشتي اي سؤال ولا شيء؟ شكرا جزيلا دكتور. المحاضر الذي بعده اسمه دكتور خليل الخطيب، تفضل. دكتور خليل برضه من زميلنا البروف التوفيق في بيدي لنا المحاضرة، تفضل يا دكتور.
Good morning. Thank you, Chairman and Co-Chairman. I'm happy to talk about this lecture, Advanced Technique and Technology for Treatment Keratoconus. What's the problem? Okay, keratoconus is a progressive tubically asymmetrical non-inflammatory axial ectasia of the cornea. It is bilateral in 96% of cases, development asymmetrical typically with diagnosis of the disease in the second eye lagging about 5 years behind of the first. Give me. Okay, the types of keratoconus according about more like the base curve and about the location of the navel cones and like that. Okay, the keratoconus, we can treat the keratoconus about surgical and non-surgical. Surgical bond of instrument lens implant and implantable corneal lens and corneal transplant and BRK. Non-surgical by spectacles and contact lens and collagen cross-linking. The advanced protocol for treatment keratoconus by use scleral contact lens. The hard contact lens consists about 3 corneal contact lens and semi-scleral contact lens and full scleral contact lens. This is the set about scleral contact lens. The advanced use of scleral contact lens for treatment keratoconus. The first of quadration يعني بنقسمها أول شيء لأربع أقسام. We can make verification from any quadrants and make verification for the cornea and reshaping cornea and the edge valute and light option. Okay, the scleral contact lens consists of central corneal zone and lid zone and scleral lens zone. Central corneal zone, we can increase and treatment and change of depth for scleral contact lens about extra by steep and flat meridian. This is the technique for observation the scleral contact lens by slit lamp and see that the width between the contact lens, scleral contact lens and eye by slit lamp. The normal central corneal zone is from 150 to 250% micron. This is 500 micron. That's the distance between the cornea and the contact lens. This is high, and this is 50 micron. This is 600 micron. And we can evaluate the limbal and by slit lamp use the technique by under the fluorescein and see this is good, this is moderate. This is the full quadrant where can be verification. This is 0 degree, and this is 90 degree, and this is 180 degree, and this 27 degree. We can make verification from scleral landing zone and the landing zone and the central cranial zone. This is the presbyopic system. We can edit from scleral contact lens the presbyopic system for treatment presbyopic patient. This is the orthokeratology system. We can use the scleral contact lens for treatment myopia from -5 and up, and with the rule stigmatism, without stigmatism. This system consists about treatment zone and resurfacing zone and dynamic edge profile zone and stabilization zone. Thank you. Any questions?
شكرا جزيلا للدكتور خليل. فإذا في حد عنده أي سؤال. Treatment modalities of the keratoconus غالبا الآن عجلة سريعة تمشي يعني فيها. كنا من البداية نتكلم عن BKB and only solutions for the keratoconus. Now الموداليتيز اختلفت كثيرة especially في السكليرال contact lenses والcross linking therapy. في حد له أي سؤال؟ شكرا جزيلا دكتور.
المحاضرة الثانية prevalence of active trachoma and associated risk factor among primary school. دكتور محمد.
السلام عليكم ورحمة الله. Title of articles: Prevalence of active trachoma and associated risk factors among primary school children in Amran City, Yemen, a cross-sectional study. Introduction. Trachoma caused by repeated ocular chlamydia trachomitis has recently been endemic in 11 of 22 countries in the eastern regions, including Yemen. The infection spreads through personal contact via hands, clothes, or beddings, and by flies that have been in contact watch discharge from the eyes or nose of an infected person. Trachoma is a disease of periphery that affects over 1 billion of the world's poorest peoples. According to the recent WHO, trachoma is estimated to be responsible for the visual impairment of about 1.9 million people, of whom 1.2 million are irreversible blinds. Approximately 185 million people worldwide were living in trachoma endemic districts and were at risk of trachoma blindness. هذه خلاصة دراسات سابقة، عدد 19 دراسة سابقة أجريت في اليمن من العام 2006 إلى العام 2021. في مختلف في الفئة العمرية من سنة إلى 9 سنوات، وكان معدل الانتشار يتراوح من 0.0 في بعض المحافظات في بعض المناطق إلى 11.9 كان، وحتى الريسك فاكتورز. The objectives: the prevalence of active trachoma among primary school children has not yet been disclosed in Amran. Therefore, the aim of the study was to determine the prevalence of active trachoma and associated risk factors among primary school children in Amran city, Yemen. The methodology: study design and study population. A cross-sectional study was conducted among primary school children living in Amran city, Yemen from September to November 2022. Data source: data on the socio-demographic and health characteristics of child were collected using a structured questionnaire and eyes examination. In the study, information about a child was conducted by interview the household head. The child's eye examination was done by Dr. Abdullah Jafar after training by ophthalmic specialist according to the WHO grading system for trachoma. Study variables: the response variables of this study was presence of signs of active trachoma (TFTI) in either eyes of that child, which can be recorded as the following بناء على المعادلة. Sampling procedures: a random sampling technique was applied to select study participants. A total of 312 primary school children were randomly selected from some primary school in Amra city. الاندبندنت او الريسك فاكتورز، حددنا 11 ريسك فاكتورز بناء على الدراسات السابقه اللي هي السكس والايج والتايبس اوف سكول والفريكونسي اوف فيس واشنج بير دي يوزنج سوب when washing face cleanness, presence of flies on child's face والاوكيبيشن اوف household head, education levels of household والفامily size والمين source energy والمين source of waters والwaterless all the days والlatern availability of solid waste disposal facility والkeeping animal living house والethical approval from Al-Razi University. والstatistical analysis اعتمدنا على الباينري logistic regression models was used to determine the prevalence and risk factors of active trachoma among primary school children living in Amran city, Yemen. Results: الباك جراوند حق الكاركترستكس اوف الستدي بارتيسيبنتس السكس كان العينه تقريبا متساويه، نص من الميل والنصف الاخر من الفيميل. من ناحيه الايج كان الماست من الفئه العمريه من 7 الى 9 سنوات 95%. والتايبز اوف سكول احنا اخترنا 66% من المشاركين من الببليك و34% من المشاركين كانوا من البريفت. frequency of washing per day 95% كانوا يقوم بغسل وجههم اكثر من مرتين في اليوم. use of soap when washing face 59% no و 41% yes. face condition 42% unclean و 58% clean، وكنا نعتمد على no nasal discharge eye discharge. الفلايز presence on child's face during interview 88% كان no و 12% yes. الإديوكيشن ليفلز الأغلب كان برايمري 45.8%. الفاميلي سايز كان 51% من الفئة العمرية من 4 إلى 6 أفراد في العائلة الواحدة. المين انرجي سورس 55% كانوا يعتمدوا على الغاز و40% على الوولز. المين سورس اوف واترز اغلبهم 69% كانوا يعتمدوا على الوايتات. الواترليس اول ذا ديز 77% يس 30% نو. واللاترن افيابيليتي 89% يس و11% نو. والافيابيليتي اوف سوليد ويست ديسبوزل 63% يس 37% نو. والكيبنج انيمال الليفنج هاوس 67% نو 33% يس. البريفالنس حق الاكتف تراكوما ان امران كان 10.1. والريسك فاكتورز احنا 11 ريسك فاكتورز درسناهم متعلقين بالبريفالنس، لكن اللي ظهر من خلال التحليل الاحصائي ان فيه علاقه ما بين البريفالنس وما بين الريسك فاكتورز هم فقط 6 عوامل اللي هم الفريكونسي اوف فيس ووشنج واليوز اوف سوب وين ووشنج فيس والتايب اوف سكول والفيس كونديشن والفلايز بريزنس اند شيلز فيس ديورينج انترفيو. باقي العوامل ما كان فيش معنا فروق ذات دلاله احصائيه عند مقايسه معامل الانحدار. الكونكلوجن زي ما قلنا اظهرت الدراسه انه معامل او الريسك فاكتورز المتعلق بالبريفيرنس اوف اكتف تراكوما اللي هو الفريكونسي اوف فيس ووشنج واليوز اوف سوب وين ووشنج فيس والتايبس اوف سكول والفيس كونديشن والفلايز بريزنت اوف تشيلد فيس ديورينج انترفيو. هذا كان significantly associated with trachoma. لذا the study recommended that any concerned bodies at the prevention and control of trachoma among primary school children living in Amran city should give special attention to these factors. Implementing the WHO endorsed the safe strategy was recommended for the effective prevention and control of trachoma in the study area, since the prevalence of active trachoma 10.1% was higher than the WHO recommended threshold اللي كان more than 10% prevalence. شكرا جزيلا.
شكرا جزيلا للدكتور على المحاضرة اللفتة الطيبة على التراكوما. بالنسبة للتراكوما one of the curable disease worldwide. التراكوما always it will be affecting the children below the age of 10 years, and the blindness it will be affecting the elderly people at the age of between 40 and 50 years. And this is one of the curable disease of the blindness according to the safe strategy for the WHO recommendations. السيف استراتيجي هو دائما كنترول على الكوميونتي الذي هي الفيس كلينينج والكوميونتي اورينتيشنز about the flies control for the spread of the trachoma. الفايزر الذي اخرجت الازيثروميسين كان قبل الازيثروميسين WHO التريتمنت اوف تراكوما طول السنة هو ياخذ البريفنتيف تريتمنت اوف تراكوما like السلفوناميدز or tetracycline whatever is topical or systemic. طبعا السيستميك ما بيعطى للاطفال التتراسايكلين. اول ما جات العلاج حق الفايزر الازيثروميسين عمل صرخه بالنسبه للكنترول اوف ذا تراكوما according to the safe strategy زي ما عمل الايفرمكتين في الكنترول اوف الأونكوسيركيازيس. فشكرا جزيلا للمحاضرين جميعا، واذا كان في اي سؤال فتفضل. ايوه. المحاضره القادمه هي بيكون عن طريق الكوردينيتور البروف مازن سنجاب في الليكتشر القادم، يعني فيها في حد له اي اضافه او اي اسئله بالنسبه للسيشن الاول. تفضل دكتور.
لما عملتوا البحث نسقتوا مع وزارة الصحة وبرنامج التراكوما ولا عملتوها لوحدكم؟ أنا رأيي الشخصي في برنامج اسمه التراكوما بروف توفيق الخطيب، أنا من رأيي تنسق 10% رقم خيالي، إلا إذا تشتوا مساعدات مالية نعم تحطها، لكن في الواقع كم حالة شفت تراخوما يا بروف؟
بالنسبة للتراخوما في صنعاء هي قليلة بالنسبة دائما بنشوفها في الأطفال على أساس this is the active stage of an trachoma. أما في الكبار هم في الغالب الذي يقبلون من المناطق الصحراوية زي الجوف زي مارب زي شبوة، هذه هي فعلا منتشرة في الغالب. نحن بنشوف الالدرلي بيشنتس الذي هي الكومبليكيشنز اوف ان تراكوما يعني فيها. بالنسبة للسيف استراتيجي على أساس برنامج الفيجن 2020 إنه في عام 2020 عندنا خالي من الأمراض في العالم من العمى whatever is the cause of the blindness، والآن البرنامج انتقل إلى 2035. فهذه يعني السياسة تعمل بالجهد وارحم الراحمين بالنهاية هو الشافي. أما بالنسبة للبريفالنس اوف تراكوما الذي هي أكثر من 10% في الغالب قد تكون موجودة في المناطق الصحراوية. الرقم الذي طلع في صنعاء طبعا في الغالب أكثر الأخصائيين الذين موجودين ثلثين أطباء العيون موجودين في صنعاء، فمتوقع الرقم هذا أنه بيكون مقارنة في بقية المحافظات يكون رقم كبير يعني جدا. نعم تفضل دكتور.
شكرا على المحاضرة ممتازة. فعلا احنا قمنا بالتراكوما في بعض المحافظات اللي كان الهدف عندنا ان احنا نروح للرورال اريا. الرورال اريا هي تمثل فعلا الانسيدنس او البريفرنس اوف تراكوما. المدارس غالبا تكون في المدن والهذا ويكون توفر عندهم الماء، لأن التراكوما تتواجد في المناطق الجافة اللي لا يوجد فيها ماء. ولهذا التراكوما كنا أول ما بدأنا في ممارسة العيون كنا نشوف التراكياسيس، وكان one of the cause of blindness. التراكوما كانت تعتبر حتى في السعودية كانت منتشرة تراكوما. مجرد حصل طفرة اقتصادية وتوفرت المياه والحياة تحولت إلى مدنية بدل ما كانت ريفية، انتهت التراكوما. ولهذا التراكوما لا تجدها في المناطق الحضارية أو في المدن، مجرد توفر الماء انتهى الموضوع. فالمدارس أعتقد لا تعطي انطباع أو لا تعكس البريفرنس الحقيقي للتراكوما، إنما هي المناطق الريفية. وإحنا كنا رحنا إلى عدة محافظات. أنا كنا بالمسح أنا والدكتور عبد الجبار العطاب، وفعلا وجدناها في شبوة في مارب في الحديدة، لكن كنا نجدها في المناطق النائية. شكرا.
هذا هو اللي في الجامعات المدارس الخاصة كانت نسبة للانتشار 0%، يعني حتى أنا طلعت المدارس الخاصة 0% معدل انتشار التراكوما، وكانت فقط منتشرة في المدارس الحكومية. والمدارس الحكومية أصبحت فعلا الآن لا يدرس بينها إلا الناس اللي هم يعني تحت خط الفقر. وكانت واحدة من الريسك فاكتورز حقا اللي أدرجناها أنه لم نجد حتى متعلقة بالنظافة وهو كان مرتبط ارتباط كبير بطلاب المدارس الحكومية.
التراكوما أغلبها يعني الانتقال عندها في الفلايز، فكل ما كان الجود سانيتيشنز في المجتمع كل ما قلت الانسيدنس والبريفالنس اوف التراكوما. كل ما كان السوشيو ايكونوميك لو في المجتمع والسانيتيشنز الديستريبيوشنز والفلايز، هذه هي one of the main factors of the distributions of the trachoma، وهي موجودة في المناطق الريفية كما ذكر الدكتور محمد، لأنه one of the الدكتورز which is working الجلوكوما مع البروف توفيق مع التراكوما مع البروف توفيق. فهي أكثر حاجة منتشرة في المناطق الريفية الذي هم منتشرة فيها أكثر هي الذباب والمخلفات حق الحيوانات والمخلفات الهيومن بيز، فهي أكثر منتشرة لها علاقة في الذباب. فإذا كان قلة الذباب في المجتمع فهي بتقل البريفالنس اوف ذا تراكوما. حد له أي إضافة؟ تفضل يا دكتورة. سؤال الدكتورة: هل بيعتمدوا على الأتروبين في السايكولوجيك ريفراكشنز under the age of 5 years؟ دكتورة الأوبتومتريست. الريفراكشنز for the children below the age of 5 years using the atropine cycloplegic refractions تعتمدوا على الأتروبين على
والله في حالة إنه كان عنده سترابلمز أو عنده حوالي خصوصا إيزو ولا إكسو، إذا كان درجة كبيرة بعمل له أتروبين. أنا ما بلجأ للأتروبين إلا في حالات خلاص درجة الإيزو عديته في الكوركشن بالسايكلوبنتليت وما نفع. احنا غالبا من افويد للاتروبين للسكلو الى السايد افكت. في ناس بتعطيها تستخدمها القطرات يعملها كلما وقت الصلاه او اي وقت، قال والله ازيد اعطيه مقطر. في واحد جاء من البيشنت قد لون البنت خضراء من كثر ما عملت او زيدت الاتروبين، لانه بيعتمد القطره الاتروبين بيستخدمها في البيت. فاحنا في اقل من 5 سنوات غالبا السكلوبنتليت بنستخدمه، الفول سايكلو بعطيه. جانا في النكست فيزيت ولسه في عنده ايزو او في عنده لسه الاسترازماز كثير او عنده سبازم كثير، احيانا تعطيها السايكلوبنتليت ولسه في سبازم اكتف سبازم، بضطر ان بحول على الاتروبين واشوفه بعد كده. فاحنا غالبا افويد قدر المستطاع علشان السايد افكت، بعدين ما غيرها احنا بنستخدم.
طيب بالنسبة للأتروبين دائما بنعطي للمريض الإرشادات إلى الأبوين قبل استخدام القطرة. دائما الإرشادات is very highly restricted للأتروبين. بعض الأوقات يجي يقول لك أنا ابني ما رضى يستخدم القطرة، فبنقرب له نقول له ممنوع الاستخدام القطرة، هذه قطرة حمراء ما تعطى إلا بواسطة الأخصائي العيون. أما بالنسبة للريفراكشنز أندر سايكلوبليجيك هو البيست تريتمنت تو دو إذا أتروبين. حتى سايكلوبنتليت لو تلاحظوا إنه الكومبليكيشنز حق السايكلوبنتليت more than the effect of an atropine. الأتروبين أوقات نقدر نتلافاها في بعض السيديشنز والعلاجات. بعض الأوقات بالنسبة للسايكلوبنتليت أنا من شفت ضمن الحالات سايكلوبنتليت side effect more than the atropine even in adult and children. أما بالنسبة للرefractions under atropine for the children under having is an esotropia is a must. حتى السايكلوبنتليت ما يعطي لنا سايكلوبلوجيك ريفراكشنز. الموست اتروبين هو الذي بيعطي لنا الجود سايكلوبلوجيك ريفراكشنز within the durations of 3 days. برضه حتى السايكلوبلوجيك ريفراكشنز ما بيعطي الا بعد 3 ايام، لانه هذا الاكشنز اوف ان اتروبين، هذا الاكشن اوف ان اتروبين. لكن هايلي ريستريكتد انه نعطي الامراض الابوين الارشادات السليمه بالنسبه لاستخدام القطره. القطره هذه ما تعطى الا للطفل كل 12 ساعه لمده 3-4 ايام، ويعود لنا المريض مع القطره ونسحب القطره من المريض، لأننا نقول له هذه القطرة للفحص فقط. إذا قال نسيتها في البيت تقول له أول ما توصل البيت افتحها وارميها ومزها كذا للأرض وارمي بالقطرة بعيدة من الأطفال أو تناول الكبار. طيب شكرا جزيلا للجميع وجزاكم الله خير. خلاص نبدأ السيشن الثاني. شكرا جزيلا.
بسم الله الرحمن الرحيم. السيشن القادم سيكون خاص بالمياكو، سيديره الأستاذ الدكتور مازن سنجاب. الدكتور مازن طبعا غني عن التعريف، أحد أبرز أطباء العيون على مستوى العالم. باسمنا وباسم الجمعية اليمنية لأطباء العيون نتقدم له بالشكر الجزيل. ما قصر معنا في السنوات الأخيرة المحاضرات الكورسات سواء أونلاين أو لما نحضر عنده في أي فعالية في الخارج. نتمنى أن تتحسن الأوضاع في اليمن ونستضيفه استضافة شخصية إلى صنعاء أو عدن أو أي محافظة أخرى إن شاء الله. الميكروفون بيدك أستاذنا الدكتور مازن.
السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا بكل خير وشكرا للتقدمة. وأود أن أشكر الجمعية اليمنية لإتاحة هذه الفرصة للقيام بجلسة مياكو فيما يتعلق طبعا بالكورنيا أند ريفراكتيف سيرجري، كاتراكت أند ريفراكتيف سيرجري. وأود أن أشكر أيضا السادة المتحدثين، الأستاذ الدكتور أحمد عساف من مصر والأستاذ الدكتور شادي عواد من لبنان، وستنضم إلينا الدكتورة نانسي الرقاد أيضا من الأردن. أود أن أشكرهم جميعا لأنهم قبلوا الدعوة ويعني للدعم. طبعا نبدأ هذه الجلسة أولا مع الدكتور شادي عواد من لبنان، نظرا لوجود ظرف عنده يحتاج إلى مغادرة الجلسة مبكرا. Good morning, Dr. Shadi. Good morning, Dr. Ahmed. Let's start with Dr. Shadi's presentation, please.
Thank you so much. Thank you, Mazen. Thank you, everybody. It's a great honor to be presenting for the first time for the Yemeni Ophthalmic Society. I'm going to share my screen. Would somebody allow me to share my screen because it's still disabled? All right. The topic I'm going to talk about today is corneal allogenic intrastromal ring segments for keratoconus, also known as CARES. This is in the realm of therapeutic refractive surgery, and the concept of CARES or allogenic intrastromal ring segments was introduced by Susan Jacob back in 2017. The concept initially was to use something instead of the PMMA ring segments. Everybody know intact scalar ring, Ferrara ring. So use something different, something allogenic to avoid complications of these segments. One of them, extrusion, intrusion, acute stromal necrosis, and so on and so forth. So very basically how the procedure is done, this is one of my cases, using those trephines that are double-edged, Jacob trephine. We can punch the cornea, creating a disc, as you can see here, with that you can cut it with a super sharp instrument. And then basically I mark the cornea, as you can see here. And just like a regular intacts, I use still those mechanical dissector to make sure there are no bridges in there, because those segments are allogenic, that are flaccid. So if there is a ring segment that can, they might not go in. I pull it in using a Sinskey hook, then I massage it again to avoid any twists in the cornea. Again, those are flabby segments. They are soft. They're not like rigid like PMMA segments. So they're a little bit of modification when you perform a corneal ring segments than when you perform these procedures. So I'm going to discuss a little bit my experience with CARES, which started in 2019 till now, where I started performing CARES first in severe cases and special cases. And then ultimately, I started performing CARES for all my segment cases. I don't do any more PMMA segments. I only do CARES for all my patients. This is a summary of my experience with CARES in terms of result. As you can see here, the CDVA improves dramatically. We have 81% improvement of 2 lines or more of CDVA. When you look at the change in UDVA and the change of CDVA, of course, no loss of lines of CDVA, but again, a gain of 2, 3, 4, and 5 lines sometimes. If you look at segmental tomography and topography, let's start first with topography. You can see a major decrease in Kmax. Basically, it depends on the Kmax tackled. The higher the Kmax, the more the flattening, even with the same segments. And this is something we have seen also in PMMA segments as well. Again, this is like about 5 or 6 diopters decrease in Kmax on the average, a decrease in SIMK and all the other topographic parameters. Now, if you look at higher order aberrations, you can also see that we have a major decrease in vertical coma. As you can see here, about 1.2 diopters, and this is what we get with the best results of the PMMA segments. Now, if you look at segmental tomography, and this was using the MS39 high definition OCT, which allows us to segment the tomography into epithelium, anterior stromal, segment size, and so on and so forth. I have a lot of things to show, but as a summary for this quick talk, you can see that what happens is actually an improvement, an improvement in stromal elevation that happens within 1 week, and then a certain flattening thereafter. So the arc length shortening or the tectonic changes in the stroma happen really the first week after corneal ring segments. Even though we might notice that the improvements keep developing over the next few weeks and sometimes months, but this is actually because we have an improvement in epithelial thickening. So as you can see here, we have epithelial thickening just adjacent to the corneal ring segments that tapers off to the center of the cone. And this actually brings about another improvement. Typically happens within the first month, and usually it flattens or it stabilizes thereafter. So technically, after 1 to 2 months, there is no more changes in corneal improvement, and most of the technical changes or tectonic changes, structural changes, happen the first week when the stromal elevation decreases. By the way, we've done the same study for intact PMMA corneal segments. That's almost the same mechanism of action. So let me put things into a more concrete example, because that's all abstract till now. So if you look at the tangential anterior corneal curvature, as you can see here, using an absolute standard scale, this is preoperatively, and that's postoperatively. Now, here we have inserted a PMMA allogenic segment, and as you can see here, it's pretty neat in the cornea. We have an improvement in the cone, but more importantly, we have an improvement in the repeatability of the measurement, which means if you're planning to perform topography guided treatment plus or minus cross-linking, then the input is much more accurate than when we deal with a Kmax of more than 50 diopter. The repeatability is much better, hence the topographic, the corneal wavefront, the ocular wavefront data is much more accurate. Let's see what happens with the same patient with stromal elevation. As you can see, this is stromal elevation, which means after we remove the epithelial impact using high definition OCT like the MS39, we have a major or a whopping improvement from at least 26 to 28 microns to about 12 to 14 microns, just 1 week, just 3 days postoperatively. Now, if you look at the epithelial thinning 3 days postoperatively, it's almost none. There's no epithelial reaction yet. We are putting the patient on steroids, the epithelium is obtended, and it takes some time to start reacting, as you can see here. However, if you wait 1 month, we start seeing epithelial thickening just adjacent to the ring. We have an improvement, a thickening from 50 microns to 71 microns, as you can see here. And this will bring about a flattening in the corneal curvature. So if you can see here, this is the allogenic case, and this is the corneal, this is the epithelial thickness right adjacent to it. As you can see here, it is tapering down all the way to the center. And that's the second improvement that we usually notice whether we insert PMMA segments or allogenic rings. Again, when we combine this with customized PRK with cross-linking, we have even more effect. This is, as you can see, this is preoperatively, allogenic segments 4 days postoperatively, and then 1 month, this is where the epithelial thickness kicks in as well, and epithelial remodeling, and we have a major decrease in the cone from 54 all the way to 46. Now add to it transepithelial PTK with cross-linking, and then we have an almost regular surface in the center. It's very regular, and that's a 20/20 cornea with a, of course, corneal, the allogenic segments showing down. Now, again, cares as a secondary intervention. So this is a patient who has had a Kera ring implant outside and coming with uveitis. When I saw him, I saw uveitis plus a penetration of the segment into the anterior chamber, so an intrusion with a local hydrops, as you can see here. And you can see the edge of the PMMA. And those triangular rings are pretty tricky because, as you can see, they hedge against the endothelium. And these patients are famous for rubbing. So they're going to rub, and that edge is going to penetrate into the stroma at one point in time. That ring was implanted several years ago outside clinic. And as you can see here, what I actually did is removing that ring, waiting about 2 months for the hydrops to improve. And then, as you can see, you can still see the tract open down there. But what I did, I can't go back to the same tract and put a ring segment. But that's the nice thing about those allogenic segments, because they're allogenic and not plastic, they will not induce anterior stromal necrosis and ischemia, and they will not block the nutrients coming from the anterior chamber to the aqueous. So you can implant them as shallow as you want. Technically, 250 microns is the shallowest I've done. And then, as you can see here, implanted at 250 microns exactly above the tract of the previous Kera ring, then I could preserve the effect of this Kera ring. This was the topography before explantation. And that was the topography after exchange, and then ultimately implanting an allogenic segments 250 microns shallow. So basically on top of the previous track. A major improvement in vision and an improvement in CDVA from 2000 to 2020. Again, another experience is actually exchanging it in the same tunnel as previous segments. Now, those did not intrude, those extruded. And this is, we know this complication, it can happen in almost a perfect surgery, and that's acute anterior stromal necrosis. We have published in GRS our comparison between explanting alone versus exchanging with allogenic segments. And then what we found that exchanging with allogenic segments preserves that quality, while removing the segment can decrease the corneal topography. So you can see, and as an example here, this is a corneal an index that has melted and was removed. And then what you can see is an epithelial downgrowth all the way to the floor of that previous segment. Now, on the other hand, you can see that the other eye of the same patient also melted, but instead of removing the segment, we just exchange it with a CARES. And as you can see with the CARES, as you can see here, you can still see a certain herniation of the tissue that into the melt that with time goes and integrates with the cornea. So instead of having a real deep tunnel of epithelium and a weak cornea, because the cornea is now basically has lost all its tectonic effect all the way to the base of the tunnel. Now we can see we have CARES and we have corneal remodeling instead. And if we can compare the two eyes, the first eye where we explanted, we can see that there is a loss of the corneal topography quality. This is pre-op and this is post-op, post-melt and removal. While in the other eye where we exchanged with the CARES, we can see this is pre-melt and that's post-exchange, and the central corneal topography has kept its quality and regularization. Again, sometimes you can use a CARES to supplement the effect of a previous corneal ring. This is a previous PMMA ring segment. It actually improved the cornea a little bit. It made it central, but it did not improve much the astigmatism. And still, this cornea is even steeper than before. So in that patient, we have to use everything we can. Instead of removing that PMMA ring, we kept it. But instead, what we did is implanting a CARES right adjacent to the previous corneal ring, as you can see here, at an optical zone of 5 millimeter. And that's nice about these rings. They're allogenic. They don't produce halos and glare like the PMMA segments, because they have the same index of refraction and they melt into the cornea perfectly well. And this is the topography. This is huge. That patient is seeing nothing. He was going for dark. And as you can see, we have hugely improved his corneal tomography. The CDVA improved from 2400 to 2030 with this cornea. That's really amazing for these patients to have to escape dark. And as you can see, this is the cornea, much better in terms of total regularization. As you can see here, this is the PMMA segment, and these are these corneas. And if you can see how they are squished, they get to almost similar sizes to the PMMA. This is Intex SK450, and this is the cornea from 750 after being squished. And as you can see here, the effect is better because they are implanted at 250 microns. So the effect at 250 microns is much better. Again, 250 microns get squished, compressed 30%, and you get 160 and 187, while the 400 here gets squished to 255. So for me, this was great, but I wanted to improve the procedure further, make it more customizable and more accurate, because when you punch with this 3-point, you're not sure if you're punching 750 or whatever, depending on the cornea thickness. And what I did is I teamed with Zemo to produce a software that would basically cut, basically cut the cornea exactly as we wanted. So as you can see here, this is a software that is not yet available commercially, but will be available soon. We can use OCT to know exactly the thickness of the cornea and decide about the depth we're going to cut. and we go ahead and perform that cut accordingly, we can cut multiple rings in the same cornea. This is an anterior chamber, an artificial anterior chamber. And as you can see, it's so easy to pee those segments. You can even put them in Optizol, you can store them, you can keep them on the same cornea. And as you can see here, they look really nice. And this is a PMMA as opposed to these allogenic segments. They integrate perfectly well. This is just fresh from the surgery and on the sit lab. And as you can see, the cut is nice. Even on OCT, they are much better than any other segments you can see. And finally, we have endless possibility, like cutting asymmetrical rings, and we've done it a lot. This is an example of an asymmetrical segment for a duct type phenotype. So as you can see here, we have one segment 500 that gets squished to 260, the other segment 750 gets squished to 423. And as you can see, this is a duct type phenotype where you can have a great improvement because we have a thicker segment inferiorly. Same thing for the other eyes, thicker segment inferiorly can improve topography and regularize it much better. So in conclusions and my actual thought about this technology, I think this is a breakthrough in terms of safety and efficacy, and it gives us more therapeutic options because we can exchange melted ring, we can implant them at the more shallow depth. We have so much to do with these segments. We can customize them. We can, especially using femto technology, no need for inventory, because otherwise with the PMMA, we have a huge inventory to be aware of. They're precise and reproducible, but definitely the challenge now is to make them more accessible to everybody and work on nomogram to standardize them just like the PMMA segments. Thank you.
Thank you very much, Professor Shadi, for the very interesting presentation and covering this hot topic. Now, because Dr. Shadi is going to leave within 5 minutes, if any question from the audience, we can take now for Dr. Shadi.
Can I ask a question?
Yes, please, Dr. Ahmed.
Hi, Ahmed. How are you? How's it going? Good to see you.
Okay. So do you implant cares all the time at 250 microns?
That's an excellent question. Actually, when I can, yes, because their effect is great at 250. There are sometimes cases where I don't for several reasons. One is being if I want to have less effect. So sometimes a patient who is older, who I'm afraid to go into a hyperopic shift. So I have the option sometimes to cut a thinner segment or of cutting the same segment and implant them a little bit deeper, let's say at 300 or 270. It actually gives you a more leeway. The problem, again, as I said, is that we don't have nomogram. I go by experience. I know that 750 and 500 is a major jump because now I have the tree find. But with the software that I'm using with Zimmer, I can really go with the segment I want. So there are so much possibility, and we don't have yet nomograms for that, but yes. And the second reason I would implant a bit shallower is when I look at the tomography. I have the MS-39 and I see thin epithelium to start with for many reasons, sometimes post-basic ectasia and other things, or sometimes dryness. So at 250, as you can see, the allogenic segment is going to take space, and the epithelium on top of that segment is going to become very thin. So a 250 sometimes induces a very thin epithelium over it, sometimes of 30 micron, and that's not really good. I had to wait a lot for that epithelium to thicken, and sometimes the patient get erosions over it. So that's one of the reasons where I would go even sometimes deeper. So typically I go from 250 to 300, but I never go beyond 300 because the effect of that ring significantly decreases.
Yeah, and I have another question that you already answered, that there is no special nomogram so far for the cares. So do you plan to have a special nomogram regarding the thickness, regarding the depth, and in relation to the care readings?
Yeah, that's excellent. Actually, what we did, there are no special nomogram because we have so many options. I'm going to tell you what, even the tunnel, we started with 1,000, then 900, then 800, and lately I've used 700. And I squished that ring in a 700 and I got more better effect because those rings, again, are malleable. So with 700, they get thicker. So you have so many options. But an easy trick, we just submitted our results to the AGO right now. And we showed that an easy trick, we are, by the way, working on a nomogram. We have it already. But again, the nomogram keeps increasing the more you want to play with it. But if somebody is used to perform Intacs or Kera ring or Ferrari ring, they can use the same nomogram the same concept, but just improve the results by 30%, which means we have that in AJO. What I can share it, we have submitted our data to AJO. So basically, if you have a 750 segment, if somebody is not using the femto technique yet, and they're using the Susan Jacobs Trifine, which cuts 750 and 500, a 750 gives you the result of a 450 SK, a 500 SK segment, but 30% more. Then if you implant it at 300 micron, it gives the results of a 450 SK segment, but 30% more. If you go to the 500 segment, it will give you the same effect as the 400 segment, but 30% more. And if you go at 500 but deeper, like 300 micron, it will give you the same effect of a 350 segment, but 30% more. It was interesting by the 30%, but when I did a small mathematical calculation, usually the most of those segments get squished 30%. 30 is an interesting number. It can be 35 or 28 depending. But if you notice, even with intacts or Kera rings, when you implant them at 400, the tissue on top of them gets squished about 30 to 35%. So for 400, if you measure with OCT, you will notice that it is 250. One of the slides, I had that as well. So if you implant at 250, the tissue gets squished on top of it at about 170 to 185, and that's 30%. And a 750 segment will be squished to about roughly 450. So that's again a 30% change. So if you think of a 450, just like a 450 intacts, but the other is implanted at 400, while the first one is implanted at 250, and you do the mathematical calculation, that's 30% more power because the epithelium is going to remodel 30% more. The stromal elevation is going to decrease 30% more. So by using this rule of thumb, you don't have to worry a lot about a nomogram. You can just use your regular ring nomogram. Think about that; it will give you 30% more and play around.
Okay. Thank you.
Time is running. Time is running. Thank you very much. Any question from the audience?
Thank you, Shadi.
Thank you.
If no question, we can move to the second
lecture. Next.
Second
Thank you.
presentation. Okay.
Thank you so much.
Thank you, Dr. Shadi. Thank you. Take care.
Thank you. Bye-bye.
Please, Dr. Ahmed Assaf, start your presentation to gain time. Thank you.
Now you can see my screen.
Yes.
Okay, thank you. Good morning everybody. بشكر طبعا الجمعية اليمنية للدعوة، بشكر الدكتور مازن سنجاب لدعوته للمشاركة في جلسة المياكو. I will talk about the cataract surgery with Fuchs endothelial corneal dystrophy. I don't have any financial interest in any of the subjects mentioned in this presentation. So as you know, Fuchs corneal endothelial dystrophy is a bilateral endothelial disorder characterized by cornea gattata presence on the back surface of the cornea and cause progressive loss of vision, leading to corneal edema, glare, and halos, as you know, and reduced visual acuity. Maybe it's sporadic, or sometimes it's autosomal dominant, and the risk factors for Fuchs endothelial dystrophy is the age, about 50 years old, female patients, thinner corneas, and sometimes smoking. And cataract surgery with cornea gattata is a special entity. If we can examine the cornea and we found that there is corneal edema together with the cataract surgery, so we have to go for triple procedure, straightforward cataract surgery and IOL implantation. But the issue, if we don't have corneal edema at the time of the cataract surgery, so if there is cataract surgery without edema, so we have to ask ourselves, would the vision improve after the cataract surgery alone? Or maybe the visual symptoms maybe increase after cataract surgery because of the corneal compromises, or maybe phacoemulsification can deteriorate further the endothelial status of the cornea. So this is the main issue, or this is the main focus of my talk today. So how to predict the cornea at risk before cataract surgery? So there are many factors we can rely on. However, there is no single parameters that we can rely on for predicting the cornea status before and after cataract surgery. For example, we can go for specular microscopy, or we can go for corneal thickness, central corneal thickness. It reflects the corneal function, the endothelial corneal functions. Maybe it's better than the specular microscopy because it estimates the function rather than the morphology of the corneal endothelium. However, Because of the large diurnal variation with the central cornea thickness up to 40 microns, and there is again large variation, especially with the ultrasound pachymetry, because of the difference in the operator, difference in the location of the measurement of the cornea. There is no direct or there is no solid cut of before and after or below and above that we can decide if we have to go for triple procedure or no. So there are different cutoff values, range from 630 microns to 650 microns. So it's not recommended as a sole agent or the sole parameters to rely on decision making before cataract surgery. Again, we have the corneal Scheimpflug image. We have the corneal densitometry that measure the corneal haziness and the backscattering of the cornea. And it's again, if there is a large backscattering, as you can see, the number is increasing, especially the area of interest is the central area from 0 to 2 microns, 2 millimeters. But it's poorly predictive for the corneal endothelium function. It measures in scale, grayscale units, and these units are not standardized, so you cannot compare between different machines together, and it's very much dependable on the device and the illumination during measurements. We can again rely sometimes on corneal tomography maps. For example, with the 4 refractive maps, you can see some of the loss of the regular isotopes on the corneal thickness maps. As you can see, this is the normal corneal thickness map, but again, sometimes if there is loss of the endothelial function, you can see here, there is the irregularities of the iso patches here. There is something pushed the central location of the cornea, nasal displacement toward the nasal side, and on the elevation, you can see sometimes focal depression on the back elevation map. And this focal depression means that there is a focal increase in the corneal thickness. So here we can look for the Scheimpflug image to look for the loss of the iso patches and the focal depression on the back elevation map. And again, we can look for the relative pachymetry map, again for the pentacam, which measures the central corneal thickness or the pachymetry in relation to the normal values. And if there is enlargement or there is increase in the corneal thickness up to 3%, there is something that needs some attention. It's not necessarily means that there is corneal edema, but at least you should take care about this cornea or predict that this cornea might be compromised during cataract surgery. So how to predict cornea at risk? There is no single scoring system to have a reliable measurement for risk factors. So advanced corneal imaging together with the clinical examination may be the best way to predict the cornea at risk. So we can rely on relative pachymetry maps on the Scheimpflug image. And the corneal backscattering, again, it's not standardized, but you can get an idea about the cornea status. And the most important is the 4 refractive map of the Scheimpflug image. Look for the iso patches and look for the focal depression on the back elevation map. Again, we have to look for the surgical technique, because there are some surgical tips trying to reduce the endothelial cell loss. We use the soft shell technique. Incision size and location, we might go for scleral incision, not necessarily to be corneal incision for the phacoemulsification. Of course, we have to modulate our power or the ultrasound power during phacoemulsification. We have to control the fluidics inside the anterior chamber, and we can rely on some of the mechanical disassemblies technique like the phacochop and MyLoop to trying to mechanically disassemble or divide the nucleus to reduce the ultrasound energy inside the eye. We can, of course, go for femtosecond assisted laser cataract surgery. And of course, we don't have to inject too much intracameral antibiotics. As you can see, this is the soft shell technique. This is a case of cornea guttata with corneal endothelium less than 1,000 cells per square millimeter. And it's a kind of dense cataract, as you can see, because of this ring with the refractive index of the lens. It's different from the refractive index of the central part of the nucleus. And this is the dispersive OVD followed by cohesive OVD to protect the corneal endothelium. I like to use the dispersive OVD that contains chondroitin sulfate because its negatively charged molecules stick on the back surface of the cornea and protect the cornea during phacoemulsification. Again, we can rely on some of the mechanical disassemblies like the phaco chop technique. As you can see here, this is a kind of vertical chopping with less ultrasound. Minimal ultrasound is used while chopping the cornea before moving forward for a new quadrant removal phase. So here, this is another strategy to reduce the ultrasound energy inside the eye and minimize the hazards of the ultrasound on the back surface of the cornea or the corneal endothelium. Again, this is a MyLoop device of Zeiss. I don't have any financial interest. This is an nitinol filament that can expand. We can expand. This is a handheld device. And we can expand this filament to accommodate the whole lens after doing the rhexis. And then we can snare this lens with this nitinol filament, and retracting the filament will cut the lens into two halves. So as you can see, while retracting the lever of this handheld device, of course, I have to support the nucleus with my secondary instrument. And you can see here the lens has been completely divided into two halves. Then we can repeat the maneuver once again to divide the nucleus into 4 quadrants. So we can just divide the nucleus into 2 halves, or if you want to divide the nucleus further into 2 quadrants, you have to rotate the nucleus for around 90 degrees, and then you can repeat the maneuver again. As you can see here, this filament is surrounding the lens, the whole lens, and then with retraction with the lever, you can see that the lens has been divided and there is no ultrasound. I didn't activate the ultrasound so far. There is 0 ultrasound. The CDE is still 0. And you can see here the beauty of this device that it can divide the nucleus into 4 quadrants, 4 complete separate quadrants without the ultrasound energy. Here, this is 1 quadrant. This is the half. This is another quadrant, as you can see, complete division because it snared the nucleus and divided the nucleus from the periphery toward the center. In comparison to the femtosecond laser, of course, we can, if you have the access to the fancy technology like the femtosecond laser technology, we can go for the femtosecond laser technology. However, according to our published data, the femtosecond laser technology can reduce the effective phaco time only in nuclear 3 and 4 cataract, but is not as effective as the MyLoop or the phaco chop for the nuclear 4+ cataracts. So if we have a case of nuclear 3 and 4, of course, femtosecond laser may carry some advantage, but not for harder or brunescent cataracts. Of course, there are some post-operative considerations like hypertonic solutions. We can use the topical hypertonic solutions, and we can consider cornea transplant at least 3 months after cataract surgery if the best corrected visual acuity is less than 0.5 on decimal scale, or the patient is complaining of blurred vision and troubling focusing, or worse vision in the morning, starbursts and halos at night, or there is subjective impairment, general subjective impairment of vision interfering with the daily routine activities of the patient. We have to keep in mind that this can produce hyperopic shift and should be considered during biometry before cataract surgery if the cornea transplant is likely to consider. And as I mentioned before, we should at least wait 3 months after the cataract surgery to decide if we have to move forward for the cornea transplant or not. So my take-home message, there is no single parameters to predict the cornea at risk before cataract surgery, but because of the advances in the cataract surgery, majority of the patients with the corneal gattata can benefit from cataract surgery alone, and most probably may not require a cornea transplant. And it's reasonable to start with cataract surgery in most of the cases and give the chance for the patient at least for 3 months before deciding to go for cornea transplant. Thank you very much for your attention.
Thank you, Dr. Ahmed, for the nice presentation. I have 2 questions before we take questions from the audience as well. The first one, do you think that corneal thickening is related to failure of the bump of the endothelium and therefore swelling due to fluid accumulation, or because of increase of the percentage of the matrix not fluid. Why I'm asking this question? Because if we measure the biomechanics of the cornea with good data, we will find it very comparable to keratoconus, although it is thick cornea. And we know that when the matrix percentage in relation with the collagen percentage, the matrix is higher, then the biomechanics are less. So do you think it is fluid or matrix?
I think it's both, because failure of the pump and the loss of the corneal hysteresis or the matrix of the cornea, abdominal matrix of the cornea, that allows some accumulation of the fluid inside the corneal stroma. And that's why we cannot rely on the CCT most of the time only as a sole agent, because of the, as you mentioned, thank you for this question, by the way, because you know that this is the only parameter that can predict the corneal endothelial function, because as you mentioned, because of the matrix, it allows accumulation of more fluid in the corneal stroma. So again, maybe we have a normal or near normal corneal endothelium, but still there is some abnormal accumulation of the fluid inside the corneal matrix. So again, I believe both factors are together.
Now, the second question is related to this. So do you think that using NaCl 5% before the operation may help reducing the thickness of the cornea and prevent, or at least reduce the risk of compromised cornea after the operation?
To be honest, I didn't try this strategy, but maybe I can try it, and I will tell you if you have any benefits of using this hypertonic saline solution before cataract surgery. I didn't try this.
So, great. I would like to ask Dr. Nancy for this. This
I answer this second question, Dr. Mazen. I do not advise using an ACL before the procedure, especially if it was preserved. Now there is a new version of unpreserved NaCl that we can use, and the reason is that the preservative will break the epithelium, and this will worsen the case after surgery. So instead of having only a diseased endothelium with a failure of a pump function that will invite fluid into the stroma, you will have also disintegration of the desmosomal attachments on the epithelium, and this will make things even worse. So I do not advise it unless you have an unpreserved NaCl. And the second thing I want to add to Dr. Assaf's excellent presentation, thank you, Ahmed, is that one tip or trick that I use at the end of a procedure that for a patient who has either a hard cataract that I used a lot of phaco power during the procedure, or a patient with a compromised endothelium, is to add an air bubble at the end of the procedure. And the reason is that the air bubble tamponades the corneal endothelium so that it gives some time for the endothelial function to recover from the stress of the surgery until let's say next day or 2 days after surgery, and it does not allow the fluid from the aqueous entering the stroma because the endothelium has been already compromised. So you save yourself some time. You have a clear cornea next day with an air bubble tamponading and touching the endothelium and preventing causing a barrier between the aqueous and the cornea, so no fluid influx would happen, and this will make you and the patient very happy next day.
Thank you, Dr. Nancy. And now I would like to go back to the second question, because of course, there are few cases of good data that we face, but I usually do this. I give ointment of NaCl 5% 1 week in advance and 1 week after drops. Okay, I don't use ointment after the operation. Everything goes beautiful, and I do the measurement of the IOL after using the ointment, because reducing the thickness, the K readings, all of that will make more accuracy in the IOL. And I have never seen any epithelial problem using this. Maybe I didn't pay attention whether it was preservative free or not, but maybe because it was preservative free. So thank you very much. We can move now to Dr. Nancy's presentation, and maybe if we have 5 minutes at the end, we can have some questions from the audience.
Okay, good morning, and thank you for شكرا للجمعية اليمنية لأطباء العيون دكتور محفوظ بامشموس for this invitation, and Dr. Mazen Sinjab for allowing me to participate within the MIACO session. My talk will be about limbal stem cell transplantation and stem cell deficiency, and what are the options for surface reconstruction. So if you see this first slide, what is in common between all these eyes is that the loss of the integrity and the clarity of the cornea, the vascularization, the loss of the integrity and the relationship between the eyelid and the cornea, the keratinization, and the severe dryness of the anterior surface of the cornea. Now, we all know that the limbus is important because it is a reservoir of cells, epithelial cells, and it repopulates the lost surface cells, and also it acts as a barrier to the encroaching cells from the vicinity and the periphery of the cornea. Now, we have lots of causes for limbal stem cell deficiency. Autoimmune, in most cases, such as Stevens-Johnson syndrome, ocular psychiatrical pemphigoid, in the young, usually is traumatic due to chemical injury, thermal injury, sometimes chronic contact lens wear, if it is with a poor fit, can cause ischemia and limbal stem cell deficiency. Sometimes if it's iatrogenic, in cases of cryotherapy, multiple surgeries. Sometimes it's infection cause, especially herpetic keratitis or extensive corneal and ocular surface infection. In congenital aniridia, also we have an element of stem cell deficiency, and sometimes if we have a neoplastic or a limbal tumor that occupies a large equator of the cornea. Now, regardless of the cause of the limbal stem cell deficiency, when do we suspect it? And usually we suspect limbal stem cell deficiency when we have a dull and irregular reflex from the conjunctivalized corneal surface. Usually the picture is described as a classic waterfall or whorled epithelium along with the loss of the limbal palisades of Vogt. We have a stippled pattern with the conjunctival epithelium has encroached on the corneal surface, recurrent erosions that can lead to persistent epithelial defects, corneal ulceration that does not heal, and sometimes in severe cases it leads to perforation. And in advanced limbal stem cell deficiency, we might get fibrovascular pannus and corneal scarring might predominate. Now, this is how the waterfall effect looks like. That comes usually from the superior part of the cornea, or from 3 and 9 o'clock. You don't see the waterfall effect from the inferior part, and also always it starts superiorly. And if you see this or suspect it, what do you do? It's very important that you have the suspicion. So if you are in doubt, this happens in cases of non-healing ulcer after a procedure. Sometimes you know the reason, you don't have to question it, such as in cases of chemical injury or congenital aniridia. And it's important to differentiate whether it is unilateral or bilateral. But if you are in doubt and you want to justify a procedure to a patient, you can still confirm it. And how we confirm limbal stem cell deficiency is by impression cytology. And it can be taken with a very simple procedure, cellophane tape that you can take from the limbus, and you put it on a special slide and send it to the laboratory, and you ask them to look for goblet cells. Now, the presence of the goblet cells on the cornea confirms of diagnosis of stem cell deficiency, because usually this is because of the encroaching of the conjunctivalization or conjunctivalized epithelium on the cornea, because the cornea usually does not have any goblet cells. Now, we have the suspicion and we have confirmed that this is limbal stem cell deficiency. What are your options? We can divide this into two sections. Either you go conservatively or you go to surgical intervention. So conservative, we mean wait and see and use some garments to help with the chemical injury. We can use steroids also in cases of inflammation, in cases of autoimmune problems such as Stevens-Johnson syndrome and OCP. We can use steroids. Lubricants is very important to compensate for the loss of mucus and the dryness of the surface. Autologous serum sometimes is used with care in order to boost the anterior part of the eye to regenerate itself. Vitamin C also is an immune booster, cyclosporin, to depress the surface immune reaction in cases of autoimmune diseases. Doxycycline can be used to strengthen the cornea, and in cases of vascularization, we can use anti-VEGF such as Avastin. Now, amniotic membrane or Percera, which is amniotic membrane lens, is also a conservative method of trying to boost and strengthen the defenses of the anterior part of the cornea in order to regenerate itself. Now, the surgical option with amniotic membrane and keratectomy, or autologous limbal stem cell transplantation, or keratolimbal allograft, or simple limbal epithelial allograft, or keratoprosthesis, I will discuss it, and this is conserved for cases of severe limbal stem cell deficiency. I want to highlight the importance of amniotic membrane and how does it work. Now, amniotic membrane is a thick basement membrane that has an avascular matrix. It has no inflammatory response. So its importance is that if you want to suppress inflammation and decrease the possibility of scarring on the cornea, use the amniotic membrane. The amniotic membrane has no cells at all, unlike the usual consideration or thought. So we keep the scarring at bay, and it supplies growth factors for the progenitor cells, whether they are present in the epithelial palisades of Vogt or you are transplanting corneal tissue. So it gives a longer lifespan to the cells. It allows better differentiation if we have progenitor cells from elsewhere, and it allows a scaffold for epithelialization. It acts a contact lens, but with endothelial-rich growth factors and nutrients that helps epithelialization of whatever cells you're using. Now, let me describe the procedure of autologous limbal stem cell transplantation. Usually we take it, this is in cases of unilateral deficiency, we take it from the contralateral eye, and usually we do not take more than 4 clock hours, and it is taken as 2 clock hours superiorly and 2 clock hours inferiorly. You don't take adjacent 4 hours because this will jeopardize the health of the limbus, and you take them, you undermine, and you just take it and either glue it to the other eye, or you stitch it with 10-0 nylon in order to stay as long as possible. And you can, after that, put an amniotic membrane on top of it. You can also use an amniotic membrane below it and then cover it as a sandwich technique on top, or you can add multiple layers of amniotic membrane on top of it, and this will just give it more time to settle down and start functioning again. Now, if we have a bilateral stem cell deficiency and we don't have any autologous limbal stem cells, and I want to highlight that in the case of taking limbal stem cells from the other eye, we don't need any immune suppressants to be used. Now, when we have a cadaveric corneal donor, we can use the limbal stem cells from the cadaveric donor, and we can use it in two ways. Either a keratolimbal allograft, and this means that the sclera and the limbus can be used as a ring around the cornea. The only disadvantage of this procedure that I don't like is that the cosmetic appearance on the sclera that acts as a white ring around the cornea, that might be not very favorable, but the function would be excellent. And the other option is that you take a strip of the limbal epithelium and you just slice it into small segments, and you just sprinkle it on the cornea in small parts, exactly like in this photo. You can see that the first one shows a vascularized cornea with a loss of structure, and then superficial keratectomy was done to expose the surface of the cornea and remove as much of conjunctiva as possible. And then a few parts, you can see the 8 or 10 parts of the limbal stem cells are sprinkled on the cornea. Usually you put it around the periphery, and you put amniotic membrane on top of it, and you start waiting for the results. It might take up to 6 to 8 weeks to clear, and if the cells have enough reservoir of epithelial cells, you will see an amazing result of clarity of the cornea. And now it's very important to put the patient on or immune suppressants such as restasis, cyclosporine, sometimes orally, and it depends on the severity. Sometimes you can use oral neural or cyclosporine to suppress the immunity. And this is how we also use the limbal stem cells. We can use it with a normal cornea or even with an artificial corneal to protect the integrity of the epithelium. Now, the last thing I want to talk about is the gray zone. So how far would you go with surface reconstruction using stem cells with corneal transplantation? So you would rehabilitate the surface and give the patient 1 and 2 times of corneal transplantation, but still, despite all the methods that you have used, all the efforts, then the cornea still is rejected and the vascularization ensues and the clarity is not maintained. So what would you do? And here where keratoprosthesis can be a game changer. The keratoprosthesis is used when needed, and what we mean with needed is desperate cases, multiple comorbidities to bypass the ocular surface and corneal and the cornea. But we have to remember that the complications must be addressed much more common than in the usual transplantation. Expectations should be explained to the patient, and compliance should be promised from the patient side, and commitment applied to both the doctor and the patient, because it's not a one-day procedure. It's a lifetime commitment between the patient and the doctor. So what kind of keratoprosthesis we have? We have 2 kinds of K-pros that are doing amazing results in patients with limbal stem cell transplantation. The first one is the Boston keratoprosthesis, which has the highest rate of retention. And this is used if you have a wet blinking eye. So if you have a wet blinking eye with a good surface reconstruction, the fornix is preserved, you have a good wetting, and the conjunctiva works almost well in a patient, you can do the Boston keratoprosthesis with excellent retention rates and function. Or in the case of severe keratinized dry eye and what we call a dry non-blinking eye. So if you have a dry non-blinking eye, no artificial cornea can withstand the hostile environment except the osteodontokeratoprosthesis that we can take from the root of the canine in a procedure that consuming for both the patient and the surgeon, but it gives excellent results if the posterior pole is intact and healthy. And it has a retention rate it's the longest lasting keratoprosthesis with a retention rate of up to 85% for 15 years and very good vision. Now, just one message I want to say: in limbal stem cell failure, you have to understand that your patient is different. You have to give extra effort. You have to go the extra mile. Perseverance is needed from both. Complications are expected. Sometimes there are multiple disappointments. There are good and bad days. And at the end, it's very important to know that you have done your best. And thank you very much.
Thank you very much, Dr. Nancy. Great presentation as usual. Let's have questions from the audience, please.
أي حد يسأل يا
For both Dr. Nancy or Dr. Ahmed, please, any question. Dr. Ahmed, do you want to comment on Nancy's presentation? Any remark, or I mean, discussion?
Maybe I want to ask Dr. Ahmed before he asks me.
Unmute, Ahmed. We cannot hear you.
It's excellent presentation as usual. I have only one comment that I like the idea of odontokeratoprosthesis, but I wonder how is it feasible in our area? I know that you have done several cases, but I don't know if it's feasible in our area to do this kind of prosthesis for our patients.
Yes, it is feasible. In terms of, you mean, it is a procedure that uses the patient's own body to create a cornea. So just with the proper kind of training, the only thing it is time consuming. It takes like 6 to 8 hours for the first stage to fashion a cornea. You need a maxillofacial surgeon to take the bone Sometimes we take the bone from a living related donor, like the son of a patient, if he does not have good, healthy teeth. And this procedure takes like 8 hours of fashioning a lamina. And we use an optic, and this optic has a power that we implant in the cornea, and it acts like a lens with a power. Because when you do the actual procedure, which is like 2 or 3 months apart, we bury the lamina under the skin to take some soft tissue, and we take it out after 3 months and implant it in the eye. Now, when we want to implant it in the eye, it's also a very long procedure that we decompartmentalize the whole anterior chamber. So there's no more cornea, no more conjunctiva. We just remove everything on the surface, and we put instead of it a buccal mucous membrane. There's يعني في شوية صعوبة إنه to find anatomical limbus in order to implant the tooth there. You know, a bulky bone with all of the stitches putting in place. You need like 4 hands with you in the surgery to hold all this together to centralize the optic. But once all this is done, it gives amazing results actually, because as I said, you just overcome all the barriers. The thing is that you need a healthy patient to withstand the anesthesia that long, and actually, we couldn't do more than 1 a month because it's very consuming in terms of the operative time, all the instrumentation that's used during this 8-hour procedure. But it is just feasible if you have a patient who understands the risks and the benefits. Usually, these live with a bonus days in their lives. They are kept in the dark for several years, and this opens hopes for them to see.
Okay, one more question. How do you assess the procedure segment for those patients before going for cataracts, for these kind of surgeries?
Actually, excellent question. Is very, very difficult because we rely on history. Patients who have diabetes are, especially if it's not controlled, we expect complications or problems. We aim at the patients who have good medical history, let's say, regarding diabetes, hypertension, but they have a problem with the anterior segment. So the patients who do best are those with chemical injury, that we are almost sure that the posterior segment is good. Or patients who have like OCP and autoimmune disease, like Stevens-Johnson syndrome, these do excellent because they do badly with the Boston keratoprosthesis. They have very severe keratinized surface. They do excellent. And we have the patient who had, he's 85, who had 6/9 vision just second day after surgery. And because we're almost sure that he had a good posterior segment. I explain always to the patient that it is there's a risk of no improvement of vision if the posterior segment was bad. We rely on good projection of light in 4 quadrants. This gives us an idea about the optic disc, and also we do sometimes EEG, ERG, or VAP studies to just assist the electricity, nothing else.
Okay, thank you.
Thank you.
Thank you very much.
Do we have time to ask Dr. Ahmed about his presentation?
Let me first ask Dr. Tariq and Dr. Mahfouz. Do we still have 5 minutes more, or we have to finalize?
Yes, still have 5 minutes. Yes.
Okay, thank you. Go on, Dr. Nancy, please.
Yeah, Dr. Ahmed, I wanted to ask you about the IOL power choice in patients with let's say Fuchs dystrophy or corneal edema. So how do you aim at the IOL power? We all know that if you expect to transplant the cornea, that we have hyperopic shift. So what is your plan for the IOL power when you implant it?
Most of the cases we can escape with most of the cases with only cataract surgery. So if I predict that the patient will do well with cataract surgery without corneal transplant, I will aim for emmetropia or slightly myopia, maybe 0.5 diopters of myopia. But most likely, if the patient is going to do corneal transplant later on, maybe 1 or 2, 3 months after the surgery, so I will aim for slight hyperopia. That's it. 0.5.
Again, Dr. Ahmed, if you plan for keratoplasty later, you plan for hypermetropia?
No, sorry. I plan for myopia. I'm sorry.
You expect hypermetropia, okay?
Yeah.
Okay, plan for myopia. I'm sorry for this. But for cases
Actually, it
that
depends.
is just for cataract surgery, I'm planning for emetropia or 0.5 diopters of myopia only.
Yeah.
Yeah,
Okay,
my
so
comment is that if you expect to do, if you expect it to do very well, as you said, we do emetropia, and it depends on the kind of surgery that might be offered to the patient after the procedure. So if it's DSEC, usually I advise planning 1.5 actually diopter of myopia. If it is ultra-thin DSEC, you can go for 0.5. If it's a DMEC, that you know the patient will go a DMEC, you don't have to do anything. It's just going with emetropia is a good choice. So it depends on what kind of surgery you expect the patient to undergo after a while. And if he doesn't go any surgery, that would be فضل ونعمة يعني.
To be honest, I usually tell to my patient that myopia is not bad. So if we end up with slight myopia, even if I expect that this patient is going to do a triple procedure or maybe cataract transplant after the cataract surgery, and the patient did not do this kind of surgery, and I was aiming for myopia after, at the time of biometry, and it ends up with only cataract surgery without cornea transplant, and the patient is myopic. Before the cataract surgery, I used to counsel the patient, tell them that the myopia is not a bad thing. Myopia is good, at least for near work, which is most of the time in our everyday life. So I try to counsel the patient, give the patient the expectations, bring the expectations of the patient down to the ground. Myopia is nice. There is definitely will be spectacles for distance and near for the patient. Only standard IOLs. There is no way to talk about the fancy IOLs like the toric lenses or the multifocal or EDOF lenses, because we are not going to predict how is the visual performance of these lenses in the status of your cornea. So just standard cataract surgery, slight myopic shift is not a bad thing, even if I'm targeting 0.5 and ends up with 0.1 with -1 or -1.5. If the patient ends up with slight myopia, is not bad. At least he can or she can read without glass.
Absolutely.
Okay, super. Thank you very much, Dr. Ahmed. Thank you very much, Dr. Nancy. And of course, great thanks to the Yemen Society of Ophthalmology for this opportunity. And we hope in the future we can present physically in Yemen to see our colleagues there. Have a great day. Wassalamu alaikum wa rahmatullahi wa barakatuh. I'm sorry, if still any questions from the audience, we are open. We have time, but it's up to you.
خلاص نشكر جلسة المياكو، نشكر الأستاذ الدكتور مازن سنجاب، الأستاذ الدكتور أحمد عساف، أيضا الدكتورة الرائعة نانسي الرقاد. إن شاء الله لنا لقاء قريب حضوريا، وربنا يفتح عليكم. ألف شكر إن شاء الله. شكرا يا شباب.
يلا بأمان الله. مع السلامة.
شكرا جزيلا.
كان في بريك نصف ساعة وبعدين الجلسة الثانية إن شاء الله. دكتور عمرو الميسري، يا دكتور عمرو، يا دكتور صالح، الدكتور علي، كيف الحال؟
إيه. إيه. دكتوري وينام؟ ها؟ هذا شيء توصيلة التلفون.
انت بتسافر الحين؟ انت بتسافر؟ اصلا ما تتوقع. خلاص. يوم الأحد يعني. هذا كله يوم الأحد. خلاص.
إذا خلاص أنا محسن.
السلام عليكم. نبدأ الجلسة إن شاء الله. نحن متأخرين 5 دقائق يا شباب. نبدأ الجلسة إن شاء الله عشان صلاة الجمعة. طيب، بسم الله الرحمن الرحيم. Pediatric Ophthalmology and Uveitis Session. هنبدأ إن شاء الله مع محاضرة بروفيسور نهال الشقنقيري Pearls of Pediatric Cataract Surgery. بروفيسور نهال الشقنقيري Professor of Ophthalmology Alexandria University Egypt. and she's the head of Department of Pediatric Ophthalmology at Alexandria University Hospital, and she's dedicated for pediatric cataract surgery for over 30 years, and she is one of the most eminent pediatric cataract surgeons worldwide. دكتورة نهال معنا؟
أيوة دكتور عمرو, can you hear me?
أهلا وسهلا دكتورة نهال, شرفتينا ونورتينا.
شكرا.
أهلا وسهلا دكتورة, يعني باسم الجمعية اليمنية نتشرف بحضرتك وسعيدين جدا بوجود حضرتك معنا, وحضرتك إن شاء الله تبدأي التوبك. أهلا وسهلا.
شكرا جزيلا. I will share screen.
اتفضلي يا دكتورة.
Okay. Is it obvious دلوقتي دكتور عمرو? Can you see my screen?
أيوة دكتورة, اتفضلي, شايفينها.
بسم الله الرحمن الرحيم. Before I start, I would like to thank Dr. Amr for his kind invitation for me to participate in your meeting. And I'm going to speak about tips in congenital cataract surgery. If you go for cataract surgery with IOL implantation, the key of success in these cases, we have to follow these steps meticulously and carefully. For example, here, if this is a congenital cataract and we plan to implant intraocular lens, we have to go for exactly 5 millimeter anterior capsular axis, 4 millimeter posterior capsular axis combined with anterior vitrectomy and IOL implantation inside the capsular bag. To start with, anterior capsular axis. Why it should be exactly 5 millimeters? To cover the IOL optic circumferentially, because the IOL is 6 millimeter in size. If you go for a smaller anterior capsular axis, capsular phimosis will occur, necessitating secondary surgical intervention. How to perform anterior capsular axis? In cases of total cataract, we have to use trypan blue stain to stain the anterior capsule, and then we perform the anterior capsular axis to attain the 5 millimeter rexes. But sometimes we have a morphology of the cataract which you can follow, and it's a sort of a landmark for the anterior capsular axis. The majority of lamellar opacities are 5 millimeter in diameter. So you start by a tear in the anterior capsule, and then you go with the rexus forceps 25 gauge, and you follow the lamellar opacity. You go tangentially like that, following the lamellar opacity. If you do so, the anterior capsular axis will be exactly 5 millimeter. Here, this is another lamellar opacity. You follow the lamellar opacity like that, it will be at the end a 5 millimeter anterior capsular axis. But sometimes you can go for a little bit larger anterior capsular axis. It's not a problem. It will be at the edge of the IOL optic, but still it can do the work. But when you have a double lamellar opacity and the inside opacity is 4 millimeter, so it has to be outside the lamellar opacity, the anterior capsular axis. It should be outside. Why? To be ideal like that, covering the IOL at the conclusion of surgery. The second step is hydrodissection. You have to go for a very good hydrodissection to facilitate cortical cleanup and hydrodelineation. But take care in these cases. Look here to the morphology of the cataract. It delineates a defect. So in cases of congenital posterior capsule defect, you have to avoid hydrodissection and hydrodelineation. Polishing the back surface of the anterior capsule, you have to go for removal of the lens epithelial cell. Look here, this is polished and this part is not polished. You should have a crystal clear capsular bag. Why? Because if you don't polish, fibrosis of the anterior capsule will occur and will prevent good visualization of the retina if desired in the future. And sometimes years after surgery, despite having a beautiful surgery, but the anterior capsule was not polished. So the lens epithelial cells may grow from the back surface of the anterior capsule over the anterior surface of the lens. And sometimes, despite having here anterior and posterior rexes, lens epithelial cells may grow over the anterior surface of the IOL and posterior surface of the IOL, necessitating secondary surgical intervention to clear the visual axis. If we come to the posterior capsule rexes, leaving the posterior capsule intact in children will lead to 100% opacification of the posterior capsule. So there is no role to leave the posterior capsule intact. You have to go for a beautiful posterior capsule rexes. So when lens epithelial cells do occur, the visual axis will remain clear along the years. Sometimes YAG laser capsulotomy is not possible in children. It may lead to IOL pitting and sometimes IOL cracks, necessitating IOL exchange in the future. And sometimes children are not cooperative enough to sit for YAG laser capsulotomy. So you have to go again for secondary surgical intervention to aspirate the pearls and open the posterior capsule to have a clear visual axis, and here before and after secondary surgical intervention. So posterior capsule rexes is a must. The size of posterior capsule rexes should be exactly 4 millimeters. Why? Because if you go for a smaller posterior capsule rexes, capsular phimosis will occur. And here the surgeon tried to do YAG laser capsulotomy and he did an IOL pitting. But the solution here is that we have to go again, secondary surgery, to cut the phimotic capsule and eat it up with a cutter to clear the visual axis. And here at conclusion of surgery. And here before and after secondary surgical intervention. So we have to go for posterior capsule rexes. How to perform posterior capsule rexes? With the cystotome, you try to find the posterior capsule. You hook the posterior capsule. This is called hooking. And then you tent the posterior capsule, tenting, more tent, until you tear the posterior capsule into a triangular tear. And then through this triangular tear, you go with a viscoelastic. You don't dip into the anterior vitreous, just at the edge of posterior capsule rexes, and then you inject viscoelastic. You will see the viscoelastic inside the Berger space, which is a space between the posterior capsule and anterior vitreous face. Injection here, as you see, into the Berger space. And then you can perform the posterior capsule rexes easily, parallel to the edge of anterior capsule rexes, and it should be 4 millimeters. Anterior vitrectomy. Anterior vitrectomy is a must in pediatric cataract surgery. You go in first with a dry vitrectomy, and then you introduce the irrigation cannula to avoid overhydration of the vitreous. In these cases, you don't have to inject steroids intracameral. Why? Because you can see the vitreous. Look here, there is kinking of the posterior capsular axis, denoting that there is a sort of a vitreous strand going towards the wound. In these cases, you have to go again, dry vitrectomy, until you achieve a beautiful circular posterior capsular axis. You have to go beyond the edge of posterior capsular axis to perform anterior vitrectomy before IOL implantation inside the capsular bag. Why anterior capsular axis is important? Inadequate anterior vitrectomy, lens epithelial cells will grow over the surface of the anterior vitreous face. Can you see here? Despite having a posterior capsular axis, years after surgery, lens epithelial cells did grow over remnants of anterior vitreous face. And here, this is inadequate vitrectomy and extensive lens epithelial cells. Here again, this is inadequate vitrectomy in this area. And sometimes there is total occlusion of the visual axis despite having a posterior capsulorhexis. See, you can see here the edge of posterior capsulorhexis, and despite of this, due to inadequate vitrectomy, there is secondary cataract that we had to go again to clear the visual axis. But when you go for a very good anterior vitrectomy, lens epithelial cells, when they grow after surgery, years after surgery, they respect the edge of posterior capsulorhexis. See here, they totally respect the edge of posterior capsulorhexis. Even when they grow circumferentially, you're going to have a beautiful, clear visual axis. And here, more and more pearls years after surgery, respecting the edge of posterior capsulorhexis. And here, circumferentially with clear visual axis. And here again, can you see the pearls at the edge of posterior capsulorhexis? Extensive, but they don't go beyond the edge of posterior capsulorhexis. And even when we have a small posterior capsulorhexis, but with a good vitrectomy, you're going to achieve clear visual axis. Look here, this is an eye 10 years after surgery. The posterior capsulorhexis was small, but the anterior vitrectomy was perfect. So the lens epithelial cells, despite having a small posterior capsulorhexis, the visual axis remain clear. IOL implantation. You inject viscoelastic inside the capsular bag, and then you inject the IOL, either a single piece IOL inside the capsular bag between the anterior and posterior rhexis, or a multi-piece in hydrophobic acrylic lens inside the capsular bag. The key of success, or the pros, how to perform these cases. Take care of the lower haptic. The lower haptic should be injected just underneath the anterior capsule, and then the IOL will unfold with a Y-shaped spatula. You can push the IOL safely between the anterior and posterior rhexis. And here with magnification. Concerning the multi-piece IOL, look here to the lower haptic. Again, take care. It has to be exactly underneath the anterior capsule to avoid losing the IOL into the vitreous. And then inject. Leave the IOL to unfold. Secondly, you push the optic until this haptic optic junction is inside the bag. And then comes later the upper haptic. You take midway between the haptic optic junction and the haptic. By a Y-shaped cannula, you push forward, push until you attain here a beautiful IOL inside the capsular bag between the two rhexis. Here, this is an eye. We will see continuously all steps of surgery. You start by the side port with an MVR knife 20 gauge, the other side port, and then the main port with the keratome 3 millimeters. You go with tearing of the anterior capsule, and then with the rhexis forceps, go to the edge of the anterior to the lamellar opacity, follow the lamellar opacity, and then you go with, this is the beautiful 5 millimeter anterior rhexis, hydrodissection just underneath the anterior capsule. You will see viscoelastic coming outside the wound. And then you go with the hydrodissection, the hydrodelineation here. And very important step to go for a hydrodelineation. Irrigation aspiration is going to be very easy. Polishing the back surface of the anterior capsule, performing the posterior capsulorhexis by hooking, tenting, and tearing into a triangular tear, injection of viscoelastic into burger space, and you can see here the edge of the viscoelastic into the burger space, perform the posterior capsulorhexis 4 millimeter anterior vitrectomy. Take care to go for a very good anterior vitrectomy near the edge of the posterior capsulorhexis. Inject the IOL. Look here, the lower optic. Can you see here the edge of the anterior rhexis? Inject. It will be beautifully injected inside the capsular bag. Push it, the upper haptic, and you're going to have the IOL between the anterior and posterior rhexis. This is before and at conclusion of surgery. This is before and at conclusion of surgery. Again, this is a triple lamellar opacity before and at conclusion of surgery, either using a multi-piece or a single piece inside the capsular bag. And you can see here, years after surgery, with a multi-piece IOL, can you see the pearls coming outside here from the equator going towards the center? This is a single piece IOL years after surgery, pearls coming from the equator, here proceeding to the edge of the posterior capsular axis, again pearls, but respecting the edge, circumferential pearls. This is an eye 5 years after surgery, 5 years after surgery. This is a 5 years after surgery with extensive pearls, but with a beautiful clear visual axis. This is an eye 10 years after surgery. This is 10 years after surgery, extensive pearls, but with clear visual axis. Sometimes the pearls start to grow in colonies. One colony like that, but again, with clear visual axis, even the pearls when they are extensive. See here, these are years and years after surgery in two spots, but with clear visual axis, extending circumferentially, 3 spots, 4 spots, and here, this is again 10 years after surgery. And sometimes we see calcification of the pearls. And this is an eye 10 years after surgery. See here with magnification, but with clear visual axis. The pearls are extensively aggressive. So you have to be very meticulous and careful. And here an eye 20 years after surgery with extensive pearls, but with clear visual axis. And sometimes we see calcification of the capsular bag. And you see here, calcification of the sommering ring, 10 years and 20 years after surgery, but with clear visual axis. And this is a baby. 6 months after surgery, he had his IOL at the age of 6 months. And here, few months after surgery, the IOL between the anterior and posterior axis, and the same eye 20 years after surgery with calcification of the capsular bag. And here the child 20, he's no longer a child, this is my baby after 20 years, and attaining a clear visual axis and a straight eyes because the mother was very cooperative in amblyopia therapy. Sometimes we see fibrosis of the posterior capsule. This is 10 years after surgery, and fibrosis 20 years after surgery, but with beautiful clear visual axis. This is concerning IOL implantation for cases with congenital cataract without IOL implantation, as in these cases, and fitting the babies with aphakic spectacles. We have to go with different sizes of anterior axis. In these cases, the anterior capsular axis should be 6 millimeter, and the posterior capsular axis should be exactly 6 millimeter, combined with a very good anterior vitrectomy. Or in these cases, you can go for a 6 millimeter anterior axis and a 5 millimeter posterior capsular axis combined with anterior vitrectomy. Why? Because smaller axes, capsular phimosis will occur, and you're going to have to go again for secondary surgical intervention to cut the phimotic capsule and eat up the capsule to clear the visual axis. And why not larger than 6 millimeters? Because if you go for a larger posterior and anterior axis, capsular retraction will occur. So at time of secondary IOL implantation, can you see here? The capsular ring will retract. This is a retracted capsular ring. So the secondary IOL implantation will be difficult. And you can see here the haptic is implanted over a retracted capsular ring. And the capsular ring will be larger than the IOL optic. Why anterior vitrectomy? Because if you don't go for a very good vitrectomy, lens epithelial cells will grow over remnants of anterior vitreous face, obstructing the visual axis. And sometimes you're going to have to go for a secondary surgery to clear the visual axis. So in these cases, we have to go for 6 and 6 millimeter posterior axis combined with the anterior vitrectomy. In these cases, few months later, you're going to have, or few years, at the time of secondary IOL implantation, fibrosis of the capsular ring will occur, and you will have a 5 millimeter capsular ring. It will be ideal to inject the secondary IOL in the sulcus. And why in these cases also you have to polish the back surface of the anterior capsule before performing, you have to have a beautiful crystal clear capsular bag before performing the posterior capsulorhexis and anterior vitrectomy. Why? Because if you don't polish, you're going to have a very thick sommering ring at time of secondary IOL implantation. This will push the IOL optic forward, increasing the risk of secondary glaucoma after secondary IOL implantation. And sometimes this sommering ring is so thick like that at time of secondary IOL implantation, you have to open the sommering ring and aspirate the pearls and then cut the phimotic capsule and eat it up with a cutter to increase the diameter of the capsular ring before secondary IOL implantation. But when you polish, at time of secondary IOL implantation, you're going to have a beautiful thin capsular support to implant the IOL over it. And it's here after secondary IOL implantation. And sometimes when you polish, you're going to have a beautiful thin capsular support. After IOL implantation, you can push the IOL optic, performing optic capture technique. And here in eye, 5 years after optic capture technique, the IOL is beautifully well centered with a beautiful clear visual axis. And after surgery, we fit the babies with what is called aphakic spectacles, ultra-thin, high-definition glasses. And in older children, we fit them with a multifocal, ultra-thin, high-definition glasses before secondary IOL implantation. The ultra-thin, high-definition glasses, can you see here the difference? This is a 20 diopter lens, and this is a 20 diopter lens. See how thick here and here is beautifully thin. And this child was referred to us from outside Egypt. Look at her plus 20 glasses. Here, this is her plus 20 glasses, and here, this is the new plus 20 ultra-thin high-definition glasses. They have a beautiful advantage that you may reach even up to 20 or 22 in these infants. Can you see here? This is plus 23, and these babies can be fitted easily with these glasses, and they are not heavy, and they are thin, and they are ideal for these babies. For children with bilateral pseudophakia, we fit them with multifocal glasses with a near add of plus 3. And finally, to conclude, when dealing with congenital cataract, you have to be extensively meticulous and careful during surgery, as we said, following the rules to have a beautiful surgeries without complications. And thank you very much for your kind attention.
شكرا جزيلا دكتور نهال، شكرا جزيلا على المحاضرة الرائعة. ممكن نستقبل سؤال أو سؤالين بالكثير عشان الوقت بس.
Thank you very much, Dr. Nihal. Very valuable lecture. I have one question for you. I mean, if you have unilateral cataract in a baby, and you remove the cataract when you didn't implant IOL, so what is the other option you will do to help, to avoid amblyopia?
Okay, for example, if you have a baby 3 months old or 2 months old, you go for the cataract surgery, and then you fit the baby with ultra-thin, high-definition glasses unilateral. They are so beautiful. And you go for amblyopia therapy, half waking hours, from 4 to 6 hours, and until he reaches 6 months or 7 months of age, where you can implant a secondary IOL implantation. Because you cannot implant before the age of 6 months, because there is large myopic shift. The stabilization of the curvature of the cornea occurs at the 6th month of age, and the axial length, 80% of the eye growth occurs in the first 2 years of age. So before 6 months, there is no IOL implantation.
سؤال بس بالنسبة للانتيريور فيتريكتومي للأطفال، Are you going to use mannitol during surgery or before surgery, or we are not using the mannitol at all?
No, never. Never. If you follow the rules, as I told you, going first with the dry vitrectomy, and then you introduce the irrigation, aspiration, vitreous will not pop up to you. You have to go into and tackle the vitreous. If it goes into the anterior chamber, you have something wrong. Either you did overhydration, you don't have a very good anesthesia. You should have a good pediatric anesthesiologist at time of surgery to go for deep anesthesia, and you have to go for a muscle relaxant, which is safe, and you have to have a good antidote in order to inject it immediately after surgery. The baby will wake up in few minutes. So it's a sort of a teamwork. It's not only a surgeon. You have to go for, it's not only the talent of the surgeon, good instrumentation, good machines, and a good pediatric anesthesiologist.
Thank you so much, Dr. Nihal. Thank you so much for your lecture.
شكرا جزيلا. شكرا.
ننتقل للأوبتيكا الثانية في الأوار سيجن البيدياتريك IOL calculation and visual rehabilitation in pediatric cataract cases with Dr. عمرو الميسري. تفضل دكتور.
السلام عليكم ورحمة الله. المحاضرة تعتبر تكملة لمحاضرة الدكتورة نهال. هنتكلم شوية عن البيدياتريك IOL calculation والفيجوال rehabilitation post operative. هذا. So first IOL implantation pediatric cataract surgery. أنا عملتها على شكل سؤال وجواب بحيث تكون أسهل وأسرع إن شاء الله عشان الوقت. So most significant areas of debate in pediatric cataract surgery and IOL implantation decision. إيش أكثر الأشياء اللي في عليها debate والنقاط اللي فيها اختلاف عن الادلت cataract surgery. First, timing. When to implant IOL in pediatric cataract surgeries. Whereas to do only cataract surgery, lensectomy, or to implant IOL primarily, and what is the IOL power, the target refraction, IOL type, and optical rehabilitation. So first of all, when to implant IOLs in pediatric cataract surgeries. Laterality is very important point that will help you in deciding when to implant the IOL. So if you have unilateral cataract surgeries, you can implant IOL as early as 7 months old, according to infant aphakia study. Even some surgeons, they implant earlier than 6 months, but as Dr. Nihal mentioned, the changes in the corneal curvature and axial length during the first 6 months of life is huge. And you will face a huge myopic shift that is unpredictable, and it can lead to amblyopia after that. In bilateral cataract surgery, you can implant IOL as early as 1 year of age. Also, ocular comorbidities will help you in deciding whether you can implant or not. For example, if the patient has microcornea, which is less than 9 millimeters, you cannot implant IOL. Also, if the patient has axial length less than 17 millimeters, and if the patient has anterior segment dysgenesis or pre-existing glaucoma, all these factors can make IOL implantation has many complications for the patient. IOL power, target refraction. There are two methods that can help you in deciding what IOL power to implant in the pediatric cases. The first one is the target refraction equals 7 minus the age in years. For example, if you have a child who is 6 years old, so you will the target refraction will be 7 minus 6. That is, you will put +1 under correction. Then if the child, for example, is 2 years old, then you will do 7 minus 2, that is +5 under correction. So if the emmetropia is +30, you will make it +25, for example. The second method to undercorrect is the percentage. So if the child is 1 to 2 years old, you can do 20% undercorrection. If he's 2 to 3 years, you can do 15% undercorrection, and so forth. But put in mind that all these are just guidelines. Personally, I do both methods in each child, and then I will take something in between. Okay. This is something quoted from Edward Wilson Pediatric Cataract Surgery book. He said these tables are only meant to be as a help as a straight point toward appropriate IOL power selection, which is multifactorial decision and customized for each child based on many variables: the age, laterality, amblyopia status, likely compliance with glasses, and family history of myopia. All these factors will help you to decide what is the target refraction for the child. Come to which IOL and what is the IOL type. For rigid PMMA is the best and the only choice. For foldable, actually the best choice for children is the acrylic hydrophobic IOLs, which is unfortunately in Yemen, like only maybe one company has hydrophobic acrylic. All the other companies has hydrophilic. Hydrophilic will cause more PCO rates, will cause more phimosis, will cause more capsular contraction because of the biocompatibility of the lens. So why acrylic hydrophobic? It has good UVL, excellent capsular biocompatibility, folds, unfolds in controlled fashion, more than hydrophilic. Hydrophobic will unfold very fast and very low water content and high refractive index. Coming to the IOL types, we have two types, single piece and multi-piece. For in-bag implantation, you can whether use single piece or multi-piece. But for sulcus, please only implant 3-piece IOL. Please only implant 3-piece IOL. If you are implanting foldable single-piece IOL in the sulcus, it will move. In many cases, it will move with the pupillary dilatation. Pupil will move and the IOL might be decentered. 3-piece IOL usually will be more stable. Coming to post-operative visual rehabilitation, aphakic glasses. In aphakic patient, you should do refraction as soon as possible. I saw some children that had done lensectomy and the surgeon told them to come after 1 month for refraction. That is too long. You have to do post-operative refraction as soon as possible. Within 1 week, you need to give these glasses, aphakic glasses. Otherwise, you will help him in like preventing deprivation of amblyopia, and you will put him in emmetropic amblyopia. So he will not gain any benefit from the surgery. Once you do the surgery, give him 3 to 5 days until the cornea clears. If you put air bubble, it will absorb. Then directly do refraction for the patient and give him the aphakic glasses. Usually put in mind, those children has no accommodation. So you need to give the full refraction. And in 1 to 2 years, you need to give the refraction plus 3 diopters. For 3 to 4 years, you need to give plus 2, and 5 years or older, you need to give bifocal glasses. Post-operative visual rehabilitation, patient who are pseudophakic, you should do refraction as mentioned as possible as after surgery. Again, when you are giving the glasses, put in mind, those children has no accommodation. Those children has no accommodation. They are not like normal children. You will give 2/3 of the refraction and so on. No, give full refraction. If he has +5, give +5. Do not undercorrect. That patient is just like an adult who is 60-year-old. He has no accommodation. Post-operative rehabilitation, the follow-up usually in pediatric cataract surgery, it's not like adult cataract surgery. You need to see the patient first day post-op, first week post-op, first month post-op, then every 2 to 3 months in the first year post-surgery, then every 4 to 6 months, and for a very long-term follow-up, because those patients has a risk of post-operative pseudophakic or aphakic glaucoma even after 10, 15, 20 years post-surgery. Those patients has a long-term risk of developing retinal detachment and glaucoma. You can see even the child more often in complicated cases or in cases of severe post-op reaction. What to do in the follow-up visit? You need to check for visual acuity, visual axis obscurations. You need to check the IOP, check the refraction, check the fundus, check the visual acuity or the fixation of the patient, and check the compliance for the amblyopia therapy. It's very important point. Very important point, especially in unilateral cataract cases. You need to put the child in an aggressive amblyopia therapy. Patch the normal eye 6 to 8 hours and check the compliance with the family in each visit. Otherwise, you will have a great surgery and very good surgery, but very poor visual outcome. Amblyopia therapy in unilateral cataract cases need to start occlusion therapy as early as 1 week post-op, start with aggressive patching regimen and check compliance each visit. In bilateral cataract cases, when fixation preference is present, for example, patient has bilateral cataract and you did bilateral cataract surgery, but he came to you after 2 or 3 months with right esotropia or right exotropia or unmaintained fixation on one of the eyes. That will give you a hint that there is one eye which is amblyopic more than the other eye. So you can also start patching.
Still 1 minute, Dr. Amir.
Biometry formulas that we use, unfortunately for pediatric cases, there is no specific IOL formula, but and errors are common. Haigis-Hofer formula for smaller eyes, and some surgeons prefer using SRKT for all the eyes. Challenges in biometric key reading using standard autorefractometer. Sometimes it's not easy for younger children. You need to use a portable autorefractometer. Further reading in pediatric cataract surgery, I would recommend 3 books that are very important pediatric cataract surgery for anyone who is doing pediatric cataract surgeries and who is interested in that field. That book, Pediatric Cataract Surgery for Mr. Edward Wilson, one of the most important books, Pediatric Lens Disease and Essentials of Pediatric Cataract Surgery by Coker. For those who love to watch videos, you can watch Dr. Nihal Shaqanqiri video on cybersite.org. She has a very nice presentation for 1 hour about surgical management of congenital cataracts, and there are other lectures like Pediatric Cataract Dilemmas by Ramesh Kekunaya and Pediatric Cataract Management by Dr. Kalyani from Shankara Netralaya. Thank you so much.
شكرا دكتور عمرو. هلا الاسئله نخليها لنهايه السجن علشان الوقت، بس علشان صلاه الجمعه. ننتقل لل other topics with pupilloplasty pediatric traumatic cataract surgery with Prof محفوظ عبد الله بن مشموس. تفضل يا دكتور.
السلام عليكم. طبعا الحالات اللي بتيجي للعياده روماتيك كاتاراكت في البيدياتريك دائما، في مش كلها بس جزء كبير منها بيجي pupil problems يا pupil irregularity dilated pupil، ومرات يكون ايضا iris dialysis. فكل الحالات هذه اللي بتيجي بنعمل لهم pupilloplasty. اسم البروسيجر single pass 4 through technique for pupilloplasty invented by عمار أجروال. البيوبيلوبلاستي بتعطينا very good results في الفيجن. يعني انتوا هتستغربوا انه مريض تعمل له كاتاراكت سيرجري مع اللينسكتومي مع فيتريكتومي ما تعملوش بيوبيلوبلاستي، الفرق كبير جدا. يعني الفيجن بيتحسن بشكل خرافي. فطبعا الطريقه سهله بسيطه جدا، يعني ممكن تشوفوها وموجوده في الانترنت، انه الجراح بيدخل النيدل وبعدين بيعمل 4 ثرو تكنيك. 4 ثرو ايش؟ هذا سكتش، تدخل النيدل وبعدين بتسحبها لبرا العين، بعدين تعمل 4 ثرو. ليش 4 ثرو؟ لو عملتها 3 ما بتسكر معك، لازم تعملها ايش؟ 4. يعني التكنيك هذا واحد خياط محترف هندي هو اللي اكتشفها، تمام. فبالتالي لما تعملها على طول بتتخيط وبتغطي الايرس بشكل جميل جدا. ماله؟ يعلق. هذه الطريقة، بتدخل النيدل، بتسحب السوتشر لبرا. طبعا نحن بنستخدم برولين عشان ما يذوب، وبنعمل 4 ثرو تكنيك. نستخدم دائما ال 10 او او ال 9 او، نحن بنجيبها من شركة اورولاب. طبعا هذا مريض سنجل اي، اجى عندنا بانفجار تاير، عين راحت والثانية عنده 1 متر. تابعناه لما تحسنت الهايفيما تبعه، وبعدين تكون عنده ايش؟ كاتاراكت. طبعا حاولنا نأجل العملية بس ما بيشوف، فبالتالي قررنا نعمل له هذه العين الأولى وهذا العين الثاني يشوف counting 6 meters. حاولنا نعمل له observation، ومع الوقت الفيجن تدهور، فقررت أعمل له فيكو مع ايريس هوكس، وإذا ما تحسن وما قدرنا نزرع له عدسة نعمل له إيش؟ سكليرال فيكسيشن. هذه هي العين بري اوبراتيف. هذه الالترا ساوند. تشغل الفيديو. طبعا زي اي عمليه فيكو بنعمل ووند، فيجن بلو، كابسولوركسس، وبعدين بنشيل الكاتاراكت، بنعمل ريليفينج للادهيجنز اللي ملزقه في الكورنيا في شو اسمه بين الايريس واللينس. بعدين نعمل كابسولوركسس. بعدين المنطقة اللي فيها اديشن نقصها. بعدين نعمل فيكو، ستاندرد فيكو. بعد ما نعمل له الفيكو نعمل irrigation aspiration للsoft lens matter. بعدين نعمل له intraocular lens. طبعا نحن نستخدم مرات السنجل بيس، مرات الثري بيس، مرات نستخدم الالكوم. هذا زرعنا له مالتي فوكال. وبعدين نعمل له ايش؟ السنجل فور ثرو تكنيك. تدخل السوتشر من البيوبل، بعدين تسحبها من الجهة الثانية. تكنيك بسيط جدا ورائع، يحتاج فقط تشوفها مرة أو مرتين وبعدين تقدر تماستر it very easily. بعدين تخرج النيدل، تسحب السوتشر بالسينسكي هوك لبرا، وبعدين تعمل بالضبط 4 ثرو. إذا عملت أقل من كده ما بتسكر. one 2 3 4. بعدين تسحب من الجهتين تتسكر معاك البيوبل. هذا المريض، هذا الفيجن حقه 2035. هذا مريض ثاني جاب تروماتيك كاتاراكت واكتوبيك بيوبل. هذا شكل الاكتوبيك بيوبل. شغل الفيديو. نعمل له irrigation aspiration. كابسولوركسس. طبعا سوفت لينس نعمل لهم. طبعا في دياليسيس في اللينس فبنستخدم كبسول هوك. كبسول ايش؟ طبعا الكبسول هوك بيفرق كثير معانا، لانه اذا ما استخدمته بيصير معاك دياليسيس ممكن لللينس ويصير معاك سبلكسيشن. تعمل irrigation aspiration، بتزرع العدسة. هذا زرعنا له 3 بيس. زي ما قال الدكتور عمر، 3 بيس هذه غيرت حياتنا بشكل كبير في حالات التروماتيك والبيدياتريك كاتاراكت. وبعدين نعمل لهم ايش؟ البيبيلوبلاستي اللي هي single 4 through technique. نعمل واحدة ونعمل أيضا مرة ثانية. هذا الشخص أجا بتروماتيك سبلكسيتد كاتاراكت. شغل الفيديو. طبعا عنده فيتريوس في الانتيريور تشامبر، فعملت له فيتريكتومي في البداية. عشان نخفف الفيتريوس. بعدين كابسولوركسس. بعد الكابسولوركسس نحط لهم كبسول شو اسمه هوكس، او حتى اذا ما فيش معك مرات كبسول هوكس تستخدم الايريس هوكس الموجوده عشان تشد ايش؟ الكبسول. بعدين تعمل irrigation aspiration، بعدين تزرع له عدسة. هذه الكون لينز. الالكون لينز زي ال 3 بيس حقيقة، نتائجها ممتازة جدا. وبعدين تثبت العدسة وتشيل الايريس هوكس، بعدين تعمل له البيبيلوبلاستي، واحدة فوق واحدة تحت. هذه آخر حالة، شخص أجا عنده أيضا ايريدو داياليسيس، أخوها ضربها علشان تليفون، صار عندها هايفيما. طبعا نحن نسجل في الملف إيش اللي صار، فلما يجي المريض بعد 10 سنوات يقول له أنت اللي ضربك بالتليفون، يقول والله على ذاكرة معك، هو مسجل بس. فهذا الايريس داياليسيس. شغل الفيديو. نفس الشيء نعمل له فيجن بلو كابسولوريكسس. طبعا هذا الشخص او البنت اللي ضرب اخوه عشان التليفون عندها ايضا ايريس داياليسيس، فلازم ايضا نعمل تثبيت للايريس. نستخدم ايريس هوكس علشان نوسع العين. طبعا الايريس هوكس اللي تيجي 5 حبات، دائما نستخدم 4 الا في الحالات هذه نحتاج ايش؟ ال5. يعني الهنود مش حاطين 5 حبات للفرع، للحالات هذه علشان الايريس ايش؟ داياليسيس. نزرع لهم العدسة. بعد ما نزرع العدسة نشيل الايريس هوكس ونبدا الخطوة اللي هي الايريدو داياليسيس ريبير. طبعا التكنيك للايريدو داياليسيس اصعب من البيبيلوبلاستي، لكن برضه بيعمل لنا نتائج كويسة. بنستخدم نفس السوتشرز اللي هي ال 9O او ال 10O برولين، ندخلها من تحت لفوق ونربطهم بحيث يرجع الايريس لمكانه. بعد ما نعمل الايريدو داياليسيس ريبير نعمل خيط ولا خيطين ونخيطها. طبعا مع الكونجنكتيفا بتغطيها، وكونه برولين ما بيدوبش. بعدين نعمل البيبيلوبلاستي اللي هي سنجل باس فور ثرو تكنيك. ممكن تعمل حبة حبتين 3 حسب ايش ما انت تشوف البيوبل يرجع لحجمه ايش الطبيعي. هذه البنت الفيجن تبعها في العين المضروبة يساوي الفيجن في العين ايش اللي مش مضروبة 20/40. طبعا نحن عندنا دكاترة شبكية للحالات الإصابة بنحولها لعندهم for re-evaluation. فبالتالي السنجل باس فور through pupilloplasty has advantages in various settings. Thank you.
شكرا جزيلا بروف. احنا هنضطر ننتقل للمحاضرات ونخلي الأسئلة للآخر لضيق الوقت وعشان صلاة الجمعة. Next topic, 6th cranial nerve palsy management by Dr. Soumya R. Dr. Soumya R is senior pediatric ophthalmology and strabismus consultant at Shankar Eye Hospital, Bangalore. And she was my mentor for 2 years during my fellowship. It is a great honor to have you, ma'am, with us in the annual meeting of Yemeni Ophthalmic Society. And I thank you very much for your accepting the invitation and for being with us. You can start, ma'am. Thank you so much.
Yeah, thank you, Dr. Amar, for the kind invitation and the opportunity. Is my slides visible?
Still, ma'am.
Just give me a minute. Is it visible?
Yes, ma'am. It's now visible. You can start.
Yeah. Shifting gears from what we discussed just now with the beautiful lectures of pediatric cataract surgery, we'll move on to the squint surgery. We would be discussing on the management of sixth nerve palsy. The overview of my talk would be have a quick introduction, a few differential diagnoses. We would understand what the investigations that we do, how do we manage medically or surgically with the help of cases, and the other options, and a quick take home. When we look at sixth cranial nerve palsy, there are two aspects of it. One is the neuroophthalmic aspect of it. The other one is the strabismic aspect of it. A quick introduction, what we need to understand is with respect to the neurological association, since the nerve nucleus lies at the level of the pons, where the facial nerve nucleus is very close to it. So any sixth cranial nerve, always look for symptoms of facial nerve palsy. In the subarachnoid space, it can have an isolated entity. In the cavernous sinus, it can have a multiple cranial nerve associations. When we look at the etiology of sixth cranial nerve, especially according to the age group, when we look at any child less than 10 years old, the most important etiology is idiopathic or post-vaccination or post-viral, unlike in adults where the vascular etiology becomes predominant, or the neuroophthalmic aspects of it. Now look at the differential diagnosis. When we look at this particular child, at the outset, what we see is there is an abduction limitation in the right eye, there's an abduction limitation in the left eye. It's easy to jump to the diagnosis of a bilateral sixth cranial nerve palsy. What is also very striking about it is the narrowing of the palpebral fissure, which is a characteristic feature in case of a Duane's retraction syndrome. Apart from that, look at the angle of strabismus with the bilateral abduction limitation, which is very, very minimal, which again goes in favor of a Duane's retraction syndrome, not a sixth cranial nerve palsy. Or the cases of infantile esotropia, where there can be apparent abduction limitation, which gives you an impression of a bilateral sixth nerve palsy. The features of cross-fixation, the age of onset, and closing one eye to elicit the abduction helps us come to a conclusion of a sixth nerve palsy or essentially infantile esotropia to be differentiated. The other important things to be differentiated are TED and divergence palsy, especially in adults. So whenever we're looking at an abduction limitation, correlate this with the amount of esotropia which is there in primary case. Also look for a distance near disparity, which always goes in favor of a sixth cranial nerve palsy. And the absence of signs of retraction or a co-contraction again goes in favor of a sixth nerve palsy. Now let's discuss a few cases to understand what the important investigations that we do and how do we manage these cases. This is an elderly gentleman who came to us with the complaints of diplopia since a week. What is obviously seen for this is the patient has a right face turn. The patient is also a known diabetic and an hypertensive and on medications for hypercholesterolemia. This is the 9-gaze photograph. The patient has obviously an esotropia, which is around 35 prism diopter. The left gaze and the left levo elevation and levo depression being completely normal. There's a gross abduction limitation of the right eye. There's no palpebral fissures that we see. The near deviation was much lesser, which is around 10 to 12 prism diopters. So what do we do in a patient with diabetic sixth nerve palsy? This is obviously due to a diabetes. You get the investigation done in terms of fasting and postprandial blood sugar levels, which were increased in this patient. You also do something called as a glycosylated hemoglobin, which is again increased. Getting this done is very important because it gives you an idea of 3-month control of diabetes in for the patient. So we take a physician opinion, get the control of diabetes. In the interim, what are the various options that we have for this patient? One, we can think of giving a Botox to the ipsilateral medial rectus to correct this deviation and help him manage. 2, give him frosted glasses for the right eye and he manages with the left eye. Lastly, we can also opt in for a Fresnel prisms. What we did for this patient, what patient chose were a frosted glasses. We waited for a month when it showed recovery and then continued on follow-up and he completely recovered at the end of 2 months. Neuroimaging in these cases with the diabetic sixth nerve palsy becomes important only if there is no recovery beyond 4 months or we see other signs of neurological involvement or there's a pupillary involvement or there's a cranial nerve involvement. Only in those cases, neuroimaging plays a role. Now, moving on to the next case, this is a 42-year-old gentleman, again coming with the complaints of diplopia for the last 2 weeks. What do we see in this patient? Has around 30 prism diopters of esotropia for distance, around 10 to 15 for near. Again, you look at the right eye abduction limitation, which is there, which is around -2. The most important part of his history was he was diagnosed with COVID 25 days back. and he was not a known hypertensive or a diabetic. Considering his 42-year-old, the atherosclerotic changes are also going to be very, very minimal. So for these investigations are going to vary compared to the first case. We get a complete blood count, which is normal. We also look for other parameters related to COVID in terms of LDH, SGOT, and serum homocysteine. In any young patient coming with a vascular etiology, an acute sixth nerve palsy, always get a serum homocysteine level. There's a definite connection between higher homocysteine levels and an onset of sixth nerve palsy. So homocysteine level was borderline high, random blood sugar was normal. In view of homocysteine and blood sugar levels being normal, we got an MRI for this patient done. MRI showed a coincidental finding of a bilateral maxillary nasal polyp. In view of his COVID etiology, we ruled out mucormycosis before we started him on steroids. So the treatment was given in terms of steroids and vitamin supplements for this patient. What we see was a patient recovered at the end of 2.5 months, being completely orthophoric and the ocular movements completely full. So in a young patient with sixth nerve palsy, the second important investigation that you do, or the investigation that you do apart from a complete blood count, will be serum homocysteine level. Now moving on to the third case, which was a 31-year-old gentleman who presented with diplopia. He had a history of trauma 2 months back, where he had a head injury, and he had got a CT scan done which showed a extradural hematoma. He had a fracture involving the pitras apex. We know that the sixth cranial nerve passes above the pitras apex, and that is why the sort of an injury. He had a 30 to 35 presumed diaptose of esotropia, which is around 40 to 45 in the right case. Gross abduction limitation of around -4 in the right. So what did we do for this patient? He was, since he was under the care of neurosurgeon and was being treated for steroids, we waited. In the interim, what we gave him was Fresnel prism. Since the angle of esotropia was around 30 to 35, what we gave him was a Fresnel on both the eyes instead of giving grounded, which has a limitation of around 10 prism characters. And we waited for it to recover completely for the next 4 months. So in any case of traumatic sixth nerve palsy, we wait for 6 months and 2 consecutive measurements which are normal before we plan a surgery. Now we come to surgical management of sixth nerve palsy. What are the options that we have? So what we have to remember in terms of sixth nerve palsy is look for ocular movements. If there is limited ocular movements, look for reduction if it is past midline or it is less than midline. If it is past midline, a resection procedure or a strengthening procedure of LR is going to work for us. If it is short of midline, you do a force generation test, which is basically to assess the functioning of the lateral rectus. If there is a moderate force generation, you can still get away with doing a larger resection. If there's no force generated, or if it's a weak force generated, you do a transposition procedures. So in a case of reduction past the midline, there is a reduced FGT and saccadic velocity being more, then you diagnose it as a partial sixth nerve palsy and do an RNR procedure or a 3-muscle procedure depending on the angle of esotropia. So now we move on to a case of partial sixth nerve palsy before we come back to the case 3. So this is a young lady who had a history of TB meningitis 2 years back and was treated with ATT that time. MRI was suggestive of a granuloma in the right basal ganglion. We got a HFA, visual fields, done in order to confirm that there is no visual field involvement. This is how she presented to us. She's been having a constant diplopia, around 40% diaptose of esotropia, which is the same in the right gaze and the left gaze, and the left eye showing a -1 to -2 limitation. The near and the distance disparity had disappeared, and there is also spread of committance in this particular patient. So we got a neurologist opinion done who confirmed that the tuberculosis is completely under cure and the granuloma is chronic and nothing to be done about it. So she had a mild limitation of abduction in the left eye, and the saccades of the lateral rectus were good and brisk. So what do we plan for this patient? It's a partially resolved sixth nerve palsy with adduction past midline, saccades being very good. So we did a RNR procedure, basically MR recession and a LR resection procedure. The patient has orthophoria in the primary gaze with good ocular movements as well. So that becomes a plan of action in case of a partial sixth nerve palsy. Now coming back to the case 3 that we were discussing, this patient, look at the saccades of the patient. This is what we were discussing. Clinically, we could check the saccades using a finger and a pen. Look at the right eye. The saccade initiation is very, very slow for this patient. So when it is very slow, you obviously know that the force generation is going to be very weaker. So what are the options that we have is in terms of transposition. So it could be a single muscle transposition or a both the muscle transposition of the vertical recti, and it could be either a full tendon or a partial tendon procedure. In the partial tendon, we could augment it with a Foster's modification, augmented Hammersheim's, or a crossed adjustable transposition or a Jensen procedure. What we have in hand as of now is also a superior rectus transposition or a modified Nishida's procedure. In all the transposition, what is the most important prerequisite is the FTT has to be free. So check for the FTT. If there is a positive FTT, always do a MRization along with the transposition. So let's look at a couple of surgical procedures. Sorry. So this is a procedure of a partial DRT procedure, which is being done. So what we do in a partial vertical rectus transposition, you're using the half tendon, that is the temporal half of the tendon of both superior and lateral inferior recti, and transposing it to the lateral rectus muscle. So you split the muscle into two, and then use the 6-0 bilateral sutures, disinsert the inferior rectus. The same procedure you repeated on the superior rectus muscle as well. So once we do the same procedure on the superior rectus, taking care that we don't harm or don't involve the superior oblique muscle when we are dissecting or transposing the superior rectus muscle. So you transpose it on either side of the lateral rectus muscle, maintaining the arc of T-locks. What we did also for this patient was a Foster's modification, that is using a non-absorbable suture. You take a bite involving the lateral rectus and the transposed superior rectus or the inferior rectus muscle, which again enhances the effect of transposition. So this is what we did for the patient, which is basically an augmented Hammersheim's procedure. You see the temporal half, the superior and inferior rectus flows to the lateral rectus. So what we also can do for these patients is a superior rectus transposition. That is using just a single muscle instead of using both the vertical recti. Why is this important? Again, we're looking at anterior segment ischemia as a complication when we do a full tendon procedure. So that is why single rectus muscle transposition comes handy. And the problem with the superior rectus transposition alone would be the induced vertical deviation and the induced torsional diplopia, which can be very troublesome in some of the patients. So taking care of the complete dissection and not using a Foster's modification in an SRT especially in order to avoid the torsional diplopia comes handy. So the superior rectus muscle, the full tendon of it is transposed to the upper border of the lateral rectus, which gives you correction around 30 prism diopter. So this also can be a procedure of choice. What we have as of now is a modified Nishida's procedure, which completely circumvents the problem of anterior segment ischemia. So here what we do is basically that you use a non-absorbable suture 10 millimeter behind the insertion of the superior rectus and inferior rectus. Don't disinsert the muscle, don't split the muscle, and use the same suture on the sclera, superotemporally or infratemporally, 10 to 12 millimeters behind the limbus, and tie this suture. So this is essentially the effect that you get post the procedure. So now let's look at the procedure. How was it actually done? You use a little different incision in terms of a radial incision. You expose the superior rectus muscle first and separate it out from the superior oblique muscle. Once we have done it, get an adequate exposure using a retractor. Use a ethibond suture, 8 to 9 millimeter, close to 10 millimeter behind the insertion of the superior rectus muscle. You use only the 1/3 of the muscle of the superior rectus. Once we have done this, you release this and go to the superotemporal area, midway between the superior rectus and the lateral rectus muscle. You take the same suture, bite onto the sclera, tie this up so as to transpose. You see that the temporal half of the superior rectus now was in the superotemporal quadrant. So these points of adhesion create abductional forces, thus improving the abduction. So this is what you do superiorly and inferiorly. Once we've done it superiorly, you do the same procedure inferiorly as well. So here again, 10 millimeter on the muscle, 12 millimeter on the sclera in the infratemporal quadrant. Use the same ethibond suture, tie it up so that you transpose both the superior and inferior rectus onto the temporal point. So this is what we did for the patient. This is the pre-op of the patient. This is the post-op. The patient is completely orthophoric with an improved abduction, almost up to -2 to -1. This is the abductional force that you get with a properly performed modified Nishida's procedure. Now let's look on to the other case, that is a pediatric sixth nerve palsy. This is a child which came to us with a left face turn, had a history of viral fever 2 weeks back. Now look at the patient when we check the ocular movements. The patient has completely normal dextroversion. He resists when I try to check the abduction or the levoversion movement. There is a gross abduction limitation of the left eye. So he has an isolated sixth nerve palsy secondary to probably viral illness or meningitis. So in these set of patients with a pediatric sixth nerve palsy, what are the important things that you look for? One, look for the history of fever, look for history of trauma, look for history of vaccination. Also check if there is an associated facial nerve palsy. So if there is history of trauma or facial palsy, obviously you need a MRI or the neuroimaging. If there is a papilledema, again, you require a neuroimaging. Any history of vaccination has to be ruled out or has to be asked for in a case of pediatric sixth nerve palsy. So we got a neuroimaging done for this patient. This neuroimaging showed was completely normal. A neurologist opinion was also sought. So he had around 25 prism diopters of esotropia. We started him on alternate patching. In any case of pediatric sixth nerve palsy, you also have to look for if the patient is adopting posture or otherwise. If he is not adopting a posture, it's important to start on alternate patching. Even if he is adopting, it's a prudent idea to start off with alternate patching as well, to prevent the amblyopia one and also to act as a physiotherapy to improve the lateral rectus movement. So once we started him on steroids, this is how he recovered in the next 6 weeks of steroid, the ocular movements being completely full and he is being orthophoric. So not every case of pediatric sixth nerve is as easy to manage as this. You can have other issues as well. This is the last case of mine. He has a history of face turn noticed by the parent at the age of 2 years. Look at the abduction limitation in the left eye. It's almost -5, has around 45 prism diopters of esotropia. What is also important in these cases, though it's a rarer onset, to ask for a family album topography. Now look at what has happened over a period of years. This is when the child started sitting, that's around 1 year, 2 months, continues to have a left face turn. It grows up to be a 3-year-old, left face turn continues, left face turn continues. So this is a case of a congenital sixth nerve palsy, which is a rarer entity. Again, important to rule out neuroimaging. What we did for him was a modified Nishida's procedure in the left eye along with the MRI session. He recovered completely well, which has around 8 to 10 prism diopters of esotropia in the primary case with a good abduction limitation improvement and the correction of abnormal head posture. So in these patients, it's also important to look for the family album topography. So modified Nishida's procedure compared to a VRT gives you the same amount of correction and with a lesser risk of anti-segment ischemia. We have other procedures also available like a cross-adjustable procedure or an inferior rectus transposition procedures also. So what is important for us to understand in any case when you're managing a sixth nerve palsy, look for vaccination signs and trauma in a pediatric sixth nerve palsy. In an adult sixth nerve palsy, most importantly, vascular risk factor. And in our scenario, like in Indian population, history of tuberculosis becomes very important. Always look for papilledema, which can present as a false localizing sign in terms of sixth nerve palsy. And anatomical localization becomes important in a neurological causes, like in cranial nerve palsy. Various surgical options that we have in hand in terms of a full tendon, partial tendon, a modified Nishida, or an adjustable techniques as well. So it's very, very important to look at the details of it before we jump into the diagnosis or in terms of managing. Thank you very much.
Thank you so much, ma'am. Thank you so much for the thorough, comprehensive lecture as usual. We will take 1 or 2 questions if there is any questions. Regarding ma'am, modified Nishida procedure, sometimes like I did it in a few cases and I found a difficulty in pulling the muscle to the site of the scleral bite. Is there any tips that can help us in approaching the muscle to the scleral bite position?
Yeah, very important because we have not disinserting the muscle per se. It becomes a little difficult when you have to pull the muscle. It will be ideal. What you can do is when you hook the inferior rectus or superior rectus for the matter, and then you're pulling it laterally, you hold the hook and take it onto the temporal side as to where you want to hook it. And then start tying it up. Rather than just pulling the muscle, you're holding the muscle straight across and then trying to pull the suture. It gets cheese bite either at the muscle end or the scleral bite comes out, your partial thickness bite that you have taken out. hold the hook in such a way that, or have an assistant who understands what you're trying to do, take the muscle temporally, take the hook onto the temporal side. You're hooking the muscle, but you're taking it temporally, and hold both the ends of the muscle, bring it inch by inch closer together. That helps in tying it up much better. So that probably could help.
Thank you so much, ma'am. Any questions before moving to the next lecture? Okay, thank you so much, ma'am. Thank you so much.
Yeah, thank you for the opportunity. Yeah, good to see you.
We'll move to Essentials of Infantile Esotropia Management, Dr. Mohammed Yassin, Maghrabi Eye Hospital.
السلام عليكم. طيب طبعا الاسنشيال انفانتايل ايزوتروبيا موضوع كبير جدا. احنا ان شاء الله بنحاول نركز فقط على المانجمنت وان شاء الله ما نطولش فيه. Okay, essential esotropia in general, it's inward deviation of the eye of infants in the first 6 months, within the first 6 months of normal infant. أهم شيء يكون no neurological disorder, no refractive errors, no limitation of ocular movement. الكونستانت انجل تكون more than 30 بريزم دايوبتر. طيب ايش الاسوشيتد فيتشرز؟ عاده بتكون مصاحبه للانفانتال ايزوتروبيك alternative esotropia or cross fixation, refractive error, separation, amblyopia, inferior oblique overaction, or disassociated vertical deviation or latent nystagmus. طيب نبدا بالمانجمنت اللي هو موضوع المحاضره. المانجمنت اوف انفانتايل ايزوتروبيا طبعا هو is a disease of surgery، يعني هو في الاول والاخير احنا بنحتاج السيرجري. في مدارس كثيره، في نظريات كثيره، بس في الاخير كلهم بيقولوا انه السيرجري هو العلاج. طيب معنا surgery or non-surgical or a combination of both. Surgery is the treatment of choice for the infantile esotropia. طيب ايش الجولز of surgery؟ to obtain alignment of as close to orthotropia as possible within 10 prism diopter. يهمني يكون الاكسبتبل كوزماتيك وسنترال سيبريشن ونو بايفوفيال فيوجن وبريفرال فيوجن. طيب التايم اوف تريتمنت must be treated as soon as possible، يكون بالكثير على اول 12 شهر، ما يزيدش عن 2 سنين. طبعا انا ما اجي افعل له العمليه الا بعد ما اتاكد انه ما فيش عنده امبليوبيا او اني ريفراكشن ايرور. طيب في معي early advantage late advantage disadvantage للسيرجري. في الايرلي advantage اللي هي better for obtain the binocularity reduce muscle contraction. في ال disadvantage may increase the risk of amblyopia or difficulty in reliable the measurement. اما الليت سيرجري بيكون معنا الادفانتج امبلوبيا مانجمنت، بتكون الامبلوبيا مانجمنت بتكون more reliable measurements و reduce potential for binocularity. هذا في disadvantage. reduce potential for binocularity والmuscle contraction can lead to mechanical component of squint. طيب so surgery is more technical challenging earlier in infant because of. ليش بيعاني الجراح من صعوبة في الحالات حق الانفانتايل ايزوتروبيك؟ لأنه حجم العين حق الطفل بتكون صغيرة و the lack of stability of the deviation، وأحيانا بيكون في صعوبة في تحديد زاوية الحول و difficulties in measuring the alignment. طيب أنا لما يجي الأب والأم لا عندي، أول حاجة ضروري أفهمه إنه ابنك أو بنتك بيحتاج عملية. طبعا في البداية كلهم يعني يمكن قد يعترض يقول لك الطفل عضو صغير، بس أنا ضروري كمان أفهمه إنه العملية هذه قد تحتاج عمليات أخرى، وضروري كمان بعد العملية بيحتاج متابعة باستمرار، فهذه مهمة جدا. طيب إيش السيرجيكال أدجستمنت أوف هوريزونتال أكتنج إكسترا أوكيولار مسل؟ في معي أشهر عملية اللي كلنا تقريبا أو أغلبكم بيشتغلها، اللي هي بايلاترال ميديال ريكتاس ريسيشن أو يونيلاترال ميديال ريكتاس ريسيشن with ipsilateral rectus resection أو 3 or more muscle resection. طيب بنتكلم عن اهم عمليه اللي هي بايلاترال ميديال ريكتس ريسيشن، اللي هي بيكون الفكره منها السيرجري ان احنا بنفعل يعني بنرخي الميديال ريكتس، يعني بنرجعها شويه للخلف عن الاناتوميكال بوزيشن عشان ايش؟ نريح العين. طيب ايش ذيس ميثودز، ايش الايجابيات اللي فيها؟ بتكون كويكر، سمبلر، ليس تروماتيك، وموست افكتيف. طبعا في الاطفال بيكون عندي برضو صعوبه في تحديد زاويه الحول، لكن انا بعد ما افعل له ريتينوسكوب والهيرشبرغ تيست واذا قدرت بالبريزم، هنا كل زاويه بيكون كم مليمتر ممكن انا بفعله يعني عشان ارجع المصل للخلف. هذه مثلا صوره قبل وبعد. طيب اليونيلاترال ميديال ريكتس ريسيشن with ipsilateral lateral rectus resection، هذه بتكون في الذي عنده ايزوتروبيا more than 17 بريزم diopter. يوسف ايوه اوكي. ان ريسكشن احنا بنفعل سترينث للمسل اللي هي اللاترال مسل، وبناخذ جزء من المسل وبعدين بنفعل ري انسيرشن لللاترال مسل to the same position. هذه هنا رسمه توضيحيه الفرق بين الريسكشن والريسكشن. طيب في معي سيرجري تو ادجستمنت ذا فيرتيكال اكتنج، الانفيرير اوبليك اوفر اكشن اللي هي بتكون احيانا مصاحبه للانفنتال ايزوتروبيك، وهي في الغالب بتكون اذا عدى السنتين هي بتظهر هذه المشكله حسب ما بتقول الستاديز. احنا طبعا بنفعل سيرجيكال ويكنينج اوف انفيرير اوبليك مسل which responsible for pulling the eye up in adduction. بنفعل cutting of part of the muscle او بنفعل anteriorization of the muscle to the anterior equator، يعني بنغيرها من البوستيريور equator للانتيريور. طيب disassociated vertical deviation هذه برضو بتكون للاطفال اللي بيكونوا more than 2 years. التريتد بيكون superior rectus recession و responsible for pulling the eye up in abduction and or primary position with or without fading suture posterior fixation or inferior oblique anterization، واعتقد اني الاخيره هي بتكون الاسهل. طيب ايش الكومبليكيشن الذي قد تحصل لي مع العمليه؟ under correction or over correction، بسبب انه الطفل صغير مش قادر يحدد الزوايا، او قد يحصل لي perforation للسكليرا لاني عادي بتكون تن loss of slipped muscle، ممكن المسل تتحصل يعني تروح عليه. infection anterior segment ischemia، هذا في حاله انه احنا اشتغلنا مثلا more than 2 muscle or post operative diplopia. طيب في معي نقطة بسيطة، احنا قلنا طبعا سيرجري هو علاج الاسنشال انفنتال ايزوتروبيك. طيب قلنا بس انه ما بيكونش معي نو ريفراكتيف ايرور. في حالة انه جاء معي ريفراكتيف ايرور مثلا في الفيرست 6 مانثs، انا يهمني يعني مثلا يكون في معي جريد ذان 1 انا هاف دايوبتر، يهمني انه اول شيء اعالج الريفراكتيف ايرور، ان انا اجيب للطفل نظارة اوكي، واذا كان في معه كمان small angle of esotropia مثلا less than 13، احنا في الاولى كنا more than 13، ف maybe corrected by glass. طيب هنا اجيب له الجلاس واشوف بعدين خفت زاويه الحول او لا واتابعه. متى بيلبس النظاره او كم بيلبسها مش عارفين، بس اني حاجه مهمه انه اجيب له النظاره. طيب وكمان اذا شفت مثلا في خلال اول 6 اشهر انه في زي الامبلوبيا، ابدا كمان ان انا اغطي له واحده من العيون، وبعدين عشان تنضبط معي زاويه الحول في حاله ان انا فكرت افعل سيرجري. هذا الترتيب اللي هو جلاس اوكلوجن وارثوبتيك تريتمنت اور سيرجري اللي هي ذا لاست تشويس. شكرا.
Thank you so much, Dr. Mohammed Yassin. We'll move to Dr. Tariq Al-Duais, Surgical Management of Fourth Cranial Nerve Palsy.
سريع. بسم الله الرحمن الرحيم. الفورث نيرف بالسي من الاشياء المور كومبليكيتد فور تريتمنت، تحتاج جود اسسمنت. في جود اسسمنت بيطلع لنا جود ريزلت. مبارك ما يشتغلش من البدايه، لا اول سلايد اعمله. surgical management of fourth nerve palsy. الاناتومي بشكل سريع. معانا الفورث نيرف بشكل عام هو سلندر او اطول نيرف، وبالتالي هو مور برون تو تروما اور انجري، وهو كروس كرينيال نيرف، وبالتالي النيوكلس بتاع الرايت تروح للليفت اي وهكذا. المريض بيجي لك بهايبرتروبيا، ليميتيشن ان ليفت ديبريشن، اكستورشن، كومبنساتوري هيد بوزيشنز. اهم حاجه لما نبدا نشتغل سيرجيكال مانجمنت بنتاكد هل هي يونيلاترال اور بايلاترال او كونجينيتال اور اكوايرد. يونيلاترال او بايلاترال مهمه لانك ممكن تشتغل على العين اليمين، بعد العمليه تكتشف انه العين اليسار اصبحت فورث نيرف بالسي. كيف نتاكد؟ Bilateral involvement should be always be suspect until proof otherwise. Is characterized by the following: right hypertrophy and left gaze, left hypertrophy and right gaze, greater than 10 degree circular deviation in double modoxro test, V pattern isotropia, bilateral positive Bilowski test. هذا بنجيب دبل مودوكسرو تيست، نخلي واحد احمر واحد ابيض، او بعض الاحيان يمكن نطرح الاثنين احمر. المريض الذي عنده فيرتيكال ديفيشن بيشوف خطين متوازيين، الذي عنده تورشن بيشوف خط منحرف قليل. بنخلي الاكسس على 90، بعدين بنعدل الزاويه بحيث انها يشوف الخطين متوازيين. اذا الزاويه تعدلت باكثر من 10 ديجري زي هذا تعدلت عن 100، معناته هذا سسبكت بايلاترال فورث نيرف بالسي. النقطة الثانية كونجينيتال أو أكوايرد، بتفرق معي في التريتمنت. إذا كان كونجينيتال ما عاد يحتاج مور ايفالويشن، مور تريتمنت، مور انفستيجيشن، لكن لو كان أكوايرد لا، هنا بيحتاج مور اكزامينيشن لايك MRI وات ايفر. كيف نعرف انها كونجينيتال او اكوايرد؟ اسهل شيء الشايلد فوتوغراف القديمه، لو معه صوره قديمه فيشيال اسيمتري، بنحصل جزء من الوجه هايبوبليزيا، واللارج فيرتيكال فيجنال امبليتيود. هذه اللارج فيجنال امبليتيود بنعطي له بريزم معين، بنخليه يشوف الصوره. الطبيعي انه يشوفها سنجل انتل 5 بريزم. اذا عدت ال 5 بريزم وشاف ايضا سنجل معناته عنده فيرتيكال امبليتيود عالي. اذا عدى ال 10 ديجري معناته عنده كونجينيتال فورث نيرف بالسي. هذا الفيشيال اسيمتري بنحصل انه فيشيال اسيمتري هايبوبليزيا في جزء من الوجه نتيجه الهيد بوستشرز. السيرجيكال انديكيشن معنا symptomatic deviation that lack prominent torsional component, abnormal head position, significant vertical deviation، او اذا المريض عنده دبلوبيا او استينوبيا. لما بنعالج المانجمنت اوف فورث نيرف بالسي في 3 اشياء اساسيه يجب ان نعالجها. اي واحده من الاشياء هذه ما تعالجتش المريض يظل يشتكي بعد العمليه انه لا زال عنده دبلوبيا ما تحسنش. انجل اوف ديفيشنز، هل في لاكس تندن اور نوت؟ هل في تورشن او ما فيش تورشن؟ بنبدا بالتورشن. انت ممكن تعدل الفيرتيكال الاينمنت اوف بيشنت، لكن يظل في تورشن، يظل يشتكي المريض انه عنده دبلوبيا بعد العمليه. هذا المريض نكتشف التورشن بالفندس اكزامينيشن، بنشوف مكان الماكولا ريليتد تو اوبتيك نيرف. ايضا بالدبل مودوكسرو تيست بيطلع لي هل في تورشن او ما فيش. كيف نعالجها؟ بعمليه اسمها هارادا ايتو بروسيدرز. هذه الهارادا ايتو بروسيدرز بنطلع السوبيريور ريكتاس، وبعدين نمسك التندون، هو فيري ثين ممبرين بتاع الفورث نيرف. طبعا الفيري ثين ممكن ينقطع عليك في اي لحظه. another hook، نمسك التندون كامل. بعدين نقطع التندون هذا يا نصفين او ثلثين بثلث 15 ملم. الان نقصه نصين. نخيط النص الأمامي الانتيريور بارت اوف تندون. قصينا 15 ملم من السوبيريور اوبليك تندون الانتيريور بارت، بعدين نخيطها 10 ملم طلعنا اللاترال ريكتس، ونعمل 10 ملم نخيطها على السكليرا. هذه نستخدمها لو المريض هذا عنده torsional component of fourth nerve palsy. مبارك قلب ما يقلبش. طيب الآن لو المريض هذا عنده تندون لاكس، في هذه الحالة مهما فعلت له من تريتمنت الانجل ديفيشن ستيل ان يشتكي ايضا من ديبلوبيا. والانجل لاكس هذا انك بترجع العين باتجاه السوبير اوبليك مسلز. اذا شفت انها غارت كثير او ضاعت في المكان هذاك معناته في لاكسيتي اوف تندون، وهذه بنعالجها بحاجه اسمها سوبير اوبليك تندون تاك. بنمشيها سريع. هذا السوبيريور اوبليك تندون بنثنيها كانك بتثني اي قطعه من الوسط بحيث انك تعمل superior oblique tendon more strength. هذا superior oblique tendon. بندخل الخيط من الامام الى الخلف ونربطها. هنا في عندنا حاجه اسمها superior oblique tendon tuck. الان لو المريض هذا عنده angle of defiance يتقسم الى 3 اقسام اساسيه: 15 بريزم، من 15 ل 30 بريزم. إذا كانت 15 بريزم هنا بنشتغل لها inferior oblique muscles weakness. أهم عملية من هذه العمليات اللي هي inferior oblique anteriorization. لف الفيديو للنص، نطلع الانفيريور oblique. كم باقي يا دكتور صالح؟
1 minute.
خلاص لف للنص وخلاص. طلعنا الانفيريور oblique ونخيطها جنب اللاترال ريكتس. هذه نسميها inferior oblique anteriorization. إذا كان الأنجل من 15 ل 30 نعمل ريسيشن للسوبيريور ريكتس مسلز مع انفيريور اوبليك ويكنين. إذا كان زي هذا المريض عنده أكثر من 30 بريزم بنعمل له انفيريور اوبليك ويكنين ابسيلاترال سوبيريور ريكتس ريسيشن مع كونترالاترال انفيريور ريكتس مسلز ريسيشنز. كconclusion, the management of trochlear nerve palsy depends on the etiology of the palsy. Surgical treatment, especially if the eye is symptomatic in primary gaze. You must be differentiated unilateral from bilateral fourth nerve palsy and congenital from acquired. Surgery to direct to superior oblique muscles or direct to superior oblique muscles in case with significant tendon laxity or when torsion is prominent problem. شكرا يا شباب. شكرا.
Thank you, Dr. Tariq. We'll move to Professor Iman Abdul Latif, Professor of Ophthalmology, Alexander University. She will talk to us about ocular inflammation tips and tricks. You can start, Dr. Iman. Thank you so much for your lecture.
صباح الخير على حضراتكم جميعا، وشكرا جزيلا للدعوة الكريمة. يسعدني دايما أكون مع حضراتكم كل سنة. النهارده إن شاء الله هناخد سيريز من عيانين اليوفيايتس اللي بنشوفهم كتير جدا، سواء من مصر أو من اللي بيجولنا بيشرفونا من الدول العربية. هو الكلاسيك بيشنت بتاعها بيبقى طفل صغير، عادة ولد، عادة صبي، ميل تشايلد، ودايما سنه هتلاقيه بيتراوح من حوالي 5 ل 10 سنوات. بعرفه على طول هو داخل العياده من شكله كده، حتى قبل ما احطه على الستيت لاب. علشان كده مصوره لكم بعض البيشنتس جروس بيكتشر بالكاميرا، حتى مش محتاج فوتو ستيت لاب. الطفل ده كلاسيك جدا، تلاقيه ولد وسنه من 5 ل 10 سنين، وتلاقي عين عنده كلير وكوايت وكويسنت، والعين الثانيه ريد انجري انجكتد مدمعه بينفول، ومش قادر يفتح في النور وكاسرها كده. كل البيشنتس اللي بعرضهم لحضراتكم انا بس بثبت في ذهن حضراتكم صوره الطفل ده عشان تعرفوا على طول او تلقطوا على طول. كلهم ريل بيشنتس حقيقيين، مش تكست بوك فوتوز، حقيقيين from my practice from my clinic. ده شكله تلاقي عين كويت and كويس انتوا ما عندوش فيها اي مشكله، والثانيه حمراء ومكسوره. ودي حاله مميزه جدا في البيدياتريك يوفيايتس، لان عاده البيدياتريك يوفيايتس ومن اشهر اسبابها الجوفينال ايديوباثيك ارثرايتس تلاقيها بايلاترال وكوايت سايلنت، قليل لما تيجي يونيلاترال، قليل لما تيجي انجري. نشوف صوره ثانيه كده، العين الشمال كوايت ونون بينفول ومش مشتكي منها خالص، واليمين حمراء دم. اخر واحده الطفل ده بص على عينه اليمين كوايت ساوند، عينه الشمال قافلها وموجوع وشاكي، وكل الناس وكل الاهل بتوعه ملاحظين ان الطفل ده عينه فيها مشكله. بيحصل ايه؟ بنلاقي في العيانين دي فوتو بقى سليت لامب، بنلاقي في العيانين دول ماس، عاده واحده، ساعات تبقى 2 أو 3، لكن ما بنلاقيهمش عددهم كبير، ناحيه الساعه 6 أو within 2 clock hours من الساعة 6، يعني بالكتير لحد الساعة 4 هنا أو لحد الساعة 8 هنا، insinuated بين الأيرس وبين الكورنيا، وساعات تبقى لازقة الأيرس في الكورنيا. وهقول لكم تيب دلوقتي في العلاج إزاي أتفادى المنظر ده، لازقة الأيرس في الكورنيا. ساعات يبقى معاها هايبوبيونس مع شوية هايفيما، ساعات تبقى عاملة moderate sized كيبيز، احيانا بيبقى معاها posterior segment inflammation. طب ايه حكايه الماس دي؟ لما تيجي تعمل لها الترا ساوند بنشوف منها اشكال كتير جدا، يعني كل دول different patients of mine. ساعات تبقى كبيره قوي كده واخده الايرس كله، ساعات تبقى صغيره limited ولازقه الايرس اهو في الكورنيا، احيانا تبقى صغيره واللوكالايزد للايرس لسه ما لزقتش في الكورنيا، لسه ما عملتش انتيريور ساينيكي. وعندي بعض الحالات بتبقى يونيك شويه، بتبقى قافله البيوبل، يعني بتبقى بريتشنج البيوبل كده اهو، لكن سايبه الانجل اوف ذا انتيريور تشامبر. دي عباره عن parasitic anterior uveitis، اسمها يعني ليها اسامي كتير، اسمها الرسمي او الاكاديمي presumed parasitic anterior uveitis. اول ما اتشخصت في الفلبين، وبعد كده اتشخصت في دول كتيره جدا. عندنا في مصر بقالي سنوات بشوف منهم مئات الحالات بتسببها التريماتود. يعني ايه التريماتود؟ يعني فلات ورم. التريماتود دي الكلاس، وبعد الكلاس عندنا فاميلي اسمها هيتيروفايدي، هيتيرو يعني مش شبه بعض. وبعد الفاميلي بتاعت الهيتيروفايدي عندنا جينس اسمها بروسيروفم. كل السبيشيز بتوعها كلهم incriminated او implicated في الحالة اللي احنا بنشرحها، لكن اشهر سبيشيز فيها في الجينس بروسيروفم اسمها بروسيروفم فاريوم. دي اكتر واحدة الدي ان ايه بتاعها اتعزل من الحالات دول. طيب السايكل دي بتحصل ازاي، والانسان بيبقى انفكتد ازاي، عشان نقدر نوعي الناس وننشر المعلومه الصحيحه عشان ما يجيلهمش الانفكشن ده، لان حياته كلها بتتقلب راسا على عقب بعد ما يجيله الانفكشن. البارازايت ده is a water borne parasite، بيحصل ان الديفينيتيف هوست عاده بيكون الفيش ايتينج بيردز، يعني البط بيبقى انفكتد، بينزل الاوفا بتاعته في الفيسز في الميه، بتطلع منها الميراسيديا وتدخل الانترميديت هوست الاولاني اللي هو السنيل، تطلع منه السيركاريا تدخل الانترميديت هوست الثاني اللي هو الفيش. المفروض السمك ده هياكله البط او الطيور المائيه. طب الانسان بيدخل في انهي مرحله؟ بيدخل كاكسيدنتال هوست مكان الديفينيتيف هوست الاصلي اللي هو البط. طيب بيدخل له ازاي؟ اكتر مرحله بيصاب فيها، يعني اكتر مود اوف انفكشن، ان تدخل في جسمه السيركاريا في البني ادم ده لما يعوم في الميه. عشان كده اغلب العيانين المصابين اطفال، وبالتالي بنقول للاطفال بلاش تنزل، او للاهل بقى بلاش تنزلوا الميه الراكده زي البحيرات والمصارف والترع. بس خلي بالك ان في مود اوف انفكشن تاني وان كان اقل شيوعا، ان الانسان ياكل الانفكتد فيش. علشان كده بنحث وبنشجع بلاش ناكل سمك مش مستوي كويس، وده اللي بيسبب يعني المود اوف انفكشن دي عن طريق اكل السمك اللي مش مستوي كويس، هو اللي بيسبب ان عندنا. بس انا طبعا عندي انا تشري بتجيني الحالات محوله، فاحيانا بشوف حالات فاريانس مش موجوده عند عموم الاطباء، يعني علشان كده عندي بعض الناس، ودي قليل قوي من اطباء العالم اللي شافوها، بيبقى ادلت وعنده نفس البيكتشر. طب ازاي؟ ما هو ما نزلش ترع ولا حاجه، هو اكل السمك الملوث. عشان كده لازم نسويه كويس، لان ده reported mode of infection. هاخد معاكم التريتمنت ميثودز وشويه تيبس كده وتريكس عن ازاي اصمم خطه علاج كفء للعيانين دول. اولا التوبيكال ستيرويدز مش افكتيف في اغلب الحالات. سيلكت البيشنتس اللي تديها لهم، واحسن ناس بيشتغلوا فيهم الناس اللي تلاقي الانتر اوكولار بريشر عندهم قليل. يبقى امتى ادي توبيكال في الناس دول؟ لما الانتر اوكولار بريشر بتاعهم يبقى قليل. السيستميك ستيرويدز مهمه، ادي على دوز نص مللي جرام بير كيلو جرام بودي ويت بير داي. يعني الطفل لو وزنه 30 كيلو اديله 15 مللي جرام بير داي. خلي بالك من النقطة اللي هنقولها دي، لما تيجي تسحب العلاج، يعني انت اديت على نص مللي جرام بير كيلو جرام بودي ويت بير داي، وهتيجي تسحب العلاج اسحب ب2.5، لأن القاعدة الأساسية في الويزدرول اوف ستيرويدز ان انا تحت ال 20 مللي جرام السحب الويزدرول التيبرنج يبقى ب2.5 مللي جرام بس، ما اسحبش 5، يعني ما خليش ابدا ال 15 10 هيركر العيان ده. السيستميك انتي هيلمينزك مهمين جدا، في كتير جدا موجودين في الماركت في الصيدليات. انا ما عنديش فاينانشال انترست، لكن خليني اديكم الاسامي عشان نساعد بعض. اشهر واحد وانجح واحد اسمه فيرميزول، لكن الفيرميزول لازم اعرف استخدمه ازاي عشان اخد منه اكبر فايده. بدي 3 سايكلز، 4 ايام ادي و3 اوف، يعني مثلا اديت العيان سبت حد 2 3 اوف 4 خميس جمعه، واعيد ده الاسبوع اللي بعده واعيد ده الاسبوع اللي بعده. بدي 5 سم 3 مرات في اليوم، 4 ايام اوف 3 4 اوف 3 4 اوف 3. ما ينفعش اقول له خدوا اسبوع وخلاص. لازم ادي كالسيوم سبلمنت. ليه؟ لان الكالسيوم ده، ودي يعني مأكدين عليها اساتذه التروبيكال ميديسن، الكالسيوم ده بيعمل كوكون، بيعمل شرنقه بتحوط البارازايت وبتحوش عنه الاميون سيستم، لان معظم الرياكشن والسيلز اللي موجوده في العين هي اميون رياكشن. يبقى لازم ادي كالسيوم سبلمنت، من غيره خطه العلاج ما بتنجحش. خلي بالك انك تبدا الكالسيوم سبلمنت 3 ايام قبل الانتي بارازيتيك، لان الانتي بارازيتيك هيكسر البارازايت فهيكسايت الاميون رياكشن. يبقى ابدا 3 ايام قبل الانتي بارازيتيك، واكمل 3 ايام بعد الانتي بارازيتيك، وال3 سايكلز اللي في النص بتوع الانتي بارازيتيك لازم افضل ادي فيهم كالسيوم. يبقى انا بدي الكالسيوم 4 اسابيع. الكالسيوم اللي موجود في الصيدليات حته براكتيكال كده نتعلمها مع بعض، في كالسيوم كربونات وكالسيوم سيتريت. اغلب الكالسيوم اللي موجود في الصيدليات هو كالسيوم كربونات بالبلدي او بمنتهى الصراحه لانه ارخص. الكالسيومات عباره عن كالسيوم كربونات، الاوستيوكيا كالسيوم كربونات، الكالسيوم دي 3 اف كالسيوم كربونات. مشكله الكالسيوم كربونات ان هو بيعمل جاسترو انتستينال ابسط، والابسوربشن بتاعه ضعيف. في ادويه قليله قوي كالسيوم سيتريت زي الكالماج، فده من افيد اللي انا بستخدمهم، بتديه مرتين في اليوم. كمان لازم تزود الانتاج بتاع الكالسيوم في الاكل، فدايما ودي احنا يعني شاطرين فيها ان احنا نقول له كل زبادي وكل جبنه طب ياكل انهي زبادي وانهي جبنه؟ اللو فات، لان كل ما الفات كونتنت بتاع الديل برودكتس يعلى كل ما الكالسيوم يقل. الكالسيوم دايما عكس الفات. اخر لاين هقوله لك السايكلوبليجيكس. من فضلك لو يعني انتوا غاليين عليا، لو انا غاليه عليكم ما تدوش سايكلوبليجيك. ليه؟ اولا لان العيان ده في الفيرجن كيسز، يعني قبل ما يعمل اي جراحات ما بيحصلوش posterior ساينيكي عاده، فانا ما عنديش posterior ساينيكي جامده. لكن لو اديت له سايكلوبليجيك بيشد الايرس لان بيوسع، فبيشد الايرس، بيقدمه هديه، بيسلم الايرس تسليم للجرانيولوماتيس انفلاميشن اللي موجود في الانجل هنا، فبيعمل بير شيبت بيوبل، والتشوه اللي في البيوبل ده بيبقى مدى الحياه ما بيتحلش ولا جراحيا. خلي بالك البوستيريور ساينيكي تبقى موجوده بعد الجراحات، يعني لو العيان ده عمل كاتاراكت سيرجري بيبقى لايبل للبوستيريور ساينيكي، لكن قبل الجراحات صعب يحصل له posterior ساينيكي لان الماس عاده قدام. والسايكلوبليجيك هتسلم الايرس، هتعمل كرامبلينج وكرمشه الايرس وتسلمها للماس اللي موجوده في الانجل، يبقى انا كده بشوه البيوبل بايدي. كل العيانين دول نصيحتي ليك دايما استعمل معاهم الكونسرفتيف تريتمنت which in my hands بيعمل نتائج ممتازه ممتازه، بس نستخدم التيبس اللي خدناها مع بعض. بلاش، نصيحة مني، بلاش أي تدخل على هوت آي، يعني بلاش أخد أسبيريت، بلاش أخد بايوبسي. التدخلات العنترية أو الاستعراضية دي للأسف بتنتهي بنتائج صعبة. عندنا يعني للأسف زميلة طبيبة في مصر يعني بتعمل بحث عن الناس دول وبتعمل أسبيريشن، الحالات بتجينا أتروفيك. خلي بالك دايما ان الانفلامد بيدياتريك اي الريسبونس بتاعها للسيرجيكال تروما غير متوقع، ممكن مره تعدي لكن كتير هيحصل اتروفي. بلاش، لو ده ابني انا هعالجه ميديكال، ابدا مش هاخد اسبريت واحلله والكلام ده، بلاش. اتمنى نكون وصلنا لرسائل. الحالات دول موجودين كتير جدا جدا جدا، بنشوفهم كتير. يعني اتشرف انكم لو عايزين اي explanation في اليوفيايتس، احنا عندنا يوتيوب channel حاجات موجوده عليها for free for everybody اسمها يوفيايتس made easy. وfor any questions this is my WhatsApp number. حاولت التزم بالتايم سلوت. Thank you very much for the invitation. سعدت بوقتي معاكم جدا.
Thank you so much Professor إيمان. شكرا جزيلا يا دكتورة، شكرا جزيلا. المحاضرة الرائعة. ألف عافية. للأسف وقت صلاة الجمعة قرب، فهننتقل سريعا للدكتور صالح الذيب. Case presentation conjunctival mass.
السلام عليكم. كده سريع بس على صلاة الجمعة. بسم الله الرحمن الرحيم. معلش نخرج شويه من البيدياتريك ومن اليوفيايتس ومن ناخذ كذا كونجنكتيفال ماس ككيس برزنتيشن. يا شباب طيب in highlight, as we all know, squamous cell carcinoma is the most frequent tumor of the eyeball. The most important risk factor, as we know, ultraviolet, which cause damage in repairing of the DNA. There are topical management protocol, and in patient with ocular or orbital invasion, the surgery is the gold standard of the care. Adjuvant therapy وهذه بنعملها مع أصحاب الأونكولوجي. طيب introduction in our case the conjunctival affection is the palpebral type. طبعا معنا palpebral معنا palpar والذي هي most common، لكن في البالبر type it is very rare which affected the palpebral conjunctiva. A discussion about the squamous cell carcinoma زي ما قلنا انه the most common malignancy of the ocular surface which are arising mainly from the limbus and rarely it can be arising from the palpebral conjunctiva. It is one of the extreme spectrum زي ما نعرف كلنا انه تكون على حسب الستبس، يا اما من الهايبربليزيا، ديسبليزيا، الOSSN، وتكون احيانا يا اما في الكارسينوما انسايتو لما توصل لمرحله سكواموس سيل كارسينوما. طيب في الليترشر about only 5 cases الذي هي documented in the palpebral squamous cell carcinoma، فبالتالي هذه حبيت اصر عليها لاني رير. طيب البرزنتيشن of our case an 66-year-old woman presented with a history of redness, lacrimation and painful swelling in the upper eyelid of the right eye. البيشنت طبعا الهيستوري از فيك شويه، بتقول 2 months. Refer to me as a discharge and painful upper lid swelling. On examination there was swelling in the right upper lid. Eversion of the right upper lid eye show a papillomatous growth over the tarsus which extending from the posterior eyelid margin. طبعا للاسف وحجمها كان كبير، يعني 2.5 في 0.7 في 0.6 سنتيمتر، نتكلم على سنتيمتر مش في الملي. طبعا من الهيستوري انه كان الفيجوال اكويتي في الافكتد اي تقريبا 20 هاند موفمنت، دخلت في شويه كومبليكيشن نذكرها شويه. الليفت اي كانت 70%، البيشنت كانت دايابيتس ميليتس فور ذا بريفيوس. نوقف شويه بس مع الصوره هذه، لو نلاحظ كذا بس لو نشوف لو نركز كذا على الماس هذه، لو نلاحظها كذا طبعا اغلبنا قد عمل اكسبوزد على الاشياء هذه في البابيلوماتاس، في السكواموس سيل كارسينوما. اي سكواموس سيل كارسينوما سبيشالي في البلبر ما بيجيب زي هذا البوزيشن. طبعا من حياتي المتواضعه كذا في طب العيون انا اول مره اشوف زي حاله زي هذه. طبعا ريفر تو مي فروم ون ممبر من الزملاء انه على اساس discharge in the eye. طبعا هذه الصوره عملناها اندر لوكال انستيزيا وذ ريتروفالبر. طبعا معنا الدكتور محمد القباطي البروفيسور اوف ثالمولوجي، بارك الله فيه، ساعدني كثير في هذه الحاله. للاسف نركز فيها شويه، نحاول لانه عملنا ايفيرشن في العياده ما استطعناش لاني سفير بينفول، فبالتالي اندر لوكال انستيزيا ريتروفالبر اند لوكال انفلتريشن اوف لوكال انستيزيا حصلنا هذه الصوره. طبعا للاسف هذه نلاحظها انه ايش فيك، يا اما ماس يا اما بابلوماتاس يا اما during surgery. حاولت اعمل كذا سيبريشن بليد 15، لاحظت ان في ايش جاب between the mass and the tarsus. هذا الذي شجعني اكثر اني اخذ ايش الوول اوف ذا ماس. طبعا excisional biopsy of the lesion was done under local anesthesia. طبعا confirmed by histopathology reported of squamous cell carcinoma. بفضل الله سبحانه وتعالى كانت كل المارجن 0.2 سنتيمتر to 0.5 سنتيمتر under local anesthesia. المارجن clearance were confirmed by post-operative histopathological examination. Margin of the excised tissue, الwall mass is excised. الحمد لله بفضل الله سبحانه وتعالى with ايش preserve of the contour of the upper eyelid. هذه during surgery. نلاحظ انه مع with the blade cutting of the wall masses. هذه البروجريشن اوف ذا سيرجري. طبعا histopathological examination disclosed الذي هي البابيلاري تايب اوف انفازيف ويل ديفرنشيتد، هذه بتفرق معنا كثير. سكواموس سيل كارسينوما showing infiltrating of island of malignant squamous cell with moderate cytoplasm hyperchromatic with clumped chromatin. A tumor was infiltrated into the desmoplastic stroma. However, there was no vascular or pre-neural invasion. الحمد لله هذه تعتبر يعني من الحالات التي هي سيف شويه، يكون فيها systemic association او systemic invasion، يكون لث شويه. البريفرال انتي مارجن زي ما تكلمنا are free of the tumor. هذه في الليتريتشر الفايف كيسز يعني وصلت لهذه المرحله. في معنا في الرايت ابر ايليد الذي هي حالتنا الموجوده في حصل وايد اكسجين. الان الحاله هي في الأونكولوجيكال سنتر في الجمهوري هوسبيتال. طيب الكومبليكيشن للاسف ما حصلتهاش في الليتريتشر. طلعت حاجه معنا كومبليكيشن الذي هي ايش؟ corneal perforated from the long standing pressure of the ocular mass او ocular surface which dealing by the corneal department in our hospital مع البروف الدكتور محفوظ، يعني مشينا على علاجات. طبعا هذه الصوره الاخيره الحمد لله الليد مارجن كوايت، بس معانا للاسف الكورنيا جبنا لها الميديكيشن والان بتابع بس قسم الاونكولوجي على اساس نشوف النتيجه. الورك اب افتر كونفيرم ذا diagnosis of squamous cell carcinoma by histopathologist. Patient must refer to the oncology center to complete other assessment about the degree of systemic affection and take the appropriate management. Conclusion: thus, squamous cell carcinoma of the conjunctiva must be considered as a differential diagnosis in elderly patient with unilateral chronic conjunctivitis. نصر على هذه unilateral chronic conjunctivitis especially في الelderly. في البالبيبرال ضروري ما نعمل ايش؟ differential diagnosis. في معنا one of the disaster tumors حصلتها في حياتي مره واحده مع المرحوم الله يرحمه الدكتور امل، الذي هو السبيشيوس جلاند كارسينوما. افتر سيرجري فعلا زي ما بتقول الليتريتشر البيشنت ستيل يعني alive just 2 years and died. الله اكبر. ثانك يو.
Thank you, Dr. Saleh. We move to the last lecture with Dr. Arwa Tal, case presentation.
Assalamu alaikum. My presentation today, I will discuss my case presentation. It's about thalamus hemorrhage and eye presentation. It's a neuroophthalmic case. And I will discuss some important points about the subject, similar case reports in 2 journals, and home message. Okay. في مشكلة في ال أيوة هو اليمين. The patient was a 55 years old male patient, came with a history of sudden blurring of vision of both eyes since 2 days. It was associated with right temporal headache and radiating to the right forehead. Patient was free of any known systemic illnesses. The patient is not smoker, nor cat chewer, not taking any medications, no history of trauma. It was the first time to have a problem in his eyes. The examination, the patient looks healthy, oriented, no abnormality, and there was no any abnormality in his speech nor gait. The visual acuity, the right eye was 6.9, the left eye was 6.6. The external examination was normal, ocular motility was normal. The pupil and intraocular pressure was also normal. The fundi, the only pathology is arterial attenuation, and the optic discs were normal. The investigation, blood pressure is 160/100. He was accidentally discovered hypertensive. The lipid profile was hyperlipidemia. Other investigations were normal. I referred the patient to cardiologist consultation. There was no cardiac problem. Anti-hyperlipidemia and antihypertensive medication were given. The patient feel improvement in his vision after a few days of medication. After 1 week, he starts to again complaint of blurring of vision and doing mistakes when write messages in WhatsApp. This was his complaint. This is the visual field. It's clear that there is a central scotoma and some changes in the left visual field. طبعا السنترال scotoma can be happened if there is alteration in cerebral blood flow if we didn't detect any ophthalmic cause. The brain CT scan reported intracerebral acute hematoma in the posterior aspect of right thalamus with surrounding faint edema. Few old lacunar infarctions in periventricles and basal ganglia on both sides. The largest one in the right measuring about 4 millimeter and old infarctions in the brainstem associated with mild diffuse brain atrophic changes. So it was a serious problem. This is the CT scan and this is the right acute thalamus hematoma. I referred the patient to a neurologist and he did his best and the patient started to improvement. This is the new CT scan and he started to improve and he will follow us. He needs follow-up after 3 months. طبعا التhalamic hemorrhage, 1/4 of intracerebral hemorrhage cases are thalamic hemorrhage. Hypertension is the most important risk factor. The mortality rate among patients with thalamic hemorrhage is high. One reported case of sudden vision loss due to a thalamic hemorrhage. Studies reported that the most striking initial characteristics of thalamic hemorrhage to be hemiplegia, hemiparesis, and contralateral sensory deficit, vomiting, headache, oculomotor disturbances, and neurobehavioral disturbances. He was lucky patient and accidentally discovered. The sensory deficits and oculomotor signs and language disturbances are 3 of the most reported clinical signs of patients who survived. There was only 2 journals I can find same case. This is Annals Neuroscience, reported 1 case of a 45-year-old hypertensive patient presented to the emergency with sudden onset of severe headache, vomiting, confusion, and visual loss. The MRI reported large hematoma in the posterior part of left thalamus, a right visual field hemianopia, no motor or sensory affection, and was reported as unique case of large thalamus hematoma presented with visual field defect. This is another Turkish magazine reported a case of 46-year-old hypertensive patient and coronary artery disease presented to the emergency with a sudden incomplete visual loss. Neurologic examination reported reveal minor dysarthria and paresis in the left upper extremity with mild hyposthesia. The ophthalmic signs, nystagmus and bilateral right quadrant anopia. CT scan reveal right thalamus hemorrhage. And the visual field, يعني لاحظنا it depends on the size of hematoma and location of hematoma. In our case, it was central scotoma and left visual field defect, and the complaint was very simple. The home message, these cases are life-threatening conditions. You can see these cases and you can miss it. Just many life-threatening conditions can be presented in an ophthalmic clinic, and history is very important as examination. And teamwork with other specialties is important to reach diagnosis.
Thank you so much, Dr. Arwa. And thank you for all the distinguished speakers, Professor Nihal Shaqanqiri, Professor Yaman Abdul Latif, and all the other speakers. Thank you so much. نختم الجلسة إن شاء الله وشكرا جزيلا.
شكرا.
يا الاخوه الزملاء والزميلات الصلاه في خارج في المسجد ها، وبعدين الساعه 2 السكند سجن ها. ايوه الزميلات يقدمون اكيد هنا تمام.
شكرا جزيلا دكتور ايمن، شكرا جزيلا.
شكرا يا فندم،
مع
شكرا
السلامة.
شكرا جزيلا، مع السلامه.
الو يا بنات، نصور لو تسمحوا، نصور. تعالوا تعالوا نصور الاول بعدين تروحوا تردوا. تعالوا.
ده بعد لو ما ترجع افرض المكان اول ما تدخل محمد.
يعني شو هذا بيطلع بي
ليدي
ماما شوفها
اغني
صوتك حلو أبو
انا خايفه على الجماعه يعني.
سارة عروس عندي بس بحكي بعد عنصر الحل بس بحكي مرحباينا 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 شنو النظارة غمضين يعني غمضين خلاص خليني بالنظارة غمضات كاملة ولا نسوي كامل؟ ايوه احسن اهم شيء يعني مش مغمضات لحظة وانا شايفة هناك جيبي لي رقمش علشان ترسلي لي الصور. عارفة لو في تعديل قولي لي. لكن صور الميل على فكرة تطلع ايوه في ميل عين مغمضة مش عارفة ايش ايش؟ ما بحاجة على خلاص ابتسم اعمل ايش؟ اني اتوتر من الكاميرا شوي. يعني مغمض عينك من الأم I can هذا عادي تماما. واضح اللوجو أهم شيء. هي البطارية اشتغلها. طيب ها ليش تعمل على البوزيشن كلها؟ ما في شيء ما ظهر متنمرة. لحظة عملت فيها ولا؟ يبان صفحة لا يبان من عيون الثاني من كذا كذا الأمر. مشكلة عيوني هذا ها ايوه اكيد. ايوه انا اول شيء وحدي بعدين كده مع بعض. ها دور هذا خلينا حلو. ملايين تمام يحسن بدأ مش ما بالطوارئ مش تمام. ايوه كده حسيت ما ادري كذا وانا هناك وقاعد اطير لما خلاص جيت كلها لا بس اليوم ساعه لا شيء اليوم بدينا من 3 عشان 1 2 3 يعني لا تشتغل 3 يعني بس هي فوق مش العدد ده. عيونش تمام. مع اللوحة عمر قولي لي أيام أنت. قولي بسرعة الوقت. ولا حد مداني ولا حد. لا حسيت من نفسي يعني خليني أصور البنات وارجع أخبرك. ليش؟ كان البنات في صفحتي بعدين عادي. عم تدخل حلوة. مش غريب يعني. مش طبعا. طبعا. اسمعي بس مش قوية كذا. مش قد ياخذ. طب كيف أفعل؟ أنا تقول زمان يعني. طب كذا يمكن لو كيف أفعل؟ كنت أول كيف أفعل يعني. كيف كذا فعل طيب كيف اسوي؟ علميني كيف مصوره حقتي. انت ايش تشتي تبين؟ هالشي كذا يعني تكون كذا صوره فخمه ممكن انزلها واتساب كذا ممكن يعني كذا فعل مع الجمعية. كيف افعل؟ انا كنت هذا يوجعني والله من الابتسامه. كيف أصلي؟ يعني ما بديش حق من كيف أسوي؟ كيف أنت تقولي لي تقولي لي ايوه خليها عادي كذا لا
نعم. حقهم حق حقهم المريض. على الصورة في بعد أين غداؤنا؟ أي باب؟ أي باب؟ كما غدينا أمس. يلا يلا. يا حميد.
وانا واحنا نتغدى. طيب من عندكم للمعدات.
يا بدي دهنا في اكلنا ايوه لا في كثير يا ولدي ما بش هذه تتغدى غدا يا عاد لسه دي يا اخي دي مالك انا كلب
لا هو قصة انه فيها ياخذ حق الاكل.
ما ينفع عادي نشتري
لا هي لحالك يعني في مجموعة.
مش طالعها هيا يلا
عليه حركات بس الحركات لا اظن ما كانت الصورة واضحة يعني.
لا على اللعبة
مش سهل.
صوفيا
ايوه
مش متقدم
مع التاسع. خلت صوتيات ما عندنا صوت.
ما احنا بنتعود مؤتمر فاصل. خالد عبد الخالق
من الفريق فريق التنظيم.
أنا عم بيغطي وهذا يكتبوا ده.
خلاص الآن شكرا.
الله. طبعا التحليه ولا حتى الغداء خلاص اللي بيخرج الاكل ويقول لك هو بالتالي بس والله مش عارف مش عارف بس مش عارف ما راح ادخل حتى ما قلتلوش حلا حلا عندي صح ماشي بعدها
Dr. Milan, can you hear me?
Yeah, hi. I can hear you. Can you?
Fine. Nice to see you again, sir.
Yeah, hi. How are you?
Fine, sir.
Wonderful.
Yeah, we'll start within 2 to 3 minutes.
No problem. I'm ready. Webinar start. I'll call them.
So, good afternoon, everyone. Now we will start the oculoplasty session. We will start with Dr. Milan Naik. He's an senior consultant at the LB Prasad Eye Institute, Hyderabad. He's also an associate professor at the University of Rochester, United States. He's the current secretary of the Oculoplastic Association of India and one of the stars of oculoplasty in whole India. This session will be an eyelid reconstruction.
Hi, thanks, Marwan. Can I share my presentation?
Yes, please.
Okay. So a very good evening to everyone in Yemen, and it's my honor and pleasure to be a part of your 6th Yemeni Ophthalmic Society conference. Just before we begin, I would like to introduce to you all someone whom you already might be knowing, and that is Marwan. So Marwan spent 15 months with us. He was rather a very experienced clinician already when he came to us, and his surgical skills as well as his clinical acumen was already impressive, and we only did a small bit of sharpening that further while he was with us in terms of surgeries, clinics, as well as training sessions such as these. And he turned out to be a wonderful graduate of our institute, excellent surgical hands, and much of what I'm going to say today is something which he has seen, assisted, and is quite capable of doing these things. So I'm glad that Yemen now has a very accomplished oculoplastic surgeon amongst you. So some of these cases, Marwan, you're going to recollect as we talk. So eyelid reconstruction, I purposely wanted to go beyond the usual. And these are the standard indications for eyelid reconstructions, either congenital defects, trauma, tumors, or even late presentations of trauma. And all of you must have heard the pentagon excision and the cutler beard and the tensile, but I wish to talk about many other options which are beyond these. And I guess that you all might require some of them when you manage these patients. So the minors, let's talk about the lamellae first. This eyelid reconstruction can be thought of in terms of lamellae. So you could have lesions which are only posterior lamellar. There are others which are marginal, which can be technically called as bilamellar. Then there are other lesions which are only anterior lamellar. So talking about all of these posterior lamellar lesions, you just have to excise it, and the posterior lamella can be left to granulate and epithelize, and nothing much is needed when it is small. Here is a marginal lesion. With these kind of lesions, you can either think of a complete pentagon excision if the lashes are also missing, or if the lashes are intact, you might just do a simple shave biopsy, which is much easier and very well appreciated by the patient. Here is another example of a shave biopsy of a lesion which is only involving posterior lamella. Anterior lamellar defects such as either the verrucae or a basal cell carcinoma or small little warts, these can only involve skin excision or skin with the underlying orbicularis. When you have lesions which are around the canthus on either side and they are less than 5 millimeters in their diameter, you can actually leave them to granulate, and that's a better way of healing than trying to close it and cause dog ears. Here is an example of a small wart which was excised, and rather than stitching it, we just decided to leave it to granulate, and it healed well. Similarly, anterior lamellar lesions can either be excised if they are small, or if they are larger, you can perform a skin graft or even a monopedical flap, as we will talk ahead. I want to bring to your notice something which is very useful, and it's called a sliding tarsal graft, and I'll describe that with an example. Here is a patient with a right upper eyelid sebaceous gland carcinoma, and it involved the medial third. So obviously when we excised, practically his medial half of the upper eyelid was missing. So we measured that defect. We everted the remaining lateral part of the eyelid. We left the marginal 4 mm and took the remaining tarsus from that remaining eyelid. We removed that tarsus, placed it on a hinged flap of conjunctiva, and shifted it into this defect. So that is how we brought the posterior lamella into place. And that tarsus was sutured in this defect. And then we had some extra skin in the form of blepharoplasty, which was removed and which was again sutured in 2 small bits and pieces to cover the anterior lamella. So posterior lamella was a flap, anterior lamella was a graft. And here is the patient a couple of weeks down the line. You can see the tarsus well taken. It came from the lateral half, and the skin also is well taken. Only thing you have is loss of lashes in that area, and even his eye closure is very good. So this is a very good option when the remaining half of the upper eyelid is available for you to share the eyelid, and this also prevents the tumor transmission to the lower eyelid had you chosen a cutler beard, for example. Another case of sebaceous gland carcinoma, which is very common in India. So you have lost not only the upper half of the eyelid, but also the lateral canthus, part of the lower eyelid. So here, what we did was an open Hughes, we call it. Why open Hughes? Because we took tarsus from the upper eyelid and we shifted it laterally to fill the defect. And you can see in this picture here that the posterior lamella came from the remaining medial part of the eyelid. And this skin was simply rearranged. We just took a vertical incision and just pulled the skin down. So that's how it healed in the initial phases. And this is the lady 6 months down the line. So you can see fairly good closure. There is a very mild nocturnal lag. Lashes are of course absent in the lateral half, but she's doing fine and is tumor-free. Open Hughes flap is something that we do for cases where the tarsus is entirely missing, even in the upper eyelid. Now here you see a melanoma in the lower eyelid. Practically 4/5 of the lower eyelid is lost, but vertically the defect is very shallow. And we took a Hughes from the upper eyelid and a skin graft on the anterior lamella. That is how she looked immediately post-op. And this is after a couple of months of recovery. You can see a very good cosmetic benefit out of the Hughes flap. Now you can also do monopedical flaps which come from the upper eyelid. This lady has basal cell carcinoma involving the lower eyelid margin, and it is practically involving the entire eyelid margin. So our excision area was quite wide. And we decided to take a Hughes flap for the posterior lamella and an anterior monopedical flap. So in monopedical flap of the skin, we hinge it on the lateral aspect. So you can see that here we took a periosteal flap to support our Hughes flap. Hughes flap came from the upper eyelid. That is sutured in place, so posterior lamella is in place. And this is your monopedical skin flap. So it is hinged laterally. It's placed like a blepharoplasty incision, and then it is transferred into the lower eyelid. So this is how it looks immediately post-operatively. 1 week later, this is after partial release of it at 2 weeks. And this is how she looks 6 weeks post-surgery. Good cosmesis and good functional outcome. Monopedical flaps are also used along with Hughes for patients who have traumatic loss of the entire lower eyelid coloboma. And couple of cases of complex defects and total eyelid reconstructions. Here was a basal cell carcinoma involving the entire lower eyelid. And this was his defect after the excision. The vertical height of the defect was very high. Obviously, a cheek rotation flap could have been considered, but we looked at something that is more local. So we raised a periosteal flap, then a Hughes flap to construct the posterior lamella. And then we thought of many other options, either a monopedical flap from the upper eyelid or the Frick flap from the temporal region. But we eventually chose a combination of monopedical flap from the upper eyelid and a preauricular skin graft. And this is the patient immediately after the surgery. This is a couple of weeks post-surgery before we release the Hughes flap, after release of Hughes flap, and 6 months down the line. So he still has a good functional cover of the eye, and we managed to repair a very complex lower eyelid defect. Another lady with a BCC involving lower eyelid and canthus. And in her case, we did a Hughes again, and we took a Frick flap coming from the temporal region. And this is how she is immediately after the release of the flap. Again, a good functional cover of the eye. Another basal cell carcinoma, lower eyelid, again, Hughes flap with a reverse Frick flap. So the Frick flap was actually coming from the cheek region rather than the temporal region. And you can see fairly good functional recovery and cosmetic correction. She's still in the phase of healing. Probably this cheek skin is a little thicker for the eyelid, but functionally she's stable. A very large sebaceous gland carcinoma, and this obviously after the excision left a very wide defect right up to the bone. So here, posterior lamella still was possible to be reconstructed using a Hughes flap, but for anterior lamella, we raised a midline forehead flap, and this is how we looked immediately post-surgery. This is before the release of his Hughes flap, then the Hughes flap was released. Then we also revised his pedicle base, which was a little thick as usual, as expected. And this is how he looks after both the stages. And good cosmetic cover of the eye. Functionally, the eye is stable. An upper eyelid BCC, where we did not only a cutler beard, but also a globular flap. So we combined two flaps to give complete cover of the eye. And here she is, a couple of months after the surgery, with fairly good cosmetic outcome. Another basal cell carcinoma in the medial canthal region, which was again excised. And here, if you see the defect, we tried to take an incision along the nasolabial fold and pulled up the defect to close it completely. So that's how she looked immediate post-op. So there are multiple options around the eye to think and innovate and follow the Langer's lines and still give the patient a good functional and cosmetic outcome. A couple of pictures talking about trauma. Laceration, whenever you see a fat prolapse, always think of a levator injury. Here is the patient fairly well recovered from the laceration, but you can see the ptosis is persistent. So he'll need a separate lid repair or a ptosis repair as a secondary procedure. Tear ducts have to be intubated with the Monoca or the lacrimal intubation set. Here is an avulsion of the eyelid, which requires complex repair. You have to put back the levator, the canaliculus has to be intubated, and the marginal tear also has to be sutured. Another example of the same. And periocular trauma, whenever you have complex abrasions, it's always good to just wait, especially if the cornea is well protected. So a couple of months down the line, you get a fairer idea of what reconstruction is actually needed for this patient. So here we just did a huge flap. We just did a lower eyelid skin graft, and he recovered very well. Complex dog bite injury, which was again treated with repair. You can still see some telecanthus, which needs care, but the pupillary axis is clear, which was more important at this age. Sometimes lid repairs can also be clubbed with bony repair. Here was a zygoma unattended fracture with malunited eyelid. So we tried to do what was best possible with the fracture as well as the eyelid reconstruction. Some occasional late sequelae here. If you measure the length of the eyelid margin from canthus to the cut edge, it's actually as much as the other eye. So all we did was to replace it back in its position. It did not require any kind of flap or a graft. Similar case again, the eyelid was united in a wrong position. We just had to put it back in place. So just to summarize and give you an overview, we all have learned enough about the direct closure, the tensils, and the Cutler-Beards. But there are several other options beyond that, and you can sometimes combine these. You can even innovate on table as long as you follow the surgical principles to try and give the best result for your patient. Thank you so much.
Thank you so much, Dr. Milan. Ayasila, any question? So we can move to the next presentation.
Thank you.
Yes, welcome to Dr. Nandini Podra. She's here with us. Hello, Dr.
Yeah. Hi, am I audible?
Do you hear me, please? Okay, welcome, Dr. Nandini Podra.
Hi, am I audible there?
Dr. Are you hear me?
Hello?
Hello, yes. Welcome, good evening, Dr.
No, I am unable. Yes. So,
okay,
I
please.
can hear Nandini, I can hear you.
I only can't hear him. Now am I audible?
Yes, yes, yes.
Yes, so I'll just share my screen.
Yes, you will represent for us external DCR video conference. Thank you for your participation with us. Please start.
Yeah. Okay, I'm just trying. Is my screen visible?
Hello, Doctora, yes. Yes,
Yeah,
start, please.
خرجت.
هو بالانجليزي كده. Hi, Dr. Nandini. How?
Okay. Extremely sorry for the thing. I think the system sort of shut down. Is my screen visible?
Yes. Yes.
Yeah. So my topic today is to just demonstrate external dacrocystorhinostomy. So as we can see, this patient right eye is showing Rho+ positivity. So the first step is we just mark the incision. Now there are various places where the incision can be made. We prefer to do it at the anterior lacrimal crest because right in this area is where your lacrimal sac is located. So now different blocks that we have to give during the surgery include the infraorbital nerve block, then the infratrochlear nerve block, which is given between the glabella and the superior orbital rim. Then we give the ethmoid nerve block for the anterior and posterior ethmoidal vessels. We go transcaruncular and inject about 3 ml, after which we infiltrate the area of surgery and then give a dorsal nasal nerve block. After that, we use a little bit of lignocaine jelly on a earbud and we put a little bit of jelly into the nasal cavity to anesthetize the nasal cavity before we insert the nasal pack inside. What is important is the position of the bud. You can see the position of the bud is almost parallel to the face. It is not going perpendicular to the face. If we actually go perpendicular, we are going along the floor, which is not the area of surgery. So we have to make sure that we are parallel to the face or parallel to the floor. And then a nasal pack is inserted. Now, after that, the incision that we had marked, we will make an incision on the skin. And then using the tenotomy scissors, we separate the orbicularis. Now at this stage, put the cat's paw in between the separated orbicularis and the attached orbicularis. Go ahead, hit the bone and again separate the orbicularis till the bone is visible. And then a periosteal incision is made. Now, as you can see, that white part, the white portion which is visible is actually the bone. And now we are separating the periosteum superiorly as well as inferiorly. Now this periosteum is separated till the anterior lacrimal crest. This is the anterior lacrimal crest, the one which I'm showing right now. And the one, so between the anterior lacrimal crest and the sac, we put a little bit of gauze piece. It helps in 2 ways. It helps to achieve hemostasis and it also separates the sac from the lacrimal sac fossa. Now, we pierce the bone in the area of the lacrimal bone and then using the rounger, we start the osteotomy. So the osteotomy has to be continued in such a way that the entire sac is completely exposed to the nasal cavity. So what are the endpoints of osteotomy? So once we know inferiorly, the point that I'm showing right now is the junction of the sac and the nasolacrimal duct over here. So that is the inferior endpoint of your osteotomy. If you see inside, you can actually see a small part of the nasolacrimal duct over here. Yes, that is the nasolacrimal duct. So we need not go much beyond the nasolacrimal duct. That is the inferior endpoint. The anterior endpoint will be until we can insert the rounger between the mucosa and the bone. So that is the most anterior and inferior that we can come. Now, superior endpoint would be when you insert a probe into the sac, at least 5 millimeters above the common canalicular junction should be the endpoint of your superior osteotomy. Now, over here, if we observe, you can see 3 different types of mucosa. I will just focus on it. Right. So this is your lacrimal sac. This white mucosa is your ethmoid mucosa, and the pinkish mucosa is your nasal mucosa. So once your ethmoid is exposed, you know that you're close to ending your superior osteotomy. That is nearly the end of your superior osteotomy now. Now we are just smoothening the bone out here so that the mucosa doesn't tear off when we try to pull. Now both the puncta are dilated, and although we know that we have done a osteotomy which is more than enough, but still to confirm whether it is enough or not, we will insert a probe and see that at least 5 to 10 millimeters above the insertion of the probe, there should not be any spare bone left superiorly. So now inside, if we look at it, over here we see the probe indenting the sac, and we do not see any bone in its vicinity. So this much amount of osteotomy is more than enough for a good outcome in a DCR surgery. Now we go ahead and make a H-shaped incision on the lacrimal sac. So we use a 11 number blade to incise the sac, and then we use conjunctival scissors to extend this incision superiorly and inferiorly in order to open the sac in its entirety, in toto. So that is the superior incision and the inferior incision. And now we make the H, that is the flaps, the vertical incisions on the anterior and the posterior sac flaps. So now after we've made this incision, that is our anterior flap. We can see the probe coming in freely. And below the probe is our posterior flap. So similar incisions, the vertical incisions that we made on the anterior flap, we will make similar incisions on the posterior flap, just so that we ensure that the posterior flap just falls behind. There, that is our posterior sac flap. Yeah. So now similarly, so the posterior and the anterior flap and the posterior flap. Now similarly, we will make a H-shaped incision onto the nasal mucosa. So we lift it, we give a cut with 11 number blade, and then extend it on either side using conjunctival scissors. Now, this is very important that we make sure no damage is done to the septum or the underlying middle turbinate. Because if during this incision, if we damage the septum or the middle turbinate, then there is a high chance of synechia formation. And that is one reason why we may have a bad outcome. So that was the anterior nasal flap. And similarly, now we will make the posterior nasal flap. Now, we strongly believe that both the posterior flaps should be we should actually make an anastomosis of both the posterior flaps. So first we apply MMC and leave it inside for about 3 minutes. That is 0.02%. And after 3 minutes of MMC application, we use 60 vicryl sutures to suture the posterior flaps. Just a single suture through the posterior flaps is generally enough because we just want both the flaps to oppose end to end. So we can see that there is a good end-to-end apposition of the flaps. And then we do a bicanalicular stent intubation. Now this is an optional step. When you have flaps which are this formed, you need not do a bicanalicular intubation and you can directly suture the anterior flaps. But in case an intubation is planned, yes, a bicanalicular intubation is done before suturing the anterior lacrimal and sac flaps. So for bicanalicular intubation, we use a suction cannula through the nose and we push the intubation into the suction cannula and just withdraw it from the nose. So this is a much easier option and it is least traumatic. The other way to withdraw the intubation into the nose is to use an artery forceps through the nose, grab the bodkin into this cavity, and then pull out the bodkin very gently through the nose. Now, once the intubation is complete, we will go ahead and suture the anterior nasal and the sac flaps. Now, when we suture the anterior flaps, just the apposition in the center is not enough. It is preferable to take a center, anterior, and a posterior suture. So better to take 3 sutures so that we have a nice end-to-end apposition of the anterior flaps. And if your flaps are too loose, 2 ways. One is to trim the flap before suturing, or second, if the flap is not trimmed, then we can anchor it to the periosteum or the orbicularis. So this is the anchoring suture. After we take the 3rd bite, we anchor it or suture it to the orbicularis so that it doesn't fall back into the ostium. And then the skin and the orbicularis is sutured using a 6-0 vicryl. So that is the end of surgery. If there are any questions, then I can take them.
Thank you for your presentation. Thank you very much. It's very interesting. Any question from our audience? No question.
Yeah, Dr. Nandini, they are asking about the rate of failure of DCR.
So if the osteotomy and the flaps are correctly made, the rate of failure is less than 2%. So at least in our hands and in our studies, we have shown a 98% success rate with external DCRs as well as with endoscopic DCRs. So once we understand the anatomy and we achieve a good osteotomy with good flap apposition and good, actually a good mucosal flap, and we make sure that they are opposed. So we have a 360-degree mucosal cover, then the chances of failure are very, very less.
Any other question? No more question, Dr. Nandini. Thank you so much for your video. Nice to see you again.
Thank you. Thank you so much. And thanks for the opportunity.
Thanks. We are moving to the next presentation with Dr. Swati Singh. She's a consultant ophthalmologist at LV Prasad Eye Institute. She's a pioneer in the field of dry eye and ocular surface disease. Also, she is an excellent and pioneer surgeon in the field of eyelid malpositioning. Welcome, Dr. Swati.
Thank you, Mawan. So nice to see you. I think first time we are seeing you in the suit and dressed up and all. Okay, so thank you so much to all the friends out there and the Yemen Ophthalmology Society. I'm going to take you through approach to an entropion case, mainly focusing on to the cicatricial entropion variety. So I'll be discussing about the anatomical concept, the classification of different types, etiopathogenesis, how can we make the good decisions, and few of the surgical approaches that you can use. As you must be versed with the eyelid anatomy, that we have essentially, when we talk in terms of entropion correction, we talk about anterior lamella and the posterior lamella. Anterior lamella is composed of skin and orbicularis. It has these eyelashes which are embedded into the orbicularis. And then in the posterior lamella, you have a tarsal plate as well as a conjunctiva, along with the levator and the retractors in the lower eyelid. So most of your lid malpositioning surgeries and other things, they operate in this field, in the area of anterior and the posterior lamella. Now, this is how a normal eyelid should look like. The eyelashes are well away from the globe. The posterior lid margin is sharp, is well abutted to the ocular surface. And if you look, the meibomian gland openings are seen onto the posterior lid margin beyond the gray line. Now, these are the two gentlemen I'm showing to you. If you see on the picture on your right, you see that there's a corneal scar. He sustained a severe chemical injury. He has all the eyelashes which are stuck onto the ocular surface. They are turned inwards. There's a tarsorrhaphy in the place. And if you look at this gentleman, he has eyelid retraction in the right eye and the lashes are coming in the field of superior cornea. Does he have any sort of entropion? And would we operate onto this gentleman who just has lashes which are now little ptotic? So it is very important to differentiate between the various lash malpositions as well as the eyelid malpositions. So if you see this gentleman which I was showing you earlier had lash ptosis, the lashes are not turned inside. And practically you are going to operate in a patient who has lashes which are rubbing onto the cornea. If there is a small amount of migration of the posterior lid margin, you will not offer any kind of surgery. And patients are usually not symptomatic for that. But you will definitely would advise surgery in cases these eyelashes are rubbing inside the eyeball onto the ocular surface, which is a frank entropion. And many times there can be only trichiasis where the lashes are turned misdirected, but the lid margin, the posterior lid margin is in normal position. Okay. So the different types of entropion that we see in our practice are involutional, cicatricial, congenital, and a spastic form or a complex form. Now, this is a lady who has lower eyelid, left lower eyelid involutional entropion. You can see if you compare it with the other eye, you can very clearly see that there is a kind of a swollen appearance of the lower eyelid. So this is what orbicularis is overriding onto the tarsal plate. So the preseptal orbicularis is going over the pretarsal and turning these lashes inwards. The etiology for this could be the dehiscence of the retractors of the lower eyelid. There could be just orbicularis hypertrophy and overriding, or they can be associated horizontal eyelid laxity because of the age. Many times when you see these patients who have lower eyelid involutional entropion, sometimes the lid margin position looks absolutely normal. So in those cases, you can ask them to do a squeeze test. You ask them to squeeze their eyelids tightly and the orbicularis will start overriding. Another important test for entropion evaluation is eyelid laxity. So how do you test it? It's a simple snapback test or pinch test. When you pinch the lower eyelid skin, and you have to measure the distance it goes beyond the bulbar conjunctiva. If it goes beyond 5 mm, that means this eyelid is lax. Snapback test means you pinch and you release it. How quickly it goes back to the globe. Immediately after a blink. If it goes after a blink, it means there is a laxity. Lateral distraction test is as shown in this picture, where you just pull the lid laterally and see how far your puncta goes. That indicates the laxity of the medial canthal tendon. So Preoperatively, it is very important to assess the degree of laxity because it will direct what kind of surgical procedure you will perform in these eyes. If there is a very severe laxity of the eyelids, then you'll have to tighten the eyelids. So you will opt for a lateral tarsal strip or a medial canthal tendon tightening. If there is simple orbicularis overriding, you can do a straight Jones procedure. So as I said, if it's a mild eyelid laxity, a simple Jones procedure is enough. If it's a significant, then you might have to do a lateral tarsal strip or a pentagon resection followed by canthoplasty. This is the same lady on whom we did just a simple Jones procedure. I think Marwan did this surgery where we just make an incision into the beyond the lash line, and you separate the orbicularis, attach the retractors, and again close the incision with the interrupted suture. So you can see how the scar prevents the overriding of the preseptal orbicularis onto the lid margin, and the lid margin is beautifully sitting onto the ocular surface. Many times, elderly population do have an amount of laxity in the eyelids. So in unilateral cases, you should compare with the other eye. If the other eye is lax and the level of laxity is similar in both the eyes, then just do a simple Jones procedure. That will be enough if you see this kind of bulge. If the laxity is very significant in these eyes, then you might have to combine it with lower eyelid tightening procedures. Next is cicatricial entropion patients, which we, being a tertiary referral center, we get a lot of patients who have cicatricial entropion secondary to chemical injuries, Stevens-Johnson syndrome, ocular cicatricial pemphigoid, or could be simply because of pseudopemphigoid because of chronic use of anti-glaucoma medications. So in these cases, it is very, very crucial that you examine the lid margin as well as the fornices. So this is a gentleman in the top panel. You can see that the left eye has significant severe cicatricial entropion. When I lift the eyelid, you can see symblepharon formation. And the tarsal plate is very much attached to the superior bulbar conjunctiva as well as the cornea. And he sustained chemical injury grade 5. If you look at the below picture, this patient has severe cicatricial entropion with the status post Stevens-Johnson syndrome, and he cannot even open his eyelid because of the severe eyelash irritation. And this is him after we have done mucous membrane grafting for both upper and lower eyelid along with entropion correction. So these cases are very, very severe and complicated cases where you need to opt for an extra graft procedure along with your routine entropion correction. I'll take you through a case of a lady who had Stevens-Johnson syndrome in 2006. She was wearing these scleral contact lenses in both the eyes. You can see the clearance of the limbal vasculature. In 2016, at presentation, her vision in both the eyes with pros lenses was 20/40. She had dryness in both the eyes. Then she was managed with a simple procedure of, she has cicatricial entropion, and she was managed with anterior lamellar repositioning in both the eyes. At 6 weeks, she had recurrence of the entropion in exactly same location in both the eyes. Then she was again advised to do a repeat entropion correction, but she refused and she continued wearing contact lenses. 5 years later, she came to us with lenses in place and severe cicatricial entropion in both the eyes and a very poor vision. These are her photographs of 2021, where you can see the everted upper eyelid and the bulbar cornea and the bulbar conjunctiva shows a severe degree of scarring and vascularization. There is a symblepharon formation in the inferior fornix, and there is a significant shortening of the fornices. Now, in these patients, whenever you see cicatricial entropion, one thing which you should look for is keratinization of the lid margin. Here, if you look on the slit lamp, you will see that this posterior marginal conjunctiva has become skin-like. It has become keratinized, and it rubs onto the cornea. It induces a lot of keratopathy over there, and it damages the vision as well as the ocular surface. So this is how the changes have progressed in both the eyes. What we did for her was we did anterior lamellar repositioning. In this, we split the anterior from posterior lamella. We reposit the anterior lamella, and then we placed a graft over the bare tarsus, the lid margin, and the keratinized segment. This shows the keratinized conjunctiva. So I'll show you a surgical video, a short surgical video of the procedure that we have devised now based on our findings. For all severe cicatricial entropion cases, now we make this procedure as a uniform standard of care. Here you make a gray line incision. You split the anterior lamella from the posterior lamella throughout the length of the tarsal plate. Once you have split it, you can see some of the eyelash root might be embedded in the tarsal plate, so you remove them all. And then you remove the keratinized conjunctiva from the posterior lid margin, which is going to otherwise, which was rubbing onto the surface. So you have this bare area on the tarsal plate, and then you reposit the anterior lamella, that is skin and orbicularis, 3 mm from the lid margin. So you take a 6-0 Vicryl suture and pass it through the lash root onto the tarsal plate, partial thickness, and then come out onto the skin. And you tie these sutures at 3 places, medial, central, and lateral. And then you harvest the mucous membrane graft, you thin it out adequately, and you place it onto that bare area as well as the lid margin, and anchor it with 7-0 Vicryl sutures anteriorly and fibrin glue onto the posterior edge so that it doesn't rub onto the cornea if you place any sutures. We had a very good outcomes. If you see this lady again at 2 weeks, you can see this mucous membrane graft and the suture of anterior lamellar repositioning. And this is her follow-up of 2022, 19 months post-ALA, and she has a vision of 2016 both the eyes with the contact lenses. You can see in this picture how all of the eyelashes were turned immediately all through the eyelid margin inwards. And there was a shortening of fornices, but you need not do any fornicial deepening procedure, just a simple lid margin surgery with anterior lamellar repositioning and mucous membrane graft. And then they can literally improve their quality of life as well as the vision. There are certain other cases where we have done. This is one-eyed lady who had ocular cicatricial pemphigoid, very bad upper eyelid entropion, and this is how she looks like after the procedure. And you can see that even the cornea clears out. If you look at this cornea, it has this keratinization over the surface of the cornea and the inferior half full of the area, and see how it is started clearing in the nasal and the temporal part. So these cases are difficult, and they are not like lost cases that you cannot offer them much of relief, but it really makes a difference if you correct the cicatricial entropion in these eyes, because they already have a very severely damaged ocular surface. In cases where you have not a severe degree of cicatricial entropion, like if you come across a case of trachoma or a mild degree of entropion in the upper eyelid, then you can simply do a tarsal fracture, in which we give an incision at 4 mm from the lid margin. You fracture the tarsus, you separate it from the anterior lamella, and then rotate it outwards. And then you close this cut edge to the lash line, so that this becomes your new lid margin. Here you can see how 3 sutures, a marginal rotation and the tarsal fracture has been done along with blepharoplasty. So in cicatricial entropion, if it's mild to moderate, you can proceed with tarsal fracture and marginal rotation. If it's a severe degree, and especially if patients have chronic ocular surface disease, then you should do anterior lamellar repositioning with mucous membrane grafting. Many times you can come across such patient where you see a riding of the orbicularis. It's similar to the involutional entropion that you have seen, that there's a bulge in this area of pretarsal orbicularis. Eyelashes are turned inwards, but this is a young patient. She's just 32 years old, and she has corneal ulcer in the left eye. And because of the severe photophobia, she's trying to squeeze her eyelids, and because of the chronic medication use, she has this pigmentation of the periocular skin, and the lid has turned inwards. So in these cases, these are mainly spastic entropion. If you put parakin and test, you would find that the degree of entropion reduces considerably. So in these cases, a simple botulinum toxin injection at 3 sites, 2.5 units each in the central, medial, and lateral position really makes the entropion disappear. This is how she looks. And now when the entropion has disappeared, the surface also heals better, because there are no eyelashes which are rubbing onto the cornea which already has an epithelial defect. Daily we come across the cases where you have epiblepharon, which means that usually these are the tiny babies where you can see these lower eyelid medial eyelashes which are turned inwards because of an extra fold of skin, which usually disappears with age, but it will be only in cases where they have persistent watering and SPKs in the cornea that you would opt for a surgical procedure. And the surgical procedure which we do for these kids is HOTS procedure. This is a child who was 5 years old, and he had these eyelashes since birth, and now it was causing a lot of watering and epiphora in this child. He was actually referred with the diagnosis of CNLD to me, and he had absolutely normal patent lacrimal drainage system, and but he had actually was this lashes which were rubbing into the cornea. In this, we just remove this extra fold of skin with the orbicularis and we suture it back with 6-0-vicryl, and this is how he looks at 1 month follow-up. Another form of therapy, is people use filler injection, but I personally feel these are not, they buy you some time, especially for the patients where you don't have fitness for the general anesthesia, or patients or parents are very apprehensive to undergo any form of surgery. In those cases, you can use fillers. Obviously, they are costly and would require supplementation depending upon the eversion of the lashes. So you just simply inject into that fold, which is right above, which separates this fold from the eyelashes, so that the eyelashes they again start turning outwards. Many times we have grown up reading these algorithms for upper lid entropion, which are given in the Collins textbook, but really when it comes to they're very useful, and in my hands, it mainly the surgeries which I have told you, if it's upper eyelid entropion, go for anti-lamellar repositioning. If it's severe because of cicatricial entropion, then go for anti-lamellar repositioning with mucous membrane graft. In lower eyelid entropion, most common is involutional, go for Jones procedure. If it's cicatricial, in the same way as for the upper eyelid, and if it's a spastic entropion, then botulinum toxin really helps. Similarly, there is an algorithm which is given for the lower eyelid as well, but really what helps is you should have a good amount of idea about what is the etiology of entropion. You should be knowing whether it's involutional, cicatricial, spastic component, how deep is my fornix, is it really the shortening which is causing the entropion, or it's only a lid margin disease. And if you do these surgeries following the anatomical borders and the anatomical spaces of the eyelids, you really come across a difficult situation where you have to redo the surgery. So I hope that's all from my end. I'll be happy to take any question. I hope I could impart some knowledge related to the entropion scenarios.
Thank you, Dr. Swati, for this very informative session. Any questions? Yes. So no questions, Dr. Swati. Thank you so much. Nice to see you.
Nice to see you, Marwan. Thank you.
Thank you.
Now we have an approach to congenital nasolacrimal duct obstruction by Dr. Marwan Farhan. He's a consultant of cosmetic, صح? oculoplasty specialist.
Hello, everyone. Good afternoon.
هاي خالد، ازيك؟
ازيك دكتور اشرف؟
ايه الاخبار؟ عامل ايه؟
اهلا، ازيكم؟ يعطيكم
انت
العافيه.
ازيك؟
الحمد لله. في سيشن شغال ولا؟
اي ثينك ان في session شغال.
السلام عليكم.
وعليكم السلام. اهلا دكتور صفوان.
اموركم؟ كيف
الحال؟
صحتكم؟
اهلا
الحبيب،
اهلا.
كيف امورك خالد؟
الحمد لله
صفوان
تمام. اهلا
راحت
دكتور.
راحت عني.
سيشن شغال.
دكتور محمد
اوكي.
في سيشن شغال. مساء الخير. في سيشن شغال اذا ممكن
اوكي.
ميوت اور سيلف.
So my presentation today is approach to the congenital nasolacrimal duct obstruction. Congenital nasolacrimal duct obstruction is a common cause of tearing or before in infants and children. Many plastic ophthalmologists, pediatric ophthalmologists may face this issue within their practice. Other causes of tearing in infant and other children must be kept in mind, especially the serious ones like congenital glaucoma. What's the etiology of the congenital nasolacrimal duct obstruction? Many causes or the main causes of the nasolacrimal duct obstruction in pediatric patients is a pathological persistence of the membrane at the distal portion of the nasolacrimal duct, or what we call the valve of Hasner, bone abnormalities of the nasolacrimal duct, and stenosis of the inferior meatus of the nasolacrimal duct. There are multiple variations, and we can call a classification for the nasolacrimal duct obstruction. The first one is that just the nasolacrimal duct opens to the superior vault of the A, showing A as at the superior vault of the inferior turbinate. It's number B or B. It's the nasolacrimal duct is passing along the lateral wall of the lateral wall. And during probing, you will feel that there is no obstruction, but you can't see the probe in the nasal cavity. So what we can call it's a buried probe. Number C variant is there is the anterior rotation of the anterior end of the inferior turbinate, causing obstruction of the nasolacrimal duct. In D, the nasolacrimal duct is passing through or along with the inferior turbinate. In E, the nasolacrimal duct is just going to the lateral wall of the maxillary sinus. In F, there is a complete absence of the nasolacrimal duct. All of them are complex type of nasolacrimal duct, except A, which is considered as a simple nasolacrimal duct obstruction. So what's the symptoms of nasolacrimal ducts? It's a classic triad, including watering, discharge, and mating of eyelashes. Usually, or mostly, this picture presents within the first few months of life. Is mainly after or by the end of the first month, and less likely after that. When you see the patient in your clinic, you will find an increased tear meniscus height. Positive fluorescein dye disappearance test. It's a useful test. Although it's like a physiological test, but it's easy to perform in pediatric patients. In some severe cases, or if there's nasolacrimal duct obstruction long-standing or something, you may find a regurgitation over lacrimal sac over pressure, RO+ positive. A rare presentation is acute dacryocystitis, dacryocele. It's a rare but very important presentation of the congenital nasolacrimal duct obstruction. So during examination, you have to do a very careful examination in any case with nasolacrimal or any case of tearing to rule out any other causes of tearing. Mostly or very important to see to look for signs of congenital glaucoma, which is a very very dangerous thing. If you if it's missed, it can cause a severe or a disaster for the patient. And look also for any causes of corneal irritation which may cause tearing, like if there is any congenital entropion or epibliferon that causes irritation to the ocular surface, so a reflex tearing. Simply before you take the patient to the general anesthesia, especially if the very small child or baby, it's not easy to take the decision. I will take that simply the child to the OR room and do an examination of the anesthesia, because most of the parents will not welcome this decision easily. So try to look for any punctal abnormalities before you taking the patient. Sometimes you just take the patient to the OR, inducing the anesthesia. Once you avert the eyelid margin, you find there is no punctum, and this would be easier if you just simply avert the eyelid in the clinic. Medial canthal swelling, look for any medial canthal swelling. So other differentials you must keep in mind, mostly the dacryoceal or anything related to the lacrimal sac will be mostly inferior and medial to the medial canthal tendon. Anything above the medial canthal tendon, you should think about other differential diagnosis like meningeal. Diffraction is a very important step during examination. Why? Because sometimes congenital nasolacrimal duct may be associated with an isometropic amblyopia, because the tearing may cause refractive errors. Dacryoceal is, as I told you before, it's a very rare presentation, but it must be care must be given to this presentation, because sometimes, or mostly, this dacryoceal could be associated with intranasal cyst. If the intranasal cyst is big enough, it can cause an obstruction to the nasal airway. So the infant patient, they are mostly a nasal breather. It can cause a life-threatening issue for this child. Lacrimal fistula is a rare presentation. Sometimes there is regurgitation. You can find lacrimation, mating eyelashes, and the nasolacrimal duct is totally patent, but there is a lacrimal fistula. So if there any lacrimal fistula with bothering the patient with regurgitation or infection, it can be closed. But if there is any nasolacrimal duct obstruction associated with this fistula, you can treat the nasolacrimal duct first and keep the fistula for spontaneous resolution. If not resolved spontaneously, you can't close it after 6 months. So
time over.
Just 1 minute. I can't. Yeah. So I will go just to the last few. Probing. Conservative treatment is the main treatment. For congenital nasolacrimal duct obstruction. Conservative treatment included first is the cricketer massage. Cricketer massage, you have to explain the correct way to the parents to do the cricketer massage, because most of the parents are doing wrong. They are not committed to their treatment, so they come after 1 to 2 months and no benefits from the massage. Just simply they are doing irregular movements. You have to show them in the clinic how to do the correct one. If there is no improvement in the first 1 year of life, conservative treatment also can give results up to 3 years of old. After that, if there is a failure of early probing, when sometimes we need early probing, if there is any the patient few days old, he or she has nasolacrimal duct obstruction, but he has also congenital cataract, congenital glaucoma, so you have to do a surgery for intraocular surgery to the patient. So you have to do early probing in this cases. Late probing can be done successfully up to 5 years of old. It's not like any patient after 1 year of old you have to do. You have to jump to intervention before conservative treatment. Probing can be done alone. It can be done with balloon catheter dilatation or with intubation. Whether balloon catheterization or intubation, which is better, they have comparable results. Intubation is easier and less less expensive. The main goal, or the golden standard now, is the endoscopic probing. Why endoscopic probing? Because you can see from where your probe is coming. Sometimes you can go with the metallic to metallic touch blindly, but the probe is coming from a false passage. Surgery, we prefer to postpone the surgery after at least 4 years of age. External or endoscopic, it depends on the surgeon prefer. The most important thing is the home message. Conservative treatment is the main or the golden standard for treatment of any patient with congenital nasolacrimal duct obstruction, especially in the first year up to 3 years and more than that. Early probing is indicated only if there is need for urgent intervention to the eye. Refraction is an important step in the congenital nasolacrimal duct evaluation. Probing could be combined with intubation of balloon dactyoplasty, especially if there is a previous failure of probing. Thank you.
Thank you, Dr. Marwan. And we will move to the next session. I think in the Mio.
السلام عليكم دكتور محمد.
وعليكم السلام، اهلا مرحبا. دكتور طارق.
معك دكتور طارق. نعم
دكتور طارق، كيف الحال؟
حياك الله دكتور محمد، معكم من جديد مع اليوم مرة أخرى. نشكر الدكتور محمد العمري، أيضا نشكر الدكتور خالد عياش، الدكتور بيريا، والدكتور صفوان البياتي، والدكتور صفا جهاد، والدكتور جورج روتش. الميكروفون معك دكتور محمد، أهلا وسهلا بكم إن شاء الله.
Thank you very much. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. First of all, I would like to thank Yemeni Ophthalmic Society for giving us this opportunity to meet our colleagues and friends in Yemen. And again, from yesterday we meet, and on the retina session today we will have anterior segment. It will be about cataract, and today we are having really eminent speakers from different parts of the world. I would like to introduce all of them. Can you, Soria, please share with me the screen? Dr. Ashraf Armia. Dr. Ashraf Armia is a consultant cataract and cornea and refractive and anterior segment reconstruction surgeon. Can you enlarge it a little bit? You know, now we are older age, so above 40 we need a little bit to be presbyopic correction. Founder and medical director of Ashraf Armia Eye Clinic, Cairo, Egypt. Also, we have Dr. Khalid Ayyash, consultant ophthalmologist and anterior segment surgeon, director of Al Hikma Eye Clinic, eye specialty hospital, Amman, Jordan. We'd like also to welcome Dr. Priya Narang from India. This is the second time she participates with us. Thank you, Dr. Priya, for being with us. She is an MS director at Narangia Eye Care and Laser Center, Ahmedabad, India surgeon, clinical research, medical educator, innovator. We are having my dearest friend, Dr. Safwan Al-Bayati, is a well-known cataract and refractive surgeon, consultant ophthalmologist, and he is the medical director of New Vision Eye Center, PHECO, and refractive surgeon, cataract LASIK, vitreoretinal surgeon in New Vision Center in Dubai. We are also proud to have today with us also Dr. Militos Validis. He is a PhD, FIPO ophthalmology, ICO. He's a surgeon of the cornea and anterior segment. He's a president of Helen Clinic, I think, Society and of Intraocular Implant and Refractive Surgeon, director of Ophthalmic Eye Institute, president of Southeastern Society of Cataract and Refractive Surgery. Maybe he will join us, or otherwise we are having his presentation in record. Also, my dearest friend, Dr. Safa Jihad from Morocco is welcome. Dr. Safa, thank you for being with us also. She is a cabinet, and Dr. Safa, she is a consultant ophthalmologist and cataract and refractive surgeon from Morocco. So the first presentation, it will be by Dr. Khalid Ayyash, and he will talk about what new in biometry. Dr. Khalid, the mic with you.
Thank you, Dr. Muhammad. I'm very happy to be in front of a lot of colleagues, a lot of seniors, a lot of colleagues that we practice together here in Jordan. A lot of Yemenis doctors were coming and joined our services here. I'm very glad to be with them again. Thank you for the invitation. I will start sharing my screen. I will be talking about what's new in biometry, and my main speech will be about the new formulas. Is the screen clear? Can you see my screen? Okay.
Yes, now
what's new in biometry? Nothing to disclose financially. I will start by updating on the formulas. In 2010, we only have very few formulas. In 2015, we start to have more and more formulas, and nowadays we have plenty of formulas, and most of them are doing well. Most of them help us as an anterior segment and phaco surgeon in improving our outcome, and help us and help our patients to get a more accurate and desirable results. So the older classification of formulas into first and second generations, maybe this is not true nowadays. So the classification now is based on other criteria, like the historic, the refraction-based formulas that are not used nowadays. Also, the regression analysis formula, like the SRK and SRK2 formulas, are also not used nowadays. Now we have the divergence formula, which are based on geometric optics, and now these can be classified depending on the variables that they use, like two variables, like the holiday one is RKT, Hoover Q, they use the axial length and the keratometer. We have the three variables formulas that use, in addition, the anterior chamber depth, like the Higgs and the Ladas formula. And then we have the five variables, like the Barrett universal 2 formulas. And also we have the 7 variable formulas, like the holiday 2, that use, in addition, the refractive and the age of the patients. And nowadays we are hearing a lot about the artificial intelligence-based formulas, like the HEL-RPF, the Clerk neural network, and the CAN formulas, and also the ray tracing formulas, like the Snellen's law, that uses the Snellen's law of refraction, like the Olsen formula. And we have mixed formulas that use, like the ray tracing and artificial intelligence, and so on. So what is the ideal formula that most surgeons nowadays are looking for? These formulas, the ideal formula should have more than 95% of eyes within less than half a diopter of the predicted outcome. One formula that fits all the axial length, whether short eye, long eye. This formula, the ideal formula, should be used in all these axial lengths, and also this formula that should fit the unusual eye conditions like keratoconus, post-refractive, post-RK patients. Also, it does not require any additional corrective formulas, and it does not require surgeon factor optimizations. And also, this formula should be suitable for toric IOL and should take into account the posterior corneal astigmatism. And preferably, this formula should be available on the machine that make the results, rather than taking our measurements into online and do the calculation. So this is the ideal formula that we are all looking for. But is this the situation nowadays? Let's see. In 2008, the source of refractive errors in biometry, according to Norby, was the estimated lens position was 35% of the error was due to estimated lens position. 27, almost 1/3, was due to axial length measurements, and 17 due to refractive errors. But nowadays, the source of error, axial length, is off the list because we have excellent optical biometry machines that gives very accurate measurements in the axial length. So we excluded around 1/3 of the error. But it comes that the cornea is another source of error, because nowadays, with better understanding of the anterior curvature and the posterior curvature, the cornea is another source of error. This is the updated biometry machines like the IOL Master 500 and now is the 700 or the Lens Star. The Pentacam, they have the AXL Oculus from Nidic. We have also machines. And if you don't have the optical biometry machines, and if you try to using the A-scan, then the emergent technique might be more accurate as it encounter less errors in the axial length measurements. Most definitely, if you have access to the optical biometry, this is the standard nowadays. One of the most known formulas nowadays is the Barrett Universal 2 formulas. It's based on ray tracing. It differs from the conventional formulas in that it takes into account the changes in the principal planes that occur with different intraocular lens powers. And it uses 5 biometric parameters to predict the effective lens position and IOL power, the axial length, the keratometry, anterior chamber depth, and also it takes into account the lens thickness and white-to-white measurements. And it continues to evolve via data-driven enhancements. Barrett, it's not just a single formula, but it's a suite of formulas. And this changes the calculation depending on whether the optical configuration alters from biconvex or meniscus lens. And it does not require any additional correction factors such as axial length transformation or unusual constant for patients with high or very short axial length. The Barrett suite includes the Barrett Universal 2 formula is the core of this formula. Then we have the Barrett True K formulas for patients with prior myopic or hyperopic laser vision correction or keratoconus patients or even RK patients. And we have the Barrett toric calculator for toric IOLs, and we have the Barrett True K toric calculator for toric lenses for those who underwent laser vision corrections. And there is a very important formula of these is the Barrett treatment formulas. It's make an analysis of the outcome, and if we have to change the IOL or if we have any errors in the outcome or unusual outcomes, then we can get to this formula and it gives us the best solution. As we said, the Barrett True K formula is derived from the Barrett Universal 2 formula and incorporates a modified double K method and can be applied to eyes that have undergone laser vision correction, as we mentioned. This is the online platform that we can see. If we can get access to this formula online, this is what we can see here. We can have the data of the patients. We enter all the mentioned data, and then it makes the calculation and it gives us the predicted outcome. This is for the toric IOL calculation also. The Barrett True formula and the Barrett toric calculator. It gives us the axis, the power of the lens that is suitable once we enter all the required data. The second formula is the Hill RBF formula. RBF stands for Radial Basis Activation Function. It's based on artificial intelligence regression model using pattern recognition and sophisticated data interpolation. It's optimized with the Hagstrite Lens Star LS900 optical biometry. This is ideally, if you have the Lens Star 900 machine, then you can use this formula as it's part of its software. And it's ideal also with the Alcon SN60 WF biconvex intraocular lens and the Alcon MA60 meniscus design intraocular lens. It's entirely data-driven and free of calculation bias. It gives a validating boundary model indicating when it's performing within a defined area of accuracy, as we will see. Hill RBF, initially it was based on 3,400 patients. The range was from 19 to 30 millimeter of axial length, and the biometry range was the keratometry range was from 37 to 49 diopters, and only at the first they use it for biconvex IOL only from +6 to +30. Then the second version, they expand the patients to more than 12,000 patients with addition of more than 1,000 cases of very short axial length. And also in version 2, they have the meniscus IOL design from -5 to +5 diopter lenses. And this is the platform for this lens, and this is what I meant by inbounds or outbounds. This is artificial intelligence formula. If anything went wrong, or any of the data is missing, or any of the data that you are giving to the machine is out of the values that the machine have, it will give you that this is an out of bounds. Once you saw that it's out of bound, it's preferable not to use this calculation and not to consider it. If it gives you it's in bounds, then the measurements will be accurate and you can use it. This is the good thing about this this formula. And here also we can see the platform online for the Hill RBF. It can be used with other devices like the IOL Master. Then you need to enter it that you are making the calculation using the IOL Master device. But as I said, this is artificial intelligence, and the way that artificial intelligence works, there are millions of information that the system used that we as humans can't understand or can't explain why this results. So if you use other machines, you can enter, and then it will give you if this within inbound or outbound. As we can see here also, for if you use, for example, CT Lucia lens, for example, it gives you that this is out of bound because there is no enough data about this lens in this system. But when it gives you, there is no mark here, then you can use the results. The third formula I will be talking about is the KIN formula. It's based on theoretical optics and also incorporates regression and artificial intelligence. The KIN formula uses the axial length, keratometry, anterior chamber depth, lens thickness, and central corneal thickness and gender of the patient to make its prediction. And this is the platform which is available online for this formula. Other formula is the Olsen formula. It uses ray tracing methodology. It comes into two-factor version that uses anterior chamber depth and lens thickness to predict the post-operative effective lens position, and a four-factor version that uses additional parameters of axial length and corneal curvature. So the two-factor version does not use the corneal curvature, and this might be suitable for patients who underwent laser vision correction. The Olsen formula, it uses the C constant factor, which defines the IOL position in terms of the crystalline lens anatomy. It's not dependent on the K readings nor on the axial length. They found that the position of the eye, what's the C constant means, that they found that the position of the IOL after standardized capsulotomy and in the bag implantation is closely related to the preoperative anterior chamber depth and lens thickness. And this knowledge stems from accurate measurements of the exact position of the IOL following surgery, as can be done by laser biometry and other technique. The EVO formula also one of the newest formula. It's based on the theory of emmetropization and generates an emmetropia factor for each eye. It's a thick lens formula and takes into account the optical dimensions of the eye and can handle different IOL geometry and power. It uses the axial length, keratometry, anterior chamber depth, and also other variables can be entered and can add in the accuracy is the lens thickness and white to white. There is also a version 2 to improve the prediction for long and short eyes and toric eye OL, and also can be used post myopic laser vision correction. This is the platform for this formula. LADAS formula, it's not a new formula. It's rather than working by optimizing multiple formulas and choosing what is the best formula for each of them to make a super formula. This formula will choose the most ideal one to use, further optimizing the values over time using both individual and the crowdsourced data. For example, for short eyes, it uses the Hofer Q formula. For long eyes, it uses the Holiday with the adjustment factor, and for other eyes, it used Holiday 1 formula. So it's like if you are going to a trip, rather than going into different online sites, then you can go to one site and it makes the calculation. And this is the idea behind the LADAS formula. It takes the data and it takes many formulas and incorporates which is the best formula for you. This is the platform online, which is available online, and it gives us a very good outcomes. ESCARS recently introduced an online calculator. It's still evolving, but it has many formulas that can also do the calculation for you. The last formula I will be talking about is the Pearl DGS formula. stands for post-operative spherical equivalent prediction using artificial intelligence and linear algorithm. DGS comes from the developer, the name of the developer of this formula. And it's available online. The nice thing about this formula, if you are doing a second eye, then you can enter the data that you did for the first eye, and this will add in giving more accurate results for you. So these are the formulas. Which formula we are using? These are the websites for each of these formulas, and most of them are free. Some of these formulas you need to have access to go in, but most of them are you can get free access and you can use them online. Which formula to use? I just will go quickly on the literature to see what the literature said about the formulas used. This is a very big study that was done in the United States, and was the aim of the study to answer 4 questions. Number 1, which is the most accurate formula in eyes of all ocular dimensions? What is the accuracy of various formula when evaluating short, medium, and long eyes? And what is the extent of bias within each formula? And the 4th question was, does the use of the Van Gogh axial length adjustment for the Hages and for the Hoover Q and the Holiday in long eyes lead to improved outcomes? So this is the 4 questions that this study was aimed. So at first they incorporated around.
Khalid, if you allow me, can you conclude, please? Because we are 2 minutes over the time already.
Okay, I will conclude in 1 minute. So this is the study. They included more than 37,000 eyes, and they found that the accuracy of the Barrett, Olsen, and the Hages formula. And I will go through all these slides quickly. And in conclusion, they found that the Barrett and the Olsen formula has the best outcome in terms of accuracy and post-operative spherical equivalence. And between axial length of 23 and 25, all the 7 formulas are given very good results. And the one one of the outcome that was in contrast to the expectations, that they found that the Hoover Q had the worst performance in short eyes for both type of IOLs. This is in comparison with the newest formula, like the Kane and the Barrett formula. But if we want to compare Hoover Q in short eyes with the older formula, no, Hoover Q do better than this formula. So in conclusion, the best practice nowadays is to obtain measurements with modern accurate devices, optical or sweep source OCT, obtain accurate keratometry, better to take total keratometry. The best machines to be used in this situation is the multi-zone LED devices. Use the best formulas, validate your results, and always explain to your patients about the outcome. And thank you very much.
Thank you very much. Okay, sorry, Dr. Ashraf, go ahead.
Thank you, Khalid. Very nice. It's very nice overview of all the formulas in the market now with the updated forms also. Before we go to Dr. Priya from India, I just want to highlight first I want to thank the Yemen Ophthalmology Society, because this is my first time between the Yemen Society and the ophthalmologist. So I'm happy to be here. I'm just going to highlight in 2 minutes a conclusion of what Dr. Khalid said. In extreme eyes, we should do more than 1 formulas. Effective lens position of the lens is very important in the final calculation and the final results. Abnormal corneas, you should do more than 1 calculation. Don't depend on 1 calculation to get the best. And if you find that there is a difference, so you can choose between what is the best. Toric calculation, as mentioned by Dr. Khalid, it's very important using the calculator, either the Barry calculator or the formulas, toric formulas from different companies. Depends on the IOL you are using for toric IOL. And finally, yes, the short eyes, especially in the short anterior chamber, it's not an easy way to calculate the IOL, especially for the effective lens position for these cases. And finally, if you have a subluxated lens or pseudo-exfoliation, always expect in the calculation of the effective lens position, it will be different post-operatively or after 1 to 2 months, because there are changes in the zonular contraction of the lens.
Dr. Mohammed, one comment for the short eye. Dr. Khalid, excellent presentation. And it was summarized for all the formula. Only one comment for the short eye, as Ashraf said. And when the AC depth is less than 3, I will go to the Hoover Q. And I compare between Hoover Q and Barrett and Hills. As you know, that Hills is not a formula, it's only collecting data. And they are improving their performance. There is no any formula in Hills. Anyway, I found that Hoover Q, it can be varied between Barrett Universal 2 and Hills and Hoover Q. There is a plus minus 0.25. And this plus minus 0.25, when you are using the premium lenses, definitely it will differ, especially when you need to target a minus 0.25, and then you will use in those very short AC, a Barrett or Hills, it will gives you either Imitrop or plus 0.25. So these are the difference, because when you are putting, for example, 2.3 AC depth for 4th generation, the difference will be 0.25. Why Hoover Q here it's playing better? Because Hoover Q, they are not considering because Hoover Q is a 3rd generation, so it's not considering the AC as a part of their calculation. So the effective lens position will be on a calculation of the corneal power and the axial length. From this point of view, Hoover Q can be better in the short AC. When the AC is less than, for example, for me, I'm considering it when the AC is less than 3 millimeter. Great, thanks.
Thank you, Dr. Safwan. If there is any question from your side, Dr. Tariq.
هذا الشيء سأل يا شباب. Next speaker, there is no question.
Okay. So I will love to introduce Dr. Priya Narang from India. She is a very eminent surgeon and eminent ophthalmologist worldwide. And the topic she is going to talk about, it is innovated by her and Dr. Amara Gorel, the whole team. It's a very important technique in cases of abnormality in the corneas. She's going to highlight this, I think, in the most proper way. So she's going to talk about pinhole pupilloplasty in cataract surgery and optical concept. Please, Priya.
Thank you so much. And it's such a wonderful honor to be here. Thank you so much, Ashraf. Thank you so much, Dr. Mohammad Amri, for involving me. And it's again a pleasure to see you everyone back. So I will just share my screen and yeah. So I hope it is seen there.
Yeah.
Yes.
Yes. Yeah.
Thank you. So I begin my talk here, pinhole pupilloplasty in cataract surgery and optical concept. So actually, the question props up that why do we actually need to do this when you're doing a cataract surgery? There's a very simple answer to this, that it's always wherever there is a higher order aberration, it is only there that we consider doing a pinhole pupilloplasty procedure. Because we all know that the pinhole optics, they try to impart the best visual acuity to the patient whenever there is a defect. Now, coming up to this is just an animation that, it just describes how this procedure, it actually works. This is a case of RK, and the patient has immense higher order aberrations. And we know that the aberrations, they are directly related to the size of the pupil, and the patient never sees anything clearly. So in these select group of patients, what we try to do here is that we try to impart pinhole optics by narrowing down the size of the pupil. And that is how we go ahead with
doing a pinhole pupilloplasty. The other concept here would be to impart a pinhole optics would be to use a pinhole intraocular lens if it is available in your part of the world. And if it is not, this can be definitely done for the patient. The prerequisite just being that you need to know how to do a pupilloplasty procedure. So coming up to this fact that whenever we have this procedure, when we need to do this procedure in a pupilloplasty, this is actually a bit of a technical procedure, but whosoever knows it can do this very well. Now, to highlight this fact, this is a case of RK, and the patient has 12 to 16 marks, deep marks on the surface of the cornea, and patient has been operated for cataract surgery, but the patient is not happy just because that everything is proper, but there are higher order aberrations, and these are massive higher order aberrations wherein the patient is just not happy with the kind of visual quality which is there for the patient. So here we are trying to narrow down the size of the pupil, and wherever you take up this the technique, we always choose a single pass pupilloplasty procedure because it's a very easy procedure, a very simple way of closing down the pupil wherever you actually need. The point here is that whenever you're trying to narrow down the size of the pupil, you need to center it around the Purkinje 1 reflex. That's a prerequisite for doing this. And specifically in this case, when you have those deep corneal marks, what you actually need to do is, you need to pass your needle from in between the two RK marks which are present, and you should not disturb the RK marks which are already present. Now, coming up to this case, this is how you see this case in the immediately on the table. Your pupil should be immediately centering this, because we always try to target and have the size of a pupil which is around 1.5 to 2 millimeter in size. And we have seen that whenever you target the size of the pupil around the Purkinje reflex, it comes down to anywhere around 1.5 millimeter. And we have done further studies, and the paper is going to be through soon. The optimum size of pinhole that is needed for patient, it varies from patient to patient. There is no one pinhole size which works for all the patients. So this is just the basic concept that I'm just trying to show here. This is a case of a cataract, you can see, and this is PK has been done for this patient, and we are trying, definitely this patient again has a higher order aberration. No matter how well you do the cataract surgery, this patient is not going to be happy in the postoperative period. So these are the cases that we electively choose these patients for doing a pinhole pupilloplasty. Now you can just see in this case again, we will be bringing down the pupil from all the sides. So all that we need to do is that, we just take this is a long arm needle, which is attached to the 9-0 polypropylene suture. We pass through one end of the iris tissue, and then we railroad this from the other side, and then we just bring the loop out. We take 4 throws through the loop and we pull this. This is just, I'm just describing the method of single pass that we try to adopt. Why we try to do this is that, we just need a single pass in this, and we don't have to redo it again and again. Because, when you are doing a pinhole pupilloplasty, you need to bring down the pupil from all the sides. So actually you need so many interventions in the eye. You at least need to do it 3 or 4 times to bring it down from all the sides. That's what you're actually seeing there. So now this is a technique which works fast, and it makes things pretty easy. So this is how this actually works in case if you find that the iris tissue is overlapping the Purkinje reflex, then we can use a vitrectomy probe, and then we can cut all around it. So this is just the pre-op and the post-op image of this. Recently, I think I would like to take this opportunity. This is a newer technique which I have introduced. This is the reverse pupilloplasty procedure. This is the track of the suture, how it goes inside the eye, and how we get the knot. This is exactly the reverse of a single pass pupilloplasty procedure. This procedure, normal procedures, we all have knot in anterior chamber, but with the reverse 4 throw, you get a knot on the posterior surface of the iris tissue. So I just take this opportunity to just show you this technique of reverse video. This is a case which I'm trying to show you. I'm trying to bring down the pupil in this case, and we take this needle and we enter from the posterior surface of the iris tissue onto the anterior surface of the iris tissue. And similarly, we do it from the other side also. Now you would say that what's actually the need of doing this when you can do a single pass four-throw pupilloplasty? Why not do this? This technique actually, I actually supported 4 cases that are scheduled for endothelial keratoplasty procedure, because you do not get any suture knot into the anterior chamber, and because that's the area where the graft gets handled, you know, and the endothelial graft remains quite safe. So this is how you see the suture goes in, and the remaining procedure remains the same. It's just the passage of the needle that makes the difference in this technique. The remaining procedure is the same like a single pass 4-throw. We just, I just pull this loop out and just take the 4 throws, but the knot slides and goes back onto the posterior surface of the iris tissue. So this is one of my peer paper, which is soon due in one of the journals. And this is how you see we need to take 4 throws for all those people who are not into doing pupilloplasty. I would just like to mention that when you take 4 throws through the loop, it creates a self-locking mechanism wherein the suture loop does not open. And it leads to apposition of the iris tissue very well, and you do not have to take a second pass again. So this is how you see the suture is being pulled from both the sides, the knot slides onto the posterior surface, and actually it looks so beautiful in the postoperative period that you will not even recognize that you have done a pupilloplasty in this case, because you do not see the knot which is there. So you just feel that it's just the apposition of the iris, and I also call it as an iris stapling, because it's like a staple. It goes behind. This is the anterior segment OCT. You actually cannot see anything in the anterior chamber because there are no knots in the anterior chamber. Anyway, coming up to the fact that these are the cases. This is one of the cases that I would just like to show you. The patient had a refractive surprise. This patient has undergone everything. The patient has LASIK, undergone LASIK. The patient has also undergone cataract, mixed astigmatism. The patient also had pseudoexfoliation with CTR into the back and all. So now these are the cases, where you would not just like to touch the capsular bag, because you know that already everything is compromised and everything is being done. So the best thing to do is, what I would actually do is that, you just narrow down the pupil and the patient is fine. So this works beautifully. And this is how we, as a team, we described it with Dr. Jack Holiday and with Dr. Agarwal. We described this, the effect of the pinhole pupilloplasty for higher order aberrations. And we assess the visual quality and the depth of focus for the patients in the photopic and the mesopic light conditions for distance, intermediate, and near vision. And the patients, they really responded very well. And this was the defocus curve. We all know that whenever there is a pinhole coming up, you always get that extended depth of focus in these patients. And it is this extended depth of focus, that really helps these patients, and it really makes life very good for them. And these patients, they have a very high satisfaction ratio post-operatively, because they have never seen anything so clearly in their life. We also assess the low contrast visual acuity for these patients, and these patients, they really work very well. Thank you so much.
Thank you very much, Dr. Abriya. I think Dr. Ashraf.
Yes, it was a very nice talk as usual, and another innovation coming from the same team, the reversed knot. I think it will be the coming knot, because it is better cosmetically inside the eye, and you cannot, and even the iris will be tucked down, not up. So this will be better cosmetic for the patients.
I have 2 questions, Dr. Ashraf, if you allow me, for Dr. Abriya. First of all, thank you very much. It was an excellent. Congratulations for this innovation. Suppose we are having a patient and he is a diabetic patient, and we want to see the posterior segment in this patient. After we do this, what are the things that we are going to face for dilatation and doing the other things?
This is a very valid question, because everybody has this thing in mind, that how you're going to do it. For examination, I would say that, maybe it might be just difficult through the 1.5 millimeter pupil to see behind, although you can just see the central fundus. But now there are ultra wide imaging devices, like I have no financial interest, like we are using the Nidec Mirante and all. They actually give you the entire periphery of the eye. You can see up to the periphery. You can take those images and you can see even the periphery. Coming up to the intervention that you are saying, that if we need to intervene these patients, maybe these patients might go in for surgery for the posterior segment, then I think the surgeon, the posterior segment surgeon, they can just cut those sutures and then it's done, and they can perform the entire surgery if at all it is needed in the future. So things are not that difficult as it seems, because the immediate result that we give to the patient is phenomenal.
There is another question, as I mentioned, Ashraf. Can you correct this high order abrasion instead of going to do this one by, doing a laser interventions?
Laser interventions. Well, no, these patients, they are actually not happy patients, because laser interventions, I don't think they are going to help too much in these cases, because these cases we choose, very carefully, wherein we have to do a pinhole, imparting the pinhole optics to the patient. I don't think anything else is going to help them. The only thing that you can do is you can use a pinhole IOL if it is available in your part. These are the only two options.
I think that, the patient, especially for RK, what I'm doing is that I'm starting with the laser treatment. I do agree with you that it's not an easy, and it need high selective treatment of the high order abrasions, because those, they have a very high spherical abrasion and they have a very flat center. So remodeling of the cornea with the remodeling of the epithelium, because those, they have a very thick central epithelial layer to remodel the cornea. So I do agree that it's not an easy, but surprisingly, when you are treating those high order abrasions, especially for those that they have an RK, they will be, their vision is improved in a way that they will not do the cataract, because part of their vision deterioration is the high order abrasion. So I did it, yes, I have few cases, and they are happy. And then then I did the cataract, and they end up with a reasonable vision comparing to the pre-op situation. Definitely I'm using my machine that Schwint and can treat all those high order regions selectively. And we compare the epithelial thickness of the center, because in MS39 we could compare the thickness of the epithelium, and it's remodeled in a beautiful way.
That's great.
Continuing, Dr. Safwan, I'm using the same technique for the unhealthy corneas. It's give better results. But how you can measure with a very small pupil 1.5? For me, I feel it a little bit difficult to calculate the high order abrasion, the refraction of the patient, because most of the machines, if the pupil is very small, it's very difficult to get a refraction for the patient. And also, if I'm using, say, for example, for me, the eye trace, it's very difficult to have a high order abrasion in 1.5 pupil.
Ashraf, here you are talking about post-op, or we are talking about pre-op?
No, I'm talking about post-op.
I'm talking about pre-op. First of all, what we are talking about is not a ocular high order abrasion. You are talking about ocular. That's why the pupil size is very important. I'm talking about the corneal wavefront. So I'm talking about corneal high order abrasions, because those patients, it's not an important for them an ocular, because there is no ocular, it's a corneal. So when you are using eye trace, it will give you definitely the ocular and corneal. Here, what we need is the corneal, and we need machine that connected to that corneal wavefront that can treat those issues selectively. So pre-op, the pupil is within the accepted limit, so we can treat it. And corneal wavefront doesn't depend on the pupil.
Yes. No, I'm not talking about pre, Dr. Safwan.
Okay.
Yes, Priya, you put a pentacam, and the main issue or the main concept for pinhole pupiloplasty is the decreasing the high order abrasion. So how, from your side, how you are calculating the post-operative high order abrasion in your center?
See, actually what happens is that post-operatively, there is not going to be much change in the higher order abrasion, because we are not doing anything for the higher order abrasion. We are only bringing down the size of the pupil, right? Now, when we bring the size, it automatically filters all the abraded rays. So it's just the central rays which are passing through the center of the eye. And that is
Yeah.
what, you know, get. For the benefit of the patients, what we can actually do with what we do is that, you know, we have that customized pinhole size. We put that in front of the eyes of the patient and we'll make them see that, okay, are you happy with the 1 millimeter size? Are you happy with 1.5, or you are happy with 2, or you are happy with 2.5? And you will be surprised to know that all these patients, you know, they are not everybody is saying I want 1.5 or I want. There are patients who say no, I'm fine with 1 millimeter. Some patient says I'm fine with 2. So it's just like, you know, we just try to show them before the surgery that, okay, look, this is what you are seeing right now, and this is what you are going to get in the post-op. If you are happy with this, we go ahead. Otherwise, no.
Thank you.
Priya, just one thing. If you are going to the map of the higher regions of the cornea and measuring 7 millimeter and then 6 and 5 and 3 and 2 and 1. When you are reaching 1, the value is very low, almost null. So
absolutely, it goes down.
So according to that, the pupil size will go to the almost null, which is the center.
Absolutely.
Thank you, Priya. And we are going to the next talk. I think.
Can we ask Ashraf if there is any question from the panel there? Tariq and anyone from the colleagues have any comment or question for Dr. Priya?
Okay, so we are, I think we can go to Dr. Safwan. For me, I love seeing Dr. Safwan, watching him doing the 4 flange. I enjoyed in last October. So I think everyone attending today is going to enjoy what Dr. Safwan is doing, either the Yemeni or the 4 flange, but it will be different with him. So you are going to enjoy all.
Great, thanks, Dr. Ashraf and Dr. Muhammad. And I was very happy to join this eminent speakers, Priya and Safa and Khalid and Ashraf Armia. And this group is, they are very close to me. They are all, but only one comment that Muhammad started with a presbyopic for all. It's all, that's right, I agree, for all except Priya and Safa. They don't have presbyopia, Muhammad. So please, just correct that. Anyway, well, just yes.
I
just want to thank you for this precision. I agree. I totally agree. Thank you. Thank you,
Muhammad. And you are interfering with them. So Safa and
I was talking about myself only, Safa. All of you are younger than me.
So returning back to Yemeni technique and 4 flanged, I'm very happy to present that to our brothers in Yemen. And if we'll start, let me start with the Yemeni technique and let us say that why we are reaching to Yemeni technique. Surgical techniques for secondary IOL implantation is not a new thing in the absence of the capsular support, have been accomplished by using an anterior chamber IOL, where in the past we had that only, and then iris fixed IOL, and then we had the revolution of transscleral suture posterior chamber IOL. That was a revolution because it supports the lens posteriorly, and we will not affect the endothelial cells, and there is no erosion of the iris. So the transscleral IOL suture technique has advantage over the other technique, which can cause corneal endothelial cell loss, glaucoma, peripheral anterior synechia. However, suture erosion and breakage remain significant concern when using the transscleral IOL suture. Suture breakage was observed in 27.9, almost 28 of cases 6 years later, and especially when you are using 10-0 polypropylene suture. Some surgeons have used Jortex, like me, suture to decrease the risk of the suture breakage. Now, if we will go to Yemeni technique, first, before that, Agarwal introduced a glued IOL. The intrascleral IOL fixation technique was reported by Gabor and Agarwal, a sutureless technique for IOL fixation. This technique can overcome the risk of the suture-related complication, but has a potential risk of postoperative hypotony, scleral, and we need scleral flap, we need peritomy, and the use of biological glue. and there is a myopic shift because of the length of the suture, and that should be away from the limbus in about 1 millimeter, and to get a good enough haptics length. Yamani and his colleague develop a new surgical procedure that can be carried out via the conjunctiva, in which the haptics of the IOL are fixed strongly to the sclera without using scleral flap, no peritomy, suture, neither suture or glue. They have named this technique flanged IOL fixation because they create a flange at the end of the haptics for firm fixation by using double needle technique. A double needle technique that's took the other name of the procedure as a double needle technique, then it's modified to the name of the founder. That can minimize the sclerotomy to 27 gauge and decrease the risk of postoperative hypotony. Now, during this period, Brian Kim came with a modification, a radical departure from the original Yamani technique, because the trailer haptics here in this technique is fixed before the leading haptics, thus bypassing many of the technical challenges. The simplest solutions to externalize the leading haptics out of the eye through an inferior limbal at 6 o'clock incision, as what I will show. And this is made even easier by using a one-step injector assisted technique. This maneuvers cure the IOL from slipping too far posteriorly into the eye. And because the IOL side more anteriorly access to the trailing haptics is enhanced for a needle fixation. Now, what we need for the Yamani technique, we need the special lenses, those lenses having haptics called polyvinyl fluoride. So it's not a PMMA, because we can use PMMA, that's right, but cracking of the PMMA haptics is a big problem here in this technique. In our region, in JCC, we have the sensor from Johnson & Johnson, and unfortunately, we don't have a Lucia from Zeiss, which have the polyvinyl fluoride. So sensor from Johnson & Johnson having, I don't have any financial inclusion here. The polyvinyl fluoride haptics is what we need. What's the needle? 30 gauge inch thin wall needle for Lucia and 27 gauge needle for the sensor and the PMMA, if someone need to use the PMMA. Now, what else we need? We need 23 gauge micro forceps, tying micro forceps. One of the clue here in the Yamani technique: 1 cc syringe, ink pen, and caliper, access ring, and cautery, a gentle cautery that we can use it, and most of them it's portable use, one used only, and that's the one that can give us the gentle cautery. Now, what else we need? We need the either trocar for the maintaining the intraocular pressure, or AC maintainer. Well, I'm not fun with the AC maintainer because it interferes with the technique. So I'm using the trocar because those cases we need to search for a lot of, because usually most of them, they have a posterior remnant of the lens, but they have a drop lens, or they have lens matter in the sulcus, or we need to clean the sulcus from the remnant of the posterior capsule, because it will interfere with the centration and tilting of the lens. That's why I'm cleaning, and I show on all live surgery how I'm cleaning the capsule, removing it in a way that we can fix the lens in its position. I'm advising all the beginner to use the Simul Eye, and it's there and on a website, and I don't have any financial enclosure here, from a Golden Ophthalmic. They can order it, and it's a very, very helpful in training on the Yemeni and flange technique. They can order it. It's two eye in one box. Now we will see a video here. The video shows the Yemeni technique on the simul eye, and you can start seeing that first of all the gross marking, and with the 2 millimeter from the limbal, the first mark, and then on the on its side there is a 2 millimeter also on side. On the other hand, on the other side there is a 2 millimeter, but the other 2 millimeter is opposite to the right side. Those markers should be very clear, very clean, because it should be visible, and the important key of it is to create the tunnel. Here I'm doing the double needle technique. The first needle that it will kept inside the eye, it should be bent on 9 millimeter. The second needle that will be for the first externalization, that is for the leading haptic externalization, we can make it 11. And why the first one we made it 9, because it will be kept inside. And why it's kept inside, we can externalize. Someone will say, you can externalize. No, it's for the centration of the lens, because the needle will give a better length for the lens for the mobility. And you can see now I'm testing both haptics. It should be test in the needle that I will use here. I'm using sensor with the gauge 27. So that the needle, both needle, the microforceps is a key factor here. The tip of the haptics should be go perpendicularly and then inside. And those issues are important and should be tested before the surgery, not inside the eye. See, I test both goes easily and in. Now, the injector injecting the lens, the haptics should be clearly visible in a way that it will not be broken. Here, I'm doing paracentesis 6 o'clock, and this is the modification of it, testing the micro tying that it should go easily through, and then preparing myself to hold the leading haptics while I'm injecting the lens to externalize it in. And then we have now supported lens. The leading haptics is outside supported, and the trailer haptics also supported. Here I'm just centering the lens, and you can imagine that if we don't have iris to support, then we can do the technique easily. And then now I'm preparing the 2 paracentesis to go in, and the tunnel, which is very important. I'm creating the tunnel, putting the tip, and then holding the trailer haptics by internalizing the trailer haptic first, and then holding it with the micro tying gauge 23 from the other paracentesis in a way that my site will be clear. And then perpendicularly, the tip should be perpendicular to, and then pass it, introducing it to, and then keep the needle in. Here, I will have enough length for the mobility. See, the tunnel should be created into its parallel to the limbus and then in. Now I will internalize the leading haptics, which is much easier than starting with the leading haptics. It's aimed with the leading haptics. Here, again, the tip of the haptic should be perpendicular to the bevel, and then here I will externalize the needle out, the assistant preparing the cautery, and my tying, it should be ready in a way that I can hold now a small flange. That will be more than enough. Leave it, and then I will go back to my trailer haptics, externalizing it, flange, and then reinsert that in, and the whole surgery and the lens center, and everything's fine. Now, if we will go to the real surgery, I will try to make it here. It's a phakic eye, a dropped lens in, and lens matter in. So all these we will skip it and see. You can see that this is the first needle with the 9 millimeter, and the second needle will be with the 11 full shaft, and then I'm just preparing the site. I will escape these. See, the paracentesis should be very in the direction of the paracentesis should be directed toward the site where we will create the fixing of the trailer haptics in a way that the manipulation and the introducing the haptics into it will be easily. This is the paracentesis at 6 o'clock to have the leading haptics out, and then testing the micro tying to go in, because sometimes it's difficult to go in. So I'm testing it, then creating the tunnel. I left the lens in, sorry, I left the needle in, and then injecting the lens, loading the lens, injecting, and preparing myself to have the leading haptics out. Now the leading haptics supported and out. Some difficulties for sure. The lens is upside down. I recorrected again. These difficulties, for sure, we will face it intraoperatively. Now I have two haptics out, and then I will start to externalize and introduce the trailer haptics first, where the needle is in the tunnel, and you can see that the needle start to be ready and go in here. Then I will go from the paracentesis to have the tip of the haptics perpendicular to the beveled, and then introducing it in a way that there will be some difficulties. I will left the needle in. That's why the length of it is 9 millimeter. Holding the trocar, that's why I like the trocar, in a way that it gives me the opportunity to have the tunnel in a parallel to the limbus. Now I'm internalizing the leading haptics in, and then holding it from the tip around 2 to 3 millimeter from the tip and perpendicular to the bevel, and then out. Now I will externalize the leading haptics, holding the haptics, and then cauterizing, creating the flange on the tip. This flange, I will leave it. I will go back to the trailer haptics, and my micro tying is ready to hold the haptics, and then another flange, and then recentering the lens by buried the tips into the tunnel. Now we will go, that's post-op. What's for flange fixation, just for taking time? So Calabrava in 18, he published one paper showing that the novel for flange transscleral IOL fixation, and that technique, I will show it to you using a 4 eyelid lens. And for me personally, I prefer the 4 flange because it's less complication and more centration of the lens. Now, if we will go to the surgery directly, we will see that here still I'm using the trocar because I need a lot of I need double tunneling. That's why I'm using the trocar. So here I'm using 2 tunnel instead of 1 tunnel. So on each side I have 2 tunnel, measuring it that it should be 2 millimeter from the limbus. And I will start cleaning, introducing the lens in. Definitely, I did the cleaning here. The video is accelerated. The lens that used is 4 eyelets. It's from Physio. I don't have any financial enclosure here. And the 4 eyelets, I will start from the first tunnel, go through the first eyelet. I prepare my suture. The suture is 5 or 6 polypropylene nylon. And then the suture will be go through. Here the suture will go through into the beveled, and it's much easier than the haptics. And there is no any risk of cracking or tilting or any because those are the main cause for the decentration. Now I'm creating a flange just to make it sure, or I will secure myself from slipping of the first suture. Then I will go to the another tunnel here, which is on opposite, and it should not cross the midline in between them, going through the second eyelet from one side and introducing the other end of the suture, which will be, I'm using it around 10 millimeter or 15 millimeter, and then taking it out, externalizing it, and it should be, see, the loop should be all inside. That's why I'm pulling from one side in a way easy to externalize it, holding it, creating the flange. So this is a primary flange. This is not the end flange. Now I will go to the other side, and other side have the same, holding what you can see, holding the trocar, using it for the first eyelet, and then externalizing it with a flange, and then the second tunnel, the second eyelet, and passing it into the beveled, much easier than the haptics. In my opinion, this is in my hand. I'm doing it both according to the situation, and then externalizing it. Now, flange, and then the centration here. This step is an important step because centration of the lens. Now I'm returning back the haptics under the iris. I have 2 suture, I have 4 flange. Now I'm centering it. Then, now 1 flange will be buried into the tunnel. The 2 flange from these 2 sides, it's buried into the tunnel, and I have two suture that I need to tighten it according to the centration of the lens. And you can see here, I'm drying the site, seeking for a good cautery, because if the site is wet, the cautery will not work. So, and I need a very faint flange, then buried it into, again, cut and flange, and then buried into the site and the central lens. And I did here pupilloplasty, but it's not for sake of time, it's not. Other use of the flange technique, just let us see this video, quick video, if Muhammad allow me. And
Dr. Safwan, can you make it fast because still we have 2 talks.
Okay, I will try. Here we have iris dialysis, we have subluxation of the lens, and we have all of it. We did it with the flange technique. And if you can see that, first of all, I draw I retract the iris in a way that I can go through and do the cataract, and the cataract done. And then I implant I did the capsulotomy, and with the Ahmed valve segment, the capsular tension segment, I pass it here. It's not very clear, unfortunately. Then I remove the iris retractor and tract only the Ahmed segment by only 1 retractors. Then phaco done.
2 minutes, please, Dr. Safwan.
Okay, I will finish, and if you don't mind, I can stop it, but just let us take this opportunity. Then the capsular tension ring also, it's done, it's in. Now I can reach to the end how we did it. Then flange into, then tunnel, and then the suture passed into the needle through the hole of the segment, and then out. The flange, the first flange will hold the Ahmed segment, and then it's centered. And then I did the prolapse, the dialysis of the iris also by flanging, by creating a loop outside, and then for 1 millimeter distance from the limbus. Here, the capsule being supported by flange technique, and the iris also supported by the flange technique. In this step, I'm doing the pupilloplasty, and the story all is finished. Thank you very much.
Thank you, Dr. Safwan. It's very nice illustrative of the Yemeni and the four flange and the modified technique by Brian Kim. For sure, he's a very talented one. I'm going to meet him in an hour. So he's a very talented person I know here. So can you stop sharing, please, Dr. Safwan?
Yes, my dear.
I just want to thank Priya, because Priya should leave now because she's obliged in certain situations in her hospital. So thank you, Priya, for being with us and for your nice video and your new technique that you are going to publish soon, the reversed four flange. It's really amazing.
Thank you so much.
Yes, Dr. Safwan, I'm just going to highlight because it's a long presentation, but one before Miltos to start, and we should to say hi to Miltos. Happy that you are here in person, not recorded, as Dr. Muhammad said. Some issues of the Wi-Fi. I know you're in your connections. Dr. Safwan, just one question about the Yemeni. Before cauterizing the haptics, we should make it dry, because
that's what I mentioned. That
yes,
I mentioned that we need to dry the site, because otherwise the cautery will not, and then we will increase the power, and then we will have a very ugly flange. So we need to dry the site and then make a small flange in a way that it will stuck in the tunnel and it will not dislodged. By the way, the stocking in the tunnel is very powerful in a way that sometimes I'm having a lot of complications removing the lenses, not from my side. I'm removing the lenses that's been implanted in Yemeni, and it's just like a fan inside, because they didn't create a tunnel, and 100%, if we are not creating a tunnel, it will be the whole lens will move upside down in all directions.
Thank you, Dr. Safwan. Thank you so much for this illustrated videos. Anyone can do the surgeries after you. You do step by step, and definitely everyone is going to follow what you are doing. So I
thank you very much, Safwan. If there is any question, Ashraf, from any from the colleagues there, Tariq, is there anyone?
Actually, I would like to comment. It was a wonderful surgery, and I don't know if you can hear me. Thank you very much, and thank you for your patience. In Europe, still Wi-Fi is not as great as probably in the areas of United Emirates and all that. But anyway, it happens. I think that we have tried the Yemeni technique. We have tried over the last 10 years also the Canabrava technique and all that. I think that what makes really difference in sclerofixating IOL is the Carlevale lens, and the Carlevale lens has been made for that, and this is really the great advantage. And also the more advanced hydrophobic version of it is even better. And I for the last 4 or 5 years, I have stopped all the other techniques, and my experience over 100 Carlevale lenses shows that it is an extremely good lens with a steep learning curve, I can say, in the beginning, maybe your first 10 cases. But then after that, you will standardize the technique and you will have a reproducible result. I'm really fan, and I have stopped all these wonderful but technically difficult lenses and techniques to use. And I really urge you, I really want to propose you to start using it, and even you can get rid of any AC lenses if you have a stock of AC lenses in your theater, and just have a stock of Carlevale lenses. I think they are great, and it will change your way of doing all that.
Yes, I totally agree, and I think the company, there are 2 companies now, and they're trying to emerge in the in our region, in the Gulf areas and the North.
Don't have it in our region.
Yes, they are trying to make it nowadays, and I think it's going to change the secondary implantation of the IOLs. And really, it's a good lens also for posterior segment surgeon. They love this lens because of there is no tilting and stability even in vitrectomized eyes. Thank you, Miltos, for highlighting this issue. And we should move to your talk. I know that you are expert in this field. So how to manage unhappy patients after multifocal. The multifocal can make the patient unhappy. So how to manage the unhappy of the multifocal? This is a complicated talk, I know. So let's hear it from you, Miltos.
Do have the
video from our side?
Okay.
Hello and good afternoon from Thessaloniki, Greece. I'm Miltos Baliris. I'm going to present the management of an unhappy patient after multifocal IOL implantation. This management has a lot of different aspects that we're going to try to explain in this presentation, but most of the cases we're going to address the importance of taking care of the ocular comorbidity and also of knowing the technology which is behind our IOLs and how can this be an advantage or a disadvantage. One of the things that will be very helpful in the future are these amberometries, which can make clear how the lens is functioning inside the eye. So it's an in vivo function of the aberrations that we have when we have a patient with a multifocal IOL. Here you can see how is this multifocal IOL designed. You can actually understand the distance between different rings, and from that you can maybe realize the type of the IOL, whether it is trifocal or bifocal, and even the manufacturer. Also, here you can see that the central part has a power of 2.20, and in contrast, the central power of another high IOL has 1.75. So this is one interesting difference that we can pinpoint almost at 1 minute when you're looking at these diagrams. We can also see the source of the problem, whether it's coma or spherical aberration or astigmatism. Like in this case, the astigmatism is a bit high. And also we can have a kind of indication of how this patient's visual function is with this simulated chart. Now, finding the cause of the patient dissatisfaction and knowing how to fix it can turn a difficult situation into a happy patient. And this is very important, so that's what I will try to illustrate with all these pictures and theories behind it. Why a patient is not happy with a multifocal IOL? In most of the cases, in the vast majority of the cases, we have promised more things that we can deliver. So the standard thing that you can hear again and again: promise less, deliver more. In other words, under promise, over deliver. The other thing is pre-op assessment. Look for ocular comorbidities. Some of them you can identify preoperatively, and that can save you a lot of time, anxiety, and effort that you will put postoperatively to make a patient happy. When they come and they have problems with the visual acuity, look at the 4 C's, which are cylinder, cornea capsule, cystoid macular edema, and centration. These are situations that in most of the cases you can correct. And for the cylinder, whatever is over 0.75 diopter can be disturbing in a patient with a multifocal IOL. So if you have astigmatism, coincide astigmatism before the operation, then you can use LRIs or opposite clear cornea incisions to treat up to 1 diopter, 1.25. And whatever is over 1.25, then you can use either a toric IOL or use PRK to correct it postoperatively. Cornea. In most of the cases, the patients come to our clinic with dry eye. In some cases, it's not just dry eye, but it's epithelial erosions, a kind of epithelial keratitis, and sometimes there's coexistence of meibomian gland dysfunction or other sources of blepharitis. So treat all these vigorously. Don't wait until they finish the other drops, but start it with cyclosporine or intensive lubricating. Now, it's a completely different thing if they come with an endothelial damage. You will wait for a considerable time for the endothelial damage to improve, but really subtle edema can reduce contraceptivity in an optical system which has already a reduced contraceptivity. So I think that if the patient continuously has corneal edema and you have recorded that in 2 or 3 consecutive visits in 2 to 3 months' time, then it's a time for IOL exchange. These are a few indications which I'm a bit more aggressive to treat with the IOL exchange. Photic phenomena. The vast majority of patients' unhappiness is because of the photic phenomena. Some of them disabling, like in this second picture, that yes, you do have some halos, but most of the time this can be not so disturbing. The patient can do all the visual function without problem. But if it comes to that sort of intensity, then this is almost impossible for the patient to withstand, and that is the non-disabling problem. These unwanted optical images like halo here or glare are sources of IOL technology, are results of the IOL technology. This is a defocused image, and this plays an important role in the ocular operations that we have, this photic phenomenon. When do we have defocus images? When we do monovision, so one eye is for distance and one for near, and when we are focusing or we're looking at the distance object, the near eye will give you a defocused image. Or when we have multifocal IOLs, where we have simultaneous vision, and also we have a simultaneous image in the retina, on the retina, one for distance and the other for intermediate and for near. And of course, we may have it in HOAs, in high order aberrations. The types are two: the negative, which comes in a kind of shadow in the periphery of the visual field, and the positive. We have the starburst, glare, halos. Negative dysautosia only can happen in patients with pseudophakia using an IOL which is square design. If we look at this schematic picture, you can see that when light comes in a 0 degrees from the visual axis, everything is focused on the fovea. But when it comes in 90 degrees, then there is a block, a shadow at the sharp edge of the IOL, and this shadow is creating this peripheral dark part that some people perceive. Now you can understand that if the distance between the pupil and the lens is bigger, then the shadow is more evident. So it's related mostly in the space between pupil and IOL. As for the positive dysphotopsia, some of these dysphotopsias can happen in other causes, either refractive error or can increase even with age. But in most of the cases, it's medically induced by the IOL design. Now, from the high ocular aberrations, you can see that almost all lenses do have some ocular aberrations, but they are not at all the same disturbance in these cases. Some of them are disabling, and usually I'm talking about halos and night driving, and some others are minimally disturbed. So halos and night driving had been shown by the patients that they are the most disturbing effects of the IOL. Simultaneous vision. When we have two images in the same time. Look at the schematic presentation. You can see we're looking for distance, and we have this part of the lens which is for near, the other which is for distance, the sharp image and the defocused image. If we're looking for something for near, then the sharp image is in the center and the defocused is in the peripheral. So when we have two images in the same time or three images in the same time, then we have halos. And when this is more evident, when there is a high contrast situation, like at night, when you have dark background and light, then the second image or third image start appearing more. When you have low contrast, like in daylight, when you have light as a background and the light in front, then this usually the defocused image is suppressed. Trifocals, by definition, have two foci, so they can give you two different halos, but the most important is the second one. Now, two very important factors, size and intensity of the halo. The size is really dominated by the additional power, the IOL power, and the pupil diameter. So the higher the additional power, the larger the pupil size, or the lower the IOL power, then the bigger the halo size. Halo intensity. Here things are simpler. Bifocals and spherical IOLs can give you higher halo intensity. Apodized, when you look at the far object, can give you lower halo intensity. When they look at the near object, then they give you higher halo intensity. So, spherical aberration, bifocals, and apodization are the three factors to consider for the intensity of the halo. Now, why bifocals can give you a worse halo intensity? Let's go back one step and consider how the bifocals are using light intensity. Usually, they split light intensity into a far and distance image. So when they are looking at the far image, we have these two images simultaneously focused on the fovea, and you can see the second image has quite high intensity, so the halo intensity is high. When you're looking at a trifocal lens, the two or three other foci, other from the distant one, have much lower light energy. So because they have lower light energy, the images that they are superimposed for a far distant object have lower intensity. That's why trifocals had less visual disturbance halos than the bifocal. And these are some images. More light energy at near focus, the more concentrated vision at near, but the more halo intensity at far. This is one thing to keep in mind. The other problem for light dispersion, usually for the multifocal IOL patient, is due to PCO. So posterior capsular opacification can cause this kind of dispersion and can be treated with YAG laser. IOL saturation, one thing to remember when you have your Xiphilong or your Pentacam, always look at the cap angle, especially when you have high hypermetra patient. Look at the angle kappa and look at the number of angle kappa. If it's more than 0.4, then this is a contraindication for multifocal IOL because you will induce aberrations, because the IOL is going to be descended from the visual axis, and that can cause multiple high order aberrations, especially like coma and other ones. Look at the IOL technology relatively to the limbus, and then if there is a descended pupil, or in some cases we've seen that the pupil, when it gets smaller, it is slightly descended, we can fix that with argon laser iridoplasty or a surgical papilloplasty to bring the pupil in the center of the IOL. Now, because we know the IOL technology, we know that in most of the trifocals, the central part is the near vision part. So if the near vision part is not as strong, what we can do is, by using the pupil, we can direct more light into the area that we want to make stronger. So if someone has to have a stronger adding power and it's not sufficient enough for the patient to read, then we can use a pupil constrictive drop like brimonidine or Pilo when they're reading, in order to constrict the pupil and direct more light into the central part of the lens. If the problem is in the distant part and it's not related to a refractive error, then maybe diluted mydriatic, especially in some old patient's pupil where they're in a smaller pupil than the normal, then a bit of a diluted mydriatic will help the distance, the light to go more for the distance vision and improve the distance vision of these patients. And always look at the retina. In cataract surgery, during cataract surgery, we may have over 70% of macular thickening, and 12% can be significant. So always use an RCT to check how is the retina postoperatively and treat. And in some cases, like I do most often, I use a prophylactic non-steroidal anti-inflammatory in order to prevent any cystoid macular edema postoperatively. In cases with epiretinal membrane or lamellar hole, then the approach should be surgical and in a different way. Posterior capsular opacification, we have discussed in the past, that usually causes contrast sensitivity and glare, and make sure that when you decide to do a YAG capsulotomy, the source of the problem is there and it's not a refractive problem or glare on halo, which is going to sometimes be even worse after the YAG capsulotomy. So if it's a problem of low visual acuity, low contrast sensitivity or glare, then proceed for a YAG. Now to summarize the pearls for the multifocal IOL patient. Preoperatively, be careful with the low myopes, with the high addition IOLs, bifocals and sphericals. Always treat the ocular comorbidity, if possible, before doing the operation. And for IOL exchange, should be your last option. And this is my quick algorithm. What is the refractive status? If there's no problem with refraction, then it's a little bit of a joker. So look at the IOL, the pupil, the positioning between the two, identify what is sort of the photic phenomenon where the patient visual acuity is disturbed. And if there's a problem with the pupil, then do argon or surgical iridoplasty. Very rarely you need to exchange or reposition. Look at the IOL properties. If it's a near vision problem, myotics. If it's a distance vision problem, mydriatics. If it's a problem at the IOL technology, then consider IOL exchange. And if there's a glare, then also some other low contrast or low visual acuity, consider doing young capsulotomy. If there's a residual refractive correction, correct it quickly, fix it quickly. Specs or refractive surgery will do the trick. And just one word for IOL exchange. Proceed with deliberation. This cannot be your first option, can be only your last. Try to identify if this is a source of a problem, so use a trial of RGB lenses, gas permeable lenses, and if the vision improves with that, then you can understand that the problem is the IOL. Do it quickly. Know how to do a good anterior vitrectomy, and handle the haptics with care, because you will need the capsule for the implantation of the other lens. And with that, I would like to thank you and conclude our presentation.
Thank you, dear Meltos. It's a very big presentation also. It's not an easy issue. It's a very big problem. But
as I say, Azrep, it's a very big problem, because in most of the cases, it's a problem created by us. It's a medical problem. So we have patients with high demands. We give them these lenses, and if they're not absolutely sure what we have offered to them, then the problem starts. So it's a medical, let's say, disease caused by us, iatrogenic.
So we can summarize it in 3 steps. Steps before the operation, that everything should be okay for the patient, from the cornea, ocular surface till the retina. Steps intraoperative, choosing the type of the IOL, which is the most perfect for this eye of the patient. Not all IOLs goes for all the patients. And surgical steps should be in a proper way. Post-operative, as you said, you should deal with the problems when we put the IOL according to the situation. Either we manage with the IOL inside the eye, or we do the last option, as you said, exchange the IOL, or change the type of the IOL, because sometimes you use one eye, change one eye and leave the other eye according to the situation.
I'm on a happy and maybe difficult situations that most of the companies are sending the lenses, so that I do small studies to understand how the lenses are working, so that I can explain to the patient. And beware, never look at any sort of advertising stuff from the companies. It is never going to stay the line. Never look at companies made papers. I think whenever they approach you, just ask them to either give you a name of someone who is using it more often, and they can give you some details. They always come. I remember when the EDOF came out, and they said, well, the EDOF didn't have glare and halos. Well, the EDOF do have halos, especially the early EDOF lenses of the AMO lenses, we have a devastating halo. So always consider to try to discuss, because there are some lenses who can give you a lot of benefits. And listen to your patients. Listen to your patients' needs. Explain to them that they may have a benefit one thing and then lose something else. If they do that, then simple tricks like pilocarping or mydriatics can do your stuff.
Do you have questions from the audience?
Dr. Ashraf, we are running behind the time. If you allow me, we can take the last presentation. And if you have a time, we can discuss any point, please.
We can present Dr. Safa Gihad from Morocco. I think her topic should be the first one, because she's going to talk about ocular surface disease before any cataract surgery, whatever the cataract surgery is. So this is the best ending for the first talk. So please, Safa, can you represent this talk, which is a very important issue nowadays in all our
I'm trying to share my screen. Give me just a while. Cannot reach you. Wait.
Open the presentation first. Open the PowerPoint. Yes, and then choose share. You are going to find it.
Yes, wait, share. No, I didn't find it. I'm on Zoom, but I didn't find it. Sorry.
Okay, Safa, can you just close everything, then open your presentation only, make it open, then go to the click on the Zoom on the arrow to share the screen.
The desktop.
You don't need to go. Okay.
I cannot reach. I cannot share my screen. I don't have the access to.
No. Just go back.
You need to open the
your
Zoom
presentation.
It is already open.
On the
Okay,
Zoom
after
screen,
that,
and you will
go to
find it down on the middle.
Now it will be then an arrow, green arrow.
Yes, in the middle down.
Yes,
So
but
share,
it gives me basic fichier or wait. No, I don't have access to the presentation. Wait. There is a problem. Help.
Okay.
You are not sharing your screen.
Okay, can you do one thing? Can you give us your, you have open Soria, if you can please access her laptop, please?
Yes.
Yes, sir. Ma'am, do you have any desk with you?
You have any desk with you? Any desk?
No, Doctor. Open your presentation separately.
It is
Minimize.
open.
Open
then you
it.
might be able to see the share screen button, center
Open
of the screen.
At the bottom of your screen.
Click there on the basic. You might be able to see the PowerPoint
Now,
presentation.
when I click on Zoom, when I try to share my screen, it gives me a screen with the basic, advanced.
Yes, ma'am.
Yes.
Basic. You have to go on the basic.
Basic, okay.
Yes, ma'am. And then, ma'am, you can share your screen from there.
Okay, share. They ask me if I want to open the preference system. I allow.
Yes, ma'am, you can.
Yes, and I utiliser le mot de passe.
So maybe
we have
you can discuss
okay.
Can I ask a question to you first, Validas? Thank you for your presentation.
Can you discuss?
The traditional questions that we always face, will you use a multifocal lenses or trifocal lenses in post-laser vision correction, because these are the most demanding patients that are keen to be free of glasses after cataract surgeries. So what are your recommendations for those patients?
Well, for patients that they have undergone, well, first of all, let's take two different kind of approaches. If they had LASIK or PRK, in some cases, we can use it, and I will explain to you what kind of lenses. If they have RKs, I never put on RKs any sort of multifocal. Now, if the initial treatment was a low minus, like 1 or 2 diopters or 2.5 diopters, and the topography that you have is a quite normal topography, and you don't have many differences that you can understand that is a big problem, or if a patient had an astigmatic correction, again, a low astigmatic, I have no problem of using a trifocal lens, although I'm looking at the asphericity and sometimes I put an EDOF lens. Now, if I have hyperopia of 1 or 2 or 3 diopters, then I prefer to use an EDOF lens because that will augment the positive asphericity that some EDOF lenses like the Technis Eye-Hans have. So in a way, if you use a Technis Eye-Hans in a hyperopic patient that has a hyperopic LASIK, then it will be augmented your result. But I will never use an aspheric lens on hyperopic in a post-hyperopic LASIK treatment. I will use either a standard spherical lens or I will use an eye-hands lens for these cases. Now, whatever is more than that, then I will go for an EDOF or a standard lens. But I always explain to the patient that when I have, for instance, a patient that has -6 or -7 diopter previous LASIK treatment, then obviously by the way, negative or positive asphericity, spherical aberration, can give you a depth of focus. It doesn't have to be only positive. Even the negative can give you a depth of focus in a different way. So both of them, we have a kind of a depth of focus because of their laser pigment, and I will use a kind of EDOF lens for them. But I will avoid trifocal lenses if they have a very high previous LASIK correction, high in diopters.
Okay, EDOF monofocal lenses, because then we have EDOF trifocal and EDOF monofocal.
No,
so
because
using EDOF monofocal lenses.
Sorry, what? I didn't hear you.
You are using EDOF monofocal lenses.
But they do the extended monofocals.
Depth of focus.
Or now I'm using pure EDOF, like the Elon lens, the Elon lens from Medicontour. Another one from Germany, which is the
IC8.
No, the
IC8.
No, it used to be Comfort. Now they have a different name. I don't remember now. But I'm doing a study on Elon lenses, which are similar to the Alcon Vivity. Similar.
Yeah.
Both of them, Alcon Vivity and Elon, had very good performance up to about 40 millimeters. But they also, both of them, reduce a little bit the contrast sensitivity, not much. The other thing is, of course, the price, which is almost half in between comparison. But anyway.
So just one comment.
Yeah.
Just one comment that's important, because when you are saying that the patient after hyperopic, yes, I do agree that I'm seeing the spherical abrasion, whether it's negative or positive, and when it's negative, I'm using even the modified EDOF, means that refractive EDOF, not diffractive EDOF. Definitely, K-reading post-op, hyperopic treatment is an important issues with the high order abrasions also. Some lasers can create some high order abrasions in coma site, not only in the spherical. I think that the presentation start to be ready for Safa.
Okay, I think Safa is now ready. If we can allow her to give a very fast talk. We are sorry for
Unmute.
Can you mute yourself?
Unmute, Safa.
Safa, unmute.
Okay, can you, the IT, unmute Dr. Safa from your side, please? Okay, unmute yourself. Unmute
yourself, Dr. Safa. We are not hearing you. We are not hearing you, Dr. Safa.
Is it okay now?
Yes.
Excellent.
Thank you.
Well, I'm really sorry for this problem, and I promise you that it will be a light dessert after all what we heard today in this session. Well, let's go. I'm gonna try to answer to this question. Is dry eye a problem in cataract surgery? I wanna thank everybody, the team of Miyom and all the Yemeni societies, of course, for inviting me. And the answer is obviously yes, it's a problem, because managing an ocular surface disease is the key of cataract surgery. Because if after having done what you have brilliantly presented today in your session, we still have an unhappy patient, it is definitely a problem. And the answer is reside first in our Hippocratic oaths that compels us first to do no harm. And when we are worsening a pre-existing fragility, it is in fact a harm. Well, you will certainly recognize Mrs. S that came to our office of all of us 3 months after the surgery. She did what she calls just a cataract. It was a phaco with a monofocal implant. The surgery was okay, good postoperative refraction, good incision, good rhexis, while the patient reports foreign body sensation, tearing, fluctuation, blurred vision, especially at night and while reading. And she specifies that she has no complaints before surgery, apart from the decrease of vision, of course. Well, before doing a macular OCT or a capsulotomy, let's have a step back and let's see if we didn't miss something on the ocular surface. Indeed, this patient has many abnormalities in the ocular surface. She has an unstable breakup time with a tear film, a bad tear film, some crusts and foam on the lid margin, meibomitis, a Meibo scale grade 2. And we did an ocular surface analyzer that confirmed this evaporative dryness with lipid deficiency, with some bad no invasive breakup time. And I confirmed by corneal topography that shows many irregularities on the anterior surface. The epithelial mapping shows two focal thinning and many irregularities in the anterior surface. Well, I treated her, but I still see her permanently every 2 or 3 months with the same complaints. Doctor, they have cut a nerve under my eyelid and I see it and I feel it just right here. Here is my first golden rule. It is much easier to treat a patient which was informed that to explain him afterward that it wasn't your surgery that was responsible for the bad postoperative course, and premium IOL patients are less forgiving. Do you believe that the initial contract with Mrs. S was fulfilled? Maybe not, because we should understand first what does quality of vision and supervision mean. It's not seeing more than 20/20, but it's being able to see good in all life conditions. And this is definitely related to the tear film, which is one of the main actors. What Mrs. S have is what typhus due 2 described as iatrogenic dry eye caused by the disruption of the ocular surface homeostasis. And this is what makes the third of our 2020 patients unhappy after a monofocal IOL, and more than it is the second cause of insatisfaction after premium IOL. Dry eye patient and cataract patient have many similarities. They both are very common pathologies. They both are age-related, and 80% of our candidates of cataract surgery have dry eye. They have also many comorbidities and take some drugs that can make the surface worse. This is here my second golden rule, which is to have a good history taken and ask about risk factor that can make things worse. We are facing a population with frail ocular surface because 75% are underdiagnosed and have asymptomatic dry eye, and the mammalian gland dysfunction exists in more than half of our refractive surgery patients. Dry eye in cataract patients has been brilliantly described in phaco study published by William Trottle that shows that 77% of our patients have corneal staining and more than 60% have a bad tear breakup time. Well, how dry eye affects cataract surgery? To understand, we should first understand the role of the tear film. The tear film is the most important and the first refractive surface of the eye. A dry eye have an irregular tear film with a thickness less than 20 micron, with a variation of refraction reaching 1.3 diopter and higher order aberration that can be more 25% than a normal eye. Now, this is a wonderful study that shows the variation and the changes of the wavefront aberration between 2 blinks. And the conclusion is that the lowest degree of high order aberration is seen between the 6th and the 8th seconds. And that make us conclude this the third golden rule, which is the best time to take any capture with any device using the anterior surface parameters is between 6 and 7 seconds after the blink. Fortunately, dry eye treatment improves quality of vision, as we see here the improvement of high order aberration and the point spread function after a drop of lubricants. Now, what about the preoperative testing? We know that dry eye changes the K reading, it gives inaccurate biometry, and this is more noticeable with premium IOL. This is what is already known. But what we learned recently is that astigmatism changes up to 35% in dry eye patient, and pain can last and remain after the 6 months in 35% after surgery in dry eye patient, and the dry eye is responsible for a postoperative visual fluctuation and an increase of high order aberrations. This is a wonderful paper published by Petropoulos and his team in the Journal of Cataract and Refractive Surgery that shows the link between the hyperosmolarity and the error in the refractive in the biometry. It shows that people with higher osmolarity in pre-op have more risk to develop post-refractive surprises up to 5.5 diopter. Now let's see how cataract surgery affects dry eye. Cataract surgery leads to a decrease in breakup time, decrease in Schirmer test, and it can lead to the occurrence or the worsening of the ocular surface dryness symptom in both groups, those who are already known as dry eye group and those who are not. Now, what about the lid margin? Cataract surgery leads to abnormalities of the lid margin. It alters the secretion and the quality of the meibomian, and it leads to a worsening of meibomian score, and this is significantly worse if the patient is already having a dry eye. The heterogeneity depends on the stage of the surgery. The speculum leads to the lid dysfunction by compression and obstruction of meibomian gland. The povidoniodine and the anesthetic leads to a tear film instability with less mucus production. The incision leads to a nerve suction, yes, and an alteration of the corneal sensitivity, the blink reflex, and the lacrimal secretion, and the microscope, the light of the microscope leads to phototoxicity. And last but not least, the drops with the preservative toxicity leads to a tear film instability. Now, once happened, how to manage? 3 keywords: prevent, prepare, and treat. We agree all that it needs an additional time to detect, to inform, and to treat if pre-existing dry eye, eyelid hygiene, preservative-free artificial tears, and maybe to initiate, if needed, the anti-inflammatory treatments, doxycycline, and nutritional substitute. During surgery, we need to remember that we should limit the operating time, use the topical anesthesia reasonably, just shortly before surgery, preservative-free with the viscous agents, ideally, adapt the brightness of the microscope, hydrate the cornea, but not too much, use HPMC ideally to minimize the incision site and to avoid limbal relaxing incision in dry patient. After surgery, 3 keywords: hear the patient, trust the patient, and treat the patient, because an unsatisfied patient with dry eye suffers. He is not an annoying patient. You should treat him aggressively with artificial tear, many drops a day, to slowly decrease till 4 times a day. And if pre-existing dry eye, we can maintain the treatment 2 months with 2 drops a day. Well, we still have an unmet aim, which is to try to identify healthy persons that are susceptible to develop dry eye symptom after cataract surgery. And that was the aim of Vellani and his team with this paper. They tried to build an ocular Frailty index based on some simple data with non-invasive and low-cost procedure. They put a cutoff value of 0.3, above which the cataract asymptomatic candidates are highly risky to have a post-surgical dry eye symptoms. Knowing the importance of this issue, the Asper's corneal team developed an algorithm to aid surgeon in efficiently diagnose and treat visual ocular surface disease before any form of refractive surgery. And the cataract and refractive surgery are one and the same, because which step of cataract surgery is not a refractive one? Now, my take-home messages are those. We are in a never-evolving field, which is the cataract procedure. We reached the increasing of safety and efficiency, but challenges increase exponentially with ocular surface disease. Cataract surgery today is not a technique to improve visual acuity, but it's a path for a better quality of life. Ocular surface should be carefully evaluated, optimized to predict the exacerbation and to provide the explanation of post-op dry eye. And our patient will be more accepting if they were before, if it were explained before, and we are relying on the artificial intelligence that can help us to be more comfortable with those kind of patient. Thank you.
Thank you very much, Dr. Safa. It was very nice and excellent. It is one of the best talk. Thank you very much.
I tried to do it lazy because because it was time is taken away.
Then you stop.
I do apologize from the next sessions, but I think this last talk we present, it can be part from their presentation, because oculoplasty, they will talk about usually about, so yes, 15 minutes, we didn't take any 15 minutes from them. So we are exceeding only by 15 minutes. Shukran, Dr. Mahmoud, Dr. Isam, thank you for giving us more time, because we start actually a little bit late. I'd like to thank all our speakers in our session, Dr. Ashraf, Dr. Safan, Dr. Miltos, Dr. Khalid, and Dr. Bria, and Dr. Safa for this excellent presentation as usual. And thanks for Yemen Ophthalmic Society for giving MIOM this opportunity to participate with them. And I will handle if there is any question or comment before we conclude our session. We know we are late. If there is any word from you, Dr. Ashraf, before we conclude, or any one of our colleagues.
I want to thank every one of the speakers. Every talk was eminent, and they give the best explanation for the topic that was suggested for the talks. Thanks for everyone. Thanks for the Yemeni ophthalmology conference. Thanks for Dr. Muhammad, who gathered us together all together. And I want to say hi to Dr. Mahmoud and Dr. Asam. And
thank you, everyone. Thank you, Dr. Ashraf, Dr.
Thank
Muhammad.
you very much. From our side, we can say goodbye and see you, inshallah, in the future. Inshallah. Thank you. Assalamu alaikum. Bye-bye.
Bye-bye.
دكتور أروطل.
مش عارف.
السلام عليكم.
وعليكم السلام.
السلام ورحمة الله وبركاته.
دكتور محمود ودكتور، مساء الخير.
أهلين، أهلا وسهلا.
مساء النور.
عشان ما نضيعش. I want to share my screen if
okay.
If you want to. We are in the right time, hopefully. Okay, joint meeting. في الحكاية. Okay. Okay. Do you appreciate my screen?
Yes. Next speaker, Prof. Mahmoud Salim, one of the most senior and pioneer in oculoplastic and ocular orbital reconstruction, not in Jordan, but in Middle East. He will talk about bears and pitfall in evaluation of ptosis patients.
Fine. Thank you, Dr. Tariq. I am grateful that you gave me this opportunity. It's very, very good that I meet friends from Yemen. I have been twice to Yemen, Sana'a, and once to Aden. I do remember this visit very well. Fine. About my presentation, actually, I want to tell you that there is maybe nothing much new about it, because it is ptosis, work above ptosis, but it is case-oriented approach. So we will go by this in 15 minutes or less, and hopefully, and I will show you how. So the ptosis could be congenital or acquired, and every one of us would like to have as good results as this, for example. But to achieve this, you have to know a little bit of the anatomy and the physiology of the levator muscle complex, which is the levator and the molar muscle. The voice is okay for you? Fine. So the levator opens the lid and helps in closure as well. And it must relax in down gaze or closure. Why do we have to have the molar muscle? The difference lies in the two types of muscle, the skeletal muscle versus the smooth muscle. Skeletal muscle is very powerful, but it's easily fatigability. Smooth muscles like molar muscle, it will have a very weak power, but poor fatigability. Yeah, I mean, it doesn't get fatigued easily. So in this talk, and the audience will appreciate a true ptosis from pseudoptosis, to spot straightforward ptosis cases from difficult ones, and to identify surgical cases from neurological problem, and to know the different ptosis syndromes. Let us just stop at this patient who I have seen several years back, and I learned a lesson from him. A child was referred for ptosis surgery, very poor levator function, and less than 4 millimeter, history of recent onset, ptosis for 2 weeks, and normal ocular motility. And I asked for old photograph, and it's true, it's acquired one. Acquired one in a child, it needs workup, and it needs to pay attention to that. But you don't decide for surgery at all, but you would wait if the neuroimaging is normal. And this is before, and this is the patient in 6 weeks later. So it completely gone away. I mean, this is kind of viral kind of levator muscle palsy and so forth. Another patient that really you can learn out of him, when I saw this patient in Qatar, actually, and he had this appearance with actually, he has wide left eyelids, and this appearance, and he claims that this eye is abnormal one, and this is his close-up picture, and the snag is that when you nullify his brow, and make it almost the same, you will see and appreciate the ptosis in the right eye. So he has got a false presentation, compensatory brow retraction, and typically occurs in ptosis of a dominant eye. So congenital ptosis, 75% of them looks unilateral, and it's generally simply pure ptosis, usually sporadic, however, occasionally positive family history. And some of them will be associated with superior rectus weakness as well, but could be very severe. And the severity is noted by absence of lid crease. Okay, and the severity, that means you want to test the excursion of the eyelids. Not the excursion, but the width of the eyelids, itself, or the marginal reflex distance. And this is mild, moderate, or severe, of 1 to 2 millimeter, 3 millimeter, 4 millimeter, and more, and so forth. And this is just a standard everywhere. This is the severity of the ptosis, I mean the degree of the ptosis. But congenital ptosis could be caused by primary dystrophy of the levator muscle, with it lag in down position. This is very important. This is shown here in this patient photograph. And not that only, but also it stays even in adult patients. Even in adult patients, when you see the lid lag in down position, you should think of congenital ptosis. So the compensation for the lid ptosis is a frontalis overactivity and chin-up position. But the best classification I found for ptosis is ptosis with good levator function versus that with ptosis with poor levator function. This is the best classification so far. And because it depends on this classification, the management will come on. There is two kinds of dystrophy, muscle dystrophy, and myogenic ptosis. And this is the lid lag in down position here. Of course, you should pay attention to the amblyopia, which is detected in approximately 20% of patients with secondary convergence strabismus, high astigmatism, and anisometropia. Okay. And here the myodystrophy and aponeurotic ptosis. And this is how it shows the difference in these cases where this is the lid lag in down position, and here the lid lag as absent in this position, and the other hand it is completely downwards. This is the aponeurotic ptosis. So the aponeurotic ptosis actually is very common, and it is due to age, use of contact lenses, prosthetic eye, and a lot of senile cases, sometimes rubbing allergy and traumatic. And these are two cases typically of aponeurotic origin with good levator function to start with. Okay, and here they can do them by local anesthesia with intravenous light sedation. These are cases that is kind of gift from God to the oculoplastic surgeon. This is very easy to do, very good results. Usually we will achieve as if you are doing a really adjustable suture. And now, common pitfalls in evaluating ptosis. The first common pitfall is that when there is a presence of like these two patients, actually, they look at this right eye here, also the right eye here, and but you ask them to look up. If you ask them to look up, you will appreciate that they have got enophthalmos. I mean, enophthalmic eyes. Okay, the enophthalmos is one of the causes that tells you that doesn't really. It's not a true ptosis, but it's a pseudoptosis. Also, microphthalmos, or this patient with little bit facial asymmetry, and you should appreciate and detect this. This is not a true ptosis. Also, when you have a dermatochalasis, this Sudanese patient with congenital bilateral dermatochalasis, and all what he needs is actually to address his dermatochalasis. And this is unilateral traumatic, what you call it, dermatochalasis. And this is what you call it, eyelash, the eyelash ptosis somehow. Now, there is also brow ptosis. Brow ptosis, this is very important for any ophthalmologist to pick up the brow ptosis. Brow ptosis easily. You just actually put your fingers over the orbital margin. This is where the eyebrow should be, over the orbital margin clearly. And these patients falsely presented as ptosis, but they have actually brow ptosis, and we treat them by just addressing their brow ptosis. Now, also hypotropia. Hypotropia, for example, this girl with even she has got a prosthetic eye. Okay, you look at her, and this patient, hopefully the video will you appreciate how the hypotropia will cause kind of ptosis. And for example, this patient, what type of surgery you think we had done? Actually, we did a plate in the floor of the orbit to elevate the prosthetic eye, and then the hair ptosis was corrected. Now, these are typical ptosis patients that everyone has got his story, but very important, crucial to distinguish between patients with ptosis who are potentially surgical patients and those from neurological cases, neurological origin. Ptosis can be done in as adjustable suture, I told you, in adults and under local anesthesia. It gives good results. First one, myasthenia gravis. Myasthenia gravis and external ophthalmoplegia, of course. Okay. External ophthalmoplegia here. And also, you should appreciate the neurofibromatosis and the plexiform neuroma. And these are not typical ptosis. They are different type of ptosis you have to deal with sometimes, if between two brackets, consider them as ptosis. Also, what now you suspect this, the patient who has got anisocoria more apparent in the dark, and this is Horner syndrome. Horner syndrome is an important milestone in medicine. Every eye doctor should appreciate really Horner, because it's a cocktail of several things. One of them is 2 millimeter ptosis and so forth, and you should appreciate. Sometimes they come to surgery. The fifth cause of the neurological cause is the third nerve palsy. Whether it is congenital, as this, or it is acquired, whether pupil sparing or pupil involving. Or you should look for the patient in all these degrees. Should look at the pupil, should look at the ocular motility, and really before you say it is simple ptosis. But sometimes third nerve palsy can be operable. Once you can really correct the eye balance, then you can really have a good result with ptosis surgery in these patients. Okay, this patient had head trauma actually 4 years back, and she said, I couldn't see my eye for the last 4 years, and then we operated in her, and she had this result. Fine. Now, for children, once you can, or you will be able to take a measurement for the levator function, then you can do operation, surgery on them. And this could be as early as 2 to 5 years, and clearly above school age. And especially in unilateral ptosis, the best is to do levator resection, and it gives you very good results with gapping methods and so forth. There is no time for videos, but I will continue. Now, this is the most important thing. The most important thing for assessing the ptosis, as I told you, to assess whether it's a good levator function or poor levator function. And the levator function could be assessed by simple ruler, and you nullify the brow position, and then you take the measurement, and if it is poor, if less than 4, and moderate 5 to 10, or excellent, and so forth. And this is actually can be done by the age of 3 years in most children. Now, not every aponeurotic ptosis will have poor levator function. Look at this man. I said home in Qatar also. Actually, this man, he had very poor levator function, but I guess that he has aponeurotic ptosis with total levator disinsertion, with total aponeurotic disinsertion. We restored his look or corrected his ptosis by simple surgery on the levator aponeurosis. And now, for a senile ptosis, if you have senile ptosis, then you should consider what we call it essential, senile ptosis repair with upper lid blepharoplasty with it. Okay, not only upper lid blepharoplasty, but sometimes you have to do the lower tarsal sling as well. Synaltosis is considered really a different ball game somehow. I want to introduce you to the term, whether Dr. Asam al-Tuhi will agree or not, to what you call it complicated ptosis versus simple ptosis. I still say simple ptosis can be operated by general ophthalmologists. They simple cataract, simple squint, even give corneal graft, whatever. But complicated cases can be referred to oculoplastic surgeon. And this is one of them. For example, when you have kind of orbital and eyelid orbital varices and so forth. Not all the orbital varices you have to deal with, but also this is the abnormal muscle as well. Also, this girl with previous trauma to the eyelid and fibrosis of the levator and so forth. And so you have to address. This is what I call complicated ptosis. It's not a simple ones. Also, this lady with a road traffic accident that was operated on. The snag is that when you operate, you don't use absorbable suture for these cases. You do Prolene or Athibond suture, and you do them under local. You can find the levator muscle. Also, sometimes if this, I am almost about to finish. Hopefully, I'm not taking somebody's time. Complicated ptosis also. Sometimes when there is muscle imbalance, this is just happened to be a Yemeni girl, actually, that I have shown at the age of 14, that was 10 years back and so forth. And she had this ptosis as well and exotropia. And the man said, you have only 4 days to correct her. And she had no chance to come back, to come back again to Old Jordan. So I operated on her and I did the squint and the ptosis surgery all in one day. So in these cases, you would like also to attend to ocular balance as well and take care of eyelash and avoiding eyelash ptosis as well. Two syndromes are linked with ptosis, and this one of them is blepharophomosis. And these girls, you should appreciate, these are the same girls that I was operated on when they were young. And also this man or this gentleman or just boy that was also attended to. And these are a syndrome of severe ptosis, epicatetic falls, telecanthus inversus, and blepharophomosis, and so forth. And the last maybe syndrome is the Marcus gun jaw winking, and this is, you should spot. You should spot early on. And this is the same girl. This is the same girl after 4 years back. Okay. Okay. So in summary, common pitfalls are management before diagnosis is inability to determine dominant eye in unilateral cases, missing eye protective mechanism, blinking, Bill's phenomena, wetting reflexes, and corneal sensation, and improper evaluation, laterality, asymmetry, and associated muscle imbalance, pupil, like seclude-hornal, blepharophomosis, jaw winking, and also you want to do phenylephrine test. Okay. And it's very important that you really differentiate between what's congenital and acquired bilateral and unilateral cases, and be aware of asymmetry, associated ocular or frontalis weakness, avoid Bissing Horner and associated brow ptosis. And this is how we management. This is not our stuff in this presentation. And here, okay, thank you for your listening. Thank you for your time. I hope I was benefiting you and give you really what you expected. Thank you.
Okay, thank you, Prof. محمود. Next speaker, Prof. عصام الطوخي. الدكتور عصام طبعا غني عن التعريف. Professor of Ophthalmology, Cairo University, Director Oculoplastic Surface, Chairman of the Egyptian Scientific Council of Ophthalmology, Head of Examination, Arab Board of Ophthalmology. The Dr. Isam will speak about corneal necrotization.
مساء الخير. اولا انا يعني بشكر الدكتور طارق وكل اعضاء اللجنه المنظمه وجمعيه اطباء العيون اليمنيه. حضراتكم يعني مش محتاج اقول لكم ان انا مصري، ولكني مصري الجنسيه ولكني يمني الهوى يعني، والكل يعلم ذلك. وباذن الله يعني لقائنا القادم باذن الله هيكون في صنعاء ان شاء الله. وانا احب النهارده ان انا اشير مع حضراتكم يعني what is considered اهم جديد او تطور في الاوكيلوبلاستي اللي حصل في ال3-4 سنين اللي فاتوا. هي was chosen كده في 21، ولا تزال هذه العمليه او هذا التطور لانه بيفتح لنا باب ومجال جديد تماما، هو الكورنيال نيوروتايزيشن. انا بحاول اشير السكرين يا فندم، بس لسه مش في حد تاني عامل شير.
محمود عمل شير، عمل كلوز.
ايه هي الكورنيال نيوروتايزيشن؟
الدكتور
الكورنيال نيوروتايزيشن انا في حاجات لها كوبي رايتس من اللي في البرزنتيشن، ان انا برجع تاني السنسيشن للكورنيا اللي فقدت السنسيشن بتاعها. فام ريستورينج الانرفيشن للنيوروتروفيك كيراتوباثي. ولازم نعرف اولا ان الكورنيا is the most sensitive structure in the body، من 300 ل 600 مره more sensitive than the skin. وده ضروري ومهم جدا لان في functions معتمده تماما على الكورنيال سنسيشن، اشهرهم البلينكينج، التيرينج، والكورنيال ووند هيلينج. اصل احنا عارفين ان في علاقه متبادله بين الكورنيال انرفيشن والحياه الكورنيال ابيثيليوم. الكورنيال ابيثيليوم ما يقدرش يعيش من غير كورنيال انرفيشن، والكورنيال نيرفز معتمده على وجود انتاكت ابيثيليوم. يبقى الاثنين بينهم علاقه متبادله بيسموها سيمبايوزس، الاثنين لازم يعتمدوا على بعض. وكلنا عارفين وشفنا الحالات اللي الكورنيال سنسيشن فيها بيتاثر، زي بوست اوبراتيف في حالات النيوروسيرجري، زي الكيميكال بيرنز، وحاجات تانية كتيرة، ليبروزي، في عيانين كتير ليبروزي لسه موجودين. الكورنيا بتوباسيفاي والإبيثيليوم بيقع وينتهي الأمر at the end بأوباستيز وبرفوريشن كمان. وبالتالي الكورنيال نيرفز مش مجرد إحساس، ده إحساس بيترجم إلى وظائف. وعندنا two very important reflexes، واحد منهم sensory اللي هو الريفلكس تيرينج، وواحد منهم موتور اللي هو الريفلكس بلينكينج. الاثنين دول معتمدين تماما على كورنيال انرفيشن مظبوط. ودي الصوره التقليديه بتاعت الهيلثي اي. انا عندي سنسورز موجودين في الكورنيا وشويه في الكونجنكتيفا، بيحسوا، بيروحوا للبرين يدوا له الافرنت، البرين بيبعت الايفرنت يا اما من خلال اللاكريمال جلاند يا اما من خلال الفيشيال نيرف في البلينكينج والموتور. فذيس از ذا نورمال هيلثي اي. لو السايكل دي، اللوب ده اتقطع وما بقاش عندي كورنيال نيرفز، انا خسرت الكورنيا تماما، وبالتالي خسرت الفيجن. لسه السيشن اللي قبلينا كانوا بيقولوا ان the most important refractive structure هي الكورنيا والتير فيلم اللي قدامها. عارفين كمان ان في حوالي من 50 واكتر نيرف تيرمينال اندينجز بيعملوا plexus around the limbus وبيبرفوريت ويدخلوا الكورنيا from the limbus. والتروما والانجري بيبقى عالي جدا في الناس اللي الافكشن فيها دبل، يعني الترايجيمينال افكتد السنسوري والفيشيال افكتد الموتور. لو الاثنين دول بقى حصل الانجري مع بعض، وده بنشوفه كتير في حالات التروماز او في حالات البوست نيورو سيرجيكال بروسيديرز. الناس اللي زي مثلا بنشتغل في مستشفى جامعي، مستشفى كبير، عندنا قسم نيورو سيرجري، بنشوف كتير جدا بعد عمليات البرين ان بيحصل فيشال نيرف بولسي، ده كومن، لكن كومبايند فيشال وتراجيمينال نيرف، وبالتالي الانجري بيبقى اكتر. طب ايه الكوزز اللي ديسترب الكورنيال انرفيشن؟ عندنا حاجات سيستميك، اشهرها طبعا الدايابيتس عشان الاعداد، الام اس، الليبرزي في الاماكن اللي لسه فيها شويه ليبرزي، الكيميكال وانجريز، موضوع مهم جدا بيحصل فيها لوس للكورنيال سنسيشن. السيفير اوكيولار سيرفيس ديزيز، ستيفن جونسون وسيكاتريشال بينفيجويد، وحضراتكم شفتوا كتير قوي الحالات دي والميزربل ريزلت اللي بيأند اب الحالات دي، لاني في افكشن للكورنيال انرفيشن. استخدام السنوات وسنوات للكونتاكت لينس بيقلل الكورنيال انرفيشن. عندنا حالتين الحقيقه هم عمال وكان دايما بيدقوا فيدخل رايش على الكورنيا، فتعودوا انهم ياخدوا القطره الانستاتيك فبقوا بيستخدموها على طول. فالتوبيكال ابيوز اوف انستاتيك ار دروبس بيعمل لوس اوف كورنيال سنسيشن. زي ما قلنا الانجري للترايجيمينال سواء بانتراكرينيال ليجنز او بوست اوبراتيف بعد النيورو سيرجري. لكن اللي ادى بقى للموضوع اهميه قصوى وخلاه فيري هوت في السنتين ثلاثه اللي فاتوا وخلوا الناس تدور هو البوست ريفراكتيف سيرجري. كلنا نعلم الملايين على مستوى العالم اللي بيعملوا ريفراكتيف بروسيديرز، اللي السنجل ستيب الاساسي في الليزك هو ان انا باجي بالمايكرو كيراتوم واقطع بالعرض الكورنيال نيرفز وانتظر ان الكورنيال انرفيشن دوت يرجع في خلال اسابيع الى شهور. نسبه قليله جدا الكورنيال انرفيشن ما بيرجعش، ولكن نتيجه ان البروسيدير ده بيتعمل على ملايين من الناس، هذه النسبه القليله اظهرت لنا حالات كتيره قوي اللي اكيد حضراتكم عارفينها وسمعتوا عنها. وسمعنا بقى عن تعبيرات زي pain without stain، العيان موجوع على طول والكورنيا مش شغاله كويس رغم ان ما فيش ألسر باينه، ما فيش ستيننج. فالبوست ريفراكتيف سيرجري هو ده الحقيقه القوه الدافعه اللي ادت لهذا الموضوع اهميه، بالاضافه زي ما قلنا الكيميكال انجريز والاوكيولار سيرفيس ديزيز والنيورو سيرجيكال بروسيدرز. ماكي كان عمل كلاسيفيكيشن لللوس اوف كورنيال سنسيشن الى 3 ستيجز. الستيج الاولاني اللي هو المايلد اللي بيجي لهم بانكتيت كيراتوباثي، لكن لما بيتحط الارتفيشال تيرز الامور بتتحسن. ستيج 2 اللي هو رغم الارتفيشال تيرز الموضوع ما بقاش بيتحسن وبدا يحصل persistent ulcers، الاستروما تبدا تبقى affected، تبدا تبقى opacified. وستيج 3 طبعا للاسف لما يبدا يحصل perforation وميلتنج للكورنيا. كنا بنعمل ايه للعيانين دول؟ كنا بنديهم لوبريكانتس ونقول لهم امشوا بالقطره وحطوا القطره كل ساعه كل ساعتين. ممكن نحط باندج كونتاكت لينس ونزود الانسيدنس بتاعت الانفكشن. ممكن نعمل امنيوتيك ممبرين ترانسبلانت عشان يحملنا الابيثيليوم شويه. في الاخر كنا بنعمل ترسورافي او نحقن بوتوكس في الابر ليد عشان نقفل العين، وطبعا ده حل يعني العاجز اللي في الاخر مش قادر احافظ على العين فاقوم قافلها وخلاص. لغايه بقى ما ظهر هذا التكنيك. التكنيك ده بيعتمد ان انا هجيب نيرف سليم واخليه هو اللي يغذي الكورنيا. فيا اما النيرف ده بجيبه دايركتلي، يبقى ده الدايركت ميثود اوف كورنيا نيوروتايزيشن، واوصله دايركتلي بالكورنيا، وده يستدعي ان هذا النيرف يكون قريب قوي، يعني السوبرا اوربيتال او السوبرا تروكلير او الانفرا اوربيتال اوف ذا سيم سايد. فده يستدعي ان هذا السيم سايد الترايجيمنال يكون شغال. ده التكنيك ده ما ينفعنيش لو الانجري سنترال او في الترايجيمنال. يا اما الاندايركت ان انا بروح لنيرف شغال واحط جرافت ما بينه وما بين الكورنيا. والنيرفز بقى اللي بقدر استخدمها are the same nerves but of the opposite side من الناحيه الثانيه. فبحط نيرف جرافت ما بين النيرف من الناحيه الثانيه وما بين الكورنيا اللي انا عايزها. يبقى انا عندي تو سيرجيكال تكنيكس، الدايركت والاندايركت. زي ما قلنا انا باخد من السوبرا اوربيتال او الانفرا اوربيتال او السوبرا تروكلير، ابسي لاترال او كونترا لاترال حسب كل حاله وحسب السايت اوف ذا انجري. طبعا احاول اخد من فوق السوبرا اوربيتال او السوبرا تروكلير عشان الافكشن اوف ذا شيك بيديسترب العيان اكتر من افكشن اوف ذا فور هيد. كل ما كان النيرف اللي هاخد منه فيكر وفي نيرف فايبرز اكتر، كل ما احتمالات ان الريتيرن واللي يرجع للكورنيا بتاعتي اكتر، وبالتالي السوبرا اوربيتال يبقى احسن من السوبرا تروكلير. ثم ظهر تعبير جديد بقى هنبدا نسمعه كتير في الاوفثالمولوجي اسمه كوابتيشن. كوابتيشن هو لما تحط نيرفين يلامسوا بعض وهم اصلا ما كانوش ملامسوا بعض، وماذا يحدث عندما two nerve fibers of different nerves يتقابلوا ويلمسوا بعض، والامبلس بيتنقل ازاي من واحد لواحد. ده تعبير جديد، وتعبير بقى فيه اكشن بوتنشال وفي فيسيولوجي كتير وتشانلز بتنقل الامبلس من النيرف الاولاني للنيرف الثاني. طب لو انا هحط نيرف جرافت، انا باخد يا اما من ورا الودن الجريتر اوريكولر، يا اما باخد احسن من الشورال نيرف، وده يستدعي ان يبقى في جراح موجود معاك في العمليه بياخد لك من الشورال نيرف. ميزه الشورال نيرف انه اكيد اطول من الجريتر اوريكولر، هو ارفع شويه الحقيقه لما بنشتغل لكن هو اطول، فده بيديني حريه احسن ان انا يبقى معايا نيرف جرافت طويل، فاقدر اخد من الناحيه الثانيه بسهوله، اقدر اخد من السوبرا من الفرونتال حتى بتاع الناحيه الثانيه احسن. فالشورال هو الحقيقه اللي احنا بنستخدمه. انا يعني انا ما استخدمتش ابدا الجريتر اوريكولر، لكن بنستخدم الشورال نيرف، وهنستخدم نيرف جرافت هجيب سيرته كمان شويه. بنوصل النيرفين ببعض. في الاول كنا بنشتغل اند تو اند، لازم اوصل الاند ده بالاند ده، لكن دلوقتي بالموديفيكيشن بقينا نقدر نوصل الاند بتاع الجرافت للسايد بتاع الاوريجينال نيرف، يعني الاند بتاع الشورال جرافت للسايد اوف ذا سوبرا اوربيتال او سوبرا تروكلير. هنشرح في التكنيك احنا بنعمل مالتيبل linear incisions superficial incisions عشان اكشف النيرف فايبرز، بشيل النيوروليما البرانيه واقرب الاند بتاع الشورال نيرف، وبعدين الاند الثاني بتاع الشورال نيرف بايباس below the skin and the orbicularis لغايه السوبيريور فورنكس، ثم below the conjunctiva لغايه ما وصلوا للليمبس. وعند الليمبس خلينا نتفرج على الصور. ادي الشورال نيرف جرافت بتاعي تحت من هنا ازاي بوصله لعند الليمبس وافتح عند الليمبس، وده هنا وانا بتككه تحت السكين لغايه ما اوصله الليمبس. وعند الليمبس النيرف فاسيكلز بسيبريتد لاربعه او خمسه، اثبت واحده عند الساعه 3، واحده عند الساعه 6، واحده عند الساعه 9، واحده عند الساعه 12، بحيث ابقى ضامن ان النيرفز اللي هتجرو تو انفيد ذا كورنيا من ديفرنت دايركشنز. بثبته ازاي؟ بنثبته الحقيقه احنا ب 8-0. بعض الناس بيعملوا تانل سكليرال تانل ويحطوا النيرف تحت التانل، لكن وي دونت دو ذات لغايه دلوقتي. احنا بنثبتها بسوتشرز 8-0 سوتشرز. فاحنا هناخد السيرجيكال بروسيدرز بتاعت الاندايركت تكنيك اللي احنا بنستخدمه، ان احنا بناخد النيرف جرافت. زميلي بتاع جراحه التجميل بياخد لي الشورال نيرف جرافت، بطلع النيرف اللي الناحيه الثانيه اللي انا عايز اخده سواء سوبرا اوربيتال او سوبرا تروكلير، وده سهل قوي. اي حد اشتغل اوربيتال سيرجري بيعرف انه كان ايدنتيفاي تو نيرفز دول بكل سهوله، واحنا بنقدر نحسهم عند السوبيريور اوربيتال مارجن، فدي مش مشكله. في الاول كنا بنصر على اند تو اند، دلوقتي بقينا بنشتغل اند تو سايد. بره بيحطوا فايبرين جلو عشان يلزقوهم في بعض، احنا بناخد 10-0 نايلون، بس بنعمل لينير انسيجنز، بنشرط بالمصري بالعاميه بنسميها بنشرط السوبرا اوربيتال او السوبرا تروكلير عشان اكسبوز لارجر اريا من النيرف فاسيكلز والنيرف فايبرز. بعد كده في الناحيه اللي انا عايزها بعمل ليد كريس انسيجن، وبستخدم الرايت نيدل بتاعه التوز السيرجري ادكك بيها الشورال نيرف جرافت ما بين المكان السوبرا اوربيتال او السوبرا تروكلير لحد الليد كريس انسيجن، وبعدين بدخل من الابر فورنكس اخد الاند بتاع الشورال نيرف جرافت من الكريس انسيجن. تمام. وبعدين بسيبريت زي ما شفنا بقى في الصوره الى different fascicles. نرجع للصوره، بس بسيبريت الى different fascicles. اهو النيرف الشورال نيرف جاي من السوبيريور فورنكس اللي باين ده هنا الليد كريس انسيجن الطرف بتاعه، واثبت الفاسيكلز ات ذا ليمبس ب 8-0 سوتشر، وبعدين بقفل الكونجكتيفال انسيجن. ممكن اعمل تمبراتور ثيرابي او احقن بوتوكس في الابر ليد عشان ادي فرصه للبروبر هيل. الهيلينج بياخد وقت الحقيقه. It takes about 2 to 3 months عشان الكورنيال سنسيشن يبدا يرجع. and it takes up to 6 months عشان يرجع في السنتر، لان هو الانفيجن بيجي من البريفري، يبدا النيرف فايبرز تنمو بالراحه، فit takes time. في حاجات بتساعدني على ان التايم ده يقل، يا اما لو عندنا القطره اللي موجوده في امريكا اللي هي نيرف جروث فاكتورز، هي غاليه، بيحضروها في امريكا بيبعتوها ب $2000، فبالتالي هي غاليه علينا. احنا بنستعيد عنها في مصر بالسيرم اي دروبس، كلنا عارفينها وبنستخدمها كتير في حالات الدراي ايز او الكيميكال انجريز، على اساس ان السيرم مليان جروث فاكتورز. التحسن بيبقى تدريجي، تبدا الكورنيال سويلنج والاديمه تقل، السنسيشن بيرجع من البريفري للجوه، السيمبتومز بتاعت الاريتيشن والبين بتقل باي تايم. في الاخر وانا هوري لحضراتكم بقى الحالات، الكورنيا بتتحسن، يا اما بتتحسن للدرجه اللي تخليني مستكفي بذلك والعيان يبقى كويس والنظر يتحسن، يا اما على الاقل بالذات بقى في حالات ستيفن جونسون او حالات الكيميكال بيرنز بتحسن لي الاريا عشان اعرف اعمل للعيان سكسسفul كيراتوبلاستي بعدها عشان اريستور الفيجن. انتوا عارفين ان حالات الكيراتوبلاستي في السيفير اوكيولار سيرفيس ديزيز نسبه نجاحها قليله قوي. واحد من الاسباب هو ان الميديم او الانفايرمنت اللي هتحط فيه الكورنيال جرافت سيء. احنا بالعمليه دي بنحسن الانفايرمنت، بنحسن التربه اللي هنزرع فيها الكورنيال جرافت، وبالتالي ده بيزود جدا الانسيدنس اوف سكسس اوف كيراتوبلاستي، بالذات طبعا في الشباب وفي الاطفال اللي انا عايز اريستور الفيجن فيه. احنا عملنا لغايه دلوقتي 8 حالات، طبعا مع وجود الكورونا في السنتين اللي فاتوا فده قلل الشغل شويه، لكن اول حاله بداناها كان قبل الكورونا على طول، كان عيان غير مصري. الدكتور محمود السالم كان بيقول الجنسيات، انا مش هقول الجنسيات، لكن عمل وجات الكورونا رجع بلده ما نعرفش عنه اي حاجه بعدها. في ابريل بعد ما الكورونا بدات تقل عملنا تاني حاله، ودي فتحت نفسنا ان احنا نزود بقى ونعمل حالات، لان حصل امبروفمنت في الكلاريتي اوف ذا كورنيا وفي الاكيوتي بتاعت الفيجن، وبالتالي عملنا ثالث حاله في نوفمبر. الفيجن فيها اتحسن من كاونتنج فيجر ل 36، بس ده بياخد 6 شهور على الاقل. الكام شهر اللي فاتوا او السنه اللي فاتوا في 22 عملنا 5 حالات كمان. انا كنت في زياره لامريكا من عده شهور، فاشتريت من هناك النيرف جرافت علشان اسهل على العيانين، ما احتاجش ناخد من رجليهم لان ده بيطول قوي مده العمليه وبيجبرني على الجنرال انستيزيا عشان اخد من الشورال نيرف، فجبت حالات بريزيرف نيرف جرافت. هو لسه مش افيلبل دول في الميدل ايست، فبنضطر نجيبهم من بره، لكن الحقيقه احنا سعداء جدا بالتكنيك، سعداء بالريزلت. اتس تايم كونسيومينج، العمليه بتاخد حوالي 2 ساعتين، بنضطر نعمل انستيزيا، بنضطر نفتح في الرجلين، لكن الاند ريزلت ان احنا نرجع للكورنيال ايبيثيليوم الفيتاليتي بتاعته، نرجع الريفلكس ستيرنج اللي كان بيحصل، نرجع الريفلكس بلينكينج، ده مخلينا سعداء الحقيقه بالنتيجه دي. وباذن الله يعني احنا هننشر السيريز دي، بنكتبها، واي هوب ان هي تبقى بينيفيشال، وان ده يفتح مجال جديد لمجموعه من العيانين كانوا الحقيقه تعساء جدا وميزربل وما كانش عندهم اي بديل اخر. اشكركم جدا يا فندم.
Next, Dr. Tarjani Vivek Dev. She is Associate Director, Kalam Anji Reddy Campus, Adjunct Professor of Ophthalmology, University of Rochester, New York, Consultant Ophthalmologist, Ophthalmic Plastic Surgery and Facial Aesthetic, Ophthalmic Ocular Prosthesis. She will speak about contracted socket management. Dr. Tajani.
Yeah, thank you. Am I audible?
Thank you. You are most welcome.
Thank you so much. I can see Tariq there. Very nice to see him. And thank you, Tariq, for having me here. And a special thank you to Marwan for training with us. One of the best mentees I've had in my life has been your Marwan Farhan. So I'm going to, without much ado, move ahead with the presentation that Marwan asked me to do. And this was about contracted socket. However, I thought it would be nice if I take you through the way we approach sockets over here. And that's going to be the theme of my presentation. I will show you certain full face photographs of my patients for which we have the consent in place. I do not have any financial presentation, which I try to do through these 10 points. So when I say that you should have an ideal socket for every patient who's lost vision, what do I mean by that? Well, you need to have the correct identification of the pathology. If you have a tumor in the eye, or even a suspected tumor in the eye, you'd want to treat that patient with an enucleation and not an evisceration, because you want to remove the tumor completely. If, on the other hand, you have a thicical eye, like you see in this lady, you'd want to go ahead and perform an evisceration with an implant, because it preserves the orbital anatomy, preserves the muscles, and gives a better aesthetic outcome to the patient. It goes without saying that when you talk of an ideal socket, you want to have good volume within the socket. You see that once an implant is placed, the sulcus has become fuller. And you also want to have a good surface area within which your prosthesis sits without any eyelid anomalies. And the prosthesis which is crafted for these patients is made from very good quality PMMA or polymethyl methacrylate. So I briefly spoke to you about evisceration and enucleation and the indications. We'll not talk about exenteration in this talk, but I'll just take you through certain examples and try to see if the message that I tried to give across has synced in. So you're seeing 3 cases here. The first one is a suspected intraocular trauma, and the third one is orbital mucormycosis. And again, goes without saying, when you have a tumor, you'll perform an enucleation with the implant in the first case, which is what was done. In the thysis bulbi, you're justified in performing a lesser mutilating surgery, which is evisceration, where the muscles and the sclera are preserved. And in certain situations like orbital extension of tumors or mucormycosis, which is covering the entire orbit, you might want to exenterate the orbit. So I'll briefly take you through these surgeries. The first surgery you're seeing over here is an enucleation and implant. And the very first step in any socket surgery is a very detailed timeout where you've ensured that you're removing the eye which has the pathology, because if you don't do this, it might really put you at risk at some point of time. So what we've done is a peritomy, and then we are dissecting the posterior tenons in the 4 oblique quadrants. Suture, which is about 4 to 6 millimeters from the silk suture. Now, this second vicral suture acts as what is known as a myoconjunctival suture. I'll tell you what it does in a bit. So you're going to do this process for all the 4 recti muscles. The oblique muscles are not of very big importance in socket surgery because the motility they provide to the prosthesis is very, very minimal. But this concept of having 2 sutures is extremely important. The second vicral suture especially, which is going to impart motility to the prosthesis. So I'm just going to fast forward the video a bit for the want of time. So you're seeing over here last rectus, which is the superior rectus, which is being tagged with a 4O silk suture. And then you'll see a vicryl suture, which is taken about 4 to 6 millimeters from the suture. Now, once you have all your 4 sutures in place, you go ahead, strum the optic nerve, dissect the optic nerve with 1 bolt cut of your scissor, and try to prolapse the globe out of the socket. Once you've done this, you send that eyeball for histopathology, and what you'll see is posterior tenons with the fat into which you place your orbital implant and close the posterior tenons over it with multiple interrupted sutures. Once you have closed all the area of exposed posterior tenons, then the 4 myoconjunctival sutures come into play. So this is the inferior myoconjunctival suture, which is then exteriorized into that particular fornix. So all those 4 vicryl sutures through the extraocular muscle are brought out. What these do is they translate the movement of the muscle to the edges of the prosthesis, which are actually sitting or resting in these 4 quadrants. And therefore, the muscle's movement is directly translated to the prosthesis, and you have better motility, even though you've performed an enucleation. Once this has been done, the anterior tenons is closed, again with interrupted 6 vicryl sutures. And finally, the conjunctiva can be closed off with a running 6 suture. That's the end of the surgery. And then you go ahead and place a conformer in to keep the fornices formed in the immediate postoperative period where you're likely to have some edema, and keep the conformer in place with the help of a tarsorrhaphy. You typically can perform an intermarginal tarsorrhaphy. This is just post-operative pain control with some amount of ropivacaine, which is a long-acting painkiller which is used. Now, in comparison to this, what you perform in evisceration in the initial steps is exactly similar, where you perform your peritomy, you go ahead and dissect your posterior tenons in all the 4 oblique quadrants, and then what is different is you do the intraocular contents either with a, and once you've scooped out all the contents, you then go ahead and wash the scleral cavity with alcohol. If there are bleeders, those can be cauterized as well. This is absolute alcohol which is used, and then it is washed off with saline because absolute alcohol is very inflammatory. And therefore you don't want to have residue of it. Ideal sclerotomies. So you're going from sclera connects to the optic nerve. You're disinserting the sclera from the optic nerve. So you have these 2 flaps of sclera, which are going to find it now easy to move and cover the implant. And therefore there's no tension on your wound, and you can place as large an implant as is required to give you a very good cosmetic outcome. Once you've placed your implant inside, you can go ahead and suture the sclera. And following this, the steps are similar in terms of closure of anterior tenons and conjunctiva as what I showed you in enucleation. And then at the end of the surgery, you place a conformer, do a tarsorrhaphy, and given some pain control. So this schematic shows you what happens when you perform these sclerotomies posteriorly. You could also choose to use a porous implant instead of a non-porous implant. The only change here is you'd need an implant introducer to ensure that there's no drag on the orbital tissues as you put that porous implant into the orbit. So essentially this schematic here shows you that this sclera is now a flap which is suspended by one extraocular muscle. So it's not a free graft, but since it's disinserted from the optic nerve, it finds it easy to come over the implant and give you a tension-free closure over the implant, which is the most important step against implant extrusion. Now, what has been taught to us is when you are performing any of these socket surgeries, you should ideally be augmenting 20% of the volume with the implant, and the remaining 30% should come from the prosthesis. So for eyes like ours, which have an axial length of about 23 to 24 millimeter, you should ideally be using about 20 to 21 millimeters as an implant diameter in nearly every case. You do not see this. And when you don't have enough volume augmentation in the orbit, then what you see is a superior sulcus deformity. For example, you see this gentleman who's undergone an evisceration. No implant was placed because he had endophthalmitis when the evisceration was done. And then now he has a prosthetic eye which looks smaller with this sulcus deformity and an enophthalmos, primarily because there's no volume which is keeping the prosthetic eye supported. And all we did in this gentleman was to place an implant secondarily, and you can see a good buildup in the sulcus as well as a good correction in the enophthalmos, and therefore a better aesthetic outcome. You might at times have patients who come to you with an implant, some amount of a sulcus deformity. This small residual sulcus deformity can simply be corrected by harvesting some amount of fat from the patient's own body. We generally tend to do this from the abdominal chin or any area which has a good amount of fat and inject it behind the eye to induce a proptosis and therefore correct that sulcus deformity. If your patient does not want a surgery to do this, you have the option of using injectable fillers. I have this one gentleman from Oman over here who underwent an evisceration and implant on the right side, but was not very happy with the difference in the sulcus on two sides. And all we've done is injected about 1 ml of filler into his orbit. And you can see this is the point of injection. And you see that the enophthalmos has built up and so has the sulcus. And he's much happier just getting this one injection in the clinic and going back home. Now, certain patients tend to have a severe loss of volume in the socket. And what that does is it makes the prosthesis really thick and heavy. And that thick and heavy prosthesis puts a lot of pressure on the lower eyelid. And therefore, you see an eyelid which is retracted, lower eyelid which is retracted. In this kind of a situation, you can also go in and put a wedge implant. What we've used in this case is a Porex wedge implant. And you can see that the weight of the prosthesis has gone down after the wedge implant has been placed. There's no eyelid procedure that's done for this patient. The only thing that's done is introducing volume into the orbit with this wedge implant and then giving him a new prosthetic eye, which is smaller. The second component of the socket is how the surface is. Now, an ideal surface is something which allows the prosthetic eye to move significantly, especially when the patient is showing emotion. When he closes or blinks his eye, there should be complete closure. There should be no leg ophthalmos. And obviously, a prosthetic eye should be very stable in that situation. So that is an ideal surface area. Sometimes you do not have that. So this is a lady who does not have an implant, and along with that, also has loss of surface area in terms of having a shallow fornix. So what do you need to do here? You need to build in the volume, and you also need to give back the surface, which has been done with the help of a mucous membrane graft and fornix formation suture. So if you compare her preoperative appearance to the postoperative appearance, you can see that this retraction in lower eyelid has become normal. The sulcus, which was shallow, has actually become deep. Yes, she has some amount of ptosis, but this can always be corrected with a very minimalistic ptosis surgery. Yet another patient who did not have an implant, and you see that retraction in the lower eyelid. He's undergone a skin graft earlier to form the fornix, but he still has a residual shallow fornix. And what we've done for him is implant and augment the surface. We were able to reduce the weight of the prosthesis normal position, and he looks better. In certain sockets, along with loss of your fornicial conjunctiva, you also tend to see an amount of entropion because there is contracture of the conjunctiva that lines the upper as well as the lower tarsal conjunctiva, and therefore you see a component of cicatricial entropion in these patients. Again, since the posterior lamina is contracted, you're going to lengthen the posterior lamina, and what we've used in this lady is a hard palate mucosal graft that's harvested from the hard palate and is transplanted into the eyelids, upper as well as lower eyelids, as a spacer graft, along with performing a secondary implant and MMG for the surface and volume augmentation. This is after the graft area has healed. You do not need to take any sutures or perform placement of amniotic membrane graft or any such thing. This area heals by itself beautifully. And you can see that along with the buildup of the surface, the volume, the eyelid is now in normal position with a very good prosthesis and everted eyelashes, something that's making her look much normal. Now, none of this would look complete until and unless you have an oculoristry team that gives you excellent artificial eyes. And one of the things that you can do is to actually print the contralateral normal iris and use a kind of photo paper that can be incorporated into the prosthesis. This is known as a digital iris. So what this does is this takes away the need to have a very elaborate painting process for the iris. And the iris is the one which is giving, the kind of clue whether it's a prosthetic eye or not comes from how the iris has been painted. So you can get away by using some amount of Photoshop and using the contralateral eye. Certain other things that you can also do, as you see over here, is sometimes these prosthetic wearers complain that the eye looks very dry and does not look natural. And to increase the hydrophilicity of the PMMA, you can treat the PMMA in a plasma machine that makes the wettability better and gives a
Doctor, we lost the voice. Hello?
Aesthetic outcome. You man who has a surface as well as loss, you see a sulcus deformity, you see a retracted lower eyelid. So in the first step, what we've done is we've actually replaced the volume with an implant and the surface with an FFS and MMG. Then we've given him a prosthesis. He complained of some amount of difference between the right and the left eye. He had minimal ptosis, which was corrected. And he was also keen to make the brow area look symmetric to the other side. And therefore, he's had a little bit of filler injection at the points that you see over here to kind of take care of the tear trough, the dark circle appearance, and build up the fullness in that area. Now, I just wanted to touch upon certain complications. You might have situations where you will have implant migration. And the concept that if an implant migrates, you remove and place another one does not hold true. No matter how many times you do that, once migrated, the second implant that you put in will also migrate into the same quadrant. And therefore, the way to treat this has to be different. How do you do that? You actually block the quadrant of migration with a second implant. And how do you make this second implant? You make it by 3D printing. So you see over here a gentleman who's not able to hold the prosthesis in place because the implant is migrated, and it's also resulting in a shallow fornix. And after we've placed a second implant crafted via 3D printing, he's able to wear his prosthesis and hold it in place. Just wanted to show you what this exactly means. So we take two-dimensional scans of a patient, and we use a readily available online software to convert it into a three-dimensional model. As you're seeing over here, you crop your, we only wanted to look at one orbit, we print that orbit, and then this information is sent to a 3D printer, which can print patient's life-size orbit in a plastic material. And here you're seeing the 3D printer doing its magic. It sort of tends to lay tissue layer by layer, the exact opposite of what happens in LASIK, where you're removing tissue layer by layer. The 3D printer is actually laying down tissue layer by layer. And you can see that behind this support structure is actually the orbit which has got printed. And then you remove the 3D printed structure, you put it in a water bath, which takes away the support structure, and you, lo and behold, have the patient's orbit in your hand. And then you can craft any kind of implant that you want, using the techniques you usually use in the oculoristry lab. Few other complications: when you see proptosis of a prosthetic eye, think of two things. If there was a tumor because of which you enucleated that eye, think of tumor recurrence. If it was not an enucleation and you performed an evisceration, then the commonest cause is peri-implant cysts. And this cysts originate from the epithelium, conjunctival epithelium, which is actually now growing inwards towards the orbital implant. Rather than excising this, a better option is to just aspirate the contents and inject a sclerosant like sodium tetradecyl sulfate. It's a very small procedure and immediately gives back the appearance to the patient. So the management paradigm for socket cases is look for the presence of surface loss. If it is there, address it. Look for the presence of volume loss. If you have both surface and volume loss, you can address both in the same sitting by placing a secondary implant, performing a fornix formation suture and a mucous membrane graft. Assess for adequacy of prosthesis, and then finally assess the eyelids, because without all these touch-ups, you'll never be able to take a patient from here until here. That's all that I wanted to convey. I've spoken to you about an ideal socket, evisceration and its technique, enucleation and its technique. I've spoken to you about some complications that you see in socket surgery, and briefly spoken to you about options of surface and volume augmentation. Thank you so much.
Thanks a lot. Thank you. Next, we will have Dr. Mahmoud Al-Salim, the implementation of plasma exeresis technique in our oculoplastic practice in Amman, Jordan. تفضل دكتور. دكتور محمود. دكتور محمود. ممكن تفتح الصوت دكتور محمود؟
Harder. You hear me now?
Yes. Yes, you can start, please.
Fine. I'm trying to share my my slides. Okay. Do you see my slides? No? You see my screen? Okay. Actually, plasma exeresis is kind of a trending technology. Actually, in the last few years, I came across this technology, and I have no financial interest to disclose, but you know, the lust for beauty is a human issue. And as we age, we lose our elasticity, we lose the volume of the face, appearance of wrinkles appears more, and also pigmentation as well. So aesthetic procedures is really divided into two categories. One is surgical, as we know, and the other is non-invasive aesthetic, non-surgical, like platelet-rich plasma, fillers, Botox, needle shaping, carbopexy, mesotherapy, radiofrequency, and laser dermablation, and the plasma exeresis. All this because we are looking for effective, safe, no surgery, no blood, no hospitalization, no downtime, and affordable and in high demand. The story started in Subaras 2016 when I met Soteris Tessiomenas from Athens, and he had an effective, acceptable, safe procedure with no surgery, no injection, and no downtime. And he invited me to his clinic, and I had a chance to operate in these cases. These are first cases that I operated on in his clinic. And then a year later, he invited me to show the plasma exeresis Jordanian experience in a meeting, in the first aesthetic meeting. It was in November 2017. And I met a lot of colleagues. They are interested in the same subject as well. So why plasma exeresis? It is non-invasive procedure, rapidly replacing invasive one. and the term is يعني soft surgery. We call it soft surgery. And conventional blepharoplasties have got hospitalization, bloody, downtime lengthy, sometimes a week or 2 weeks, and could be risky, like this case who had a lot of excision of the lower lid skin. It's not my case, but you see, at least anyone can have this actually kind of mishap. At least we try to avoid this by soft surgery. So plasma is the fourth state of matter. It is ionized kind of atom, and it depends on sublimation. Sublimation, that means transformation of material from solid to gas state without passing into the liquid. Thus, it doesn't leave any scar behind. So it tethers the epidermis without destruction of the basement membrane, followed by full regeneration of the epidermis. And this is the machine. The machine is simple. It has got a base with wireless kind of cords with two at least hot and what we call it kind red, green, and in the middle the white one. And plasma is generated between the atmospheric gas and the instrument tip. It is kind of lightning, exactly lightning as this you see in this picture. And it causes a little spark. If you put the needle near to the skin, just at the skin, there is no spark. Okay, but you have to put the needle off the skin at least 2-3 millimeters, then you will get a spark. This spark will cause tethering and shortening of skin fibers. It's very good for wrinkles, and as you will see. So it has 3 wireless hand pieces, 3 degrees of power, mild, moderate, and high. Central charging unit, needles available everywhere. Any needle will do. And has no running cost, actually. It's a cost-effective technology, I assure you. And you prepare the patient by IMLA cream, IMLA or any kind of xylocaine with zinc oxide cream and so forth for half an hour. It will ease the pain. This is very important that you do also photography for these patients. Okay, and then you do kind of burns. Your burns should not really coalesce or should not overlap each other. The burn should have interrupted either dais or triangle. Okay, as shown here, it's a dais or a triangle somehow. Okay, over the high over the summit of the wrinkles, يعني top of the wrinkles. الحته العاليه هذول اللي بنكويهم بيصيروا كله ممسوح كله زي بعض. Okay, this is how you start. Interrupted spots, either zigzag or thin folds, dais or thick folds. And this is an example before and after. And also an example before and after. And so we start modification of this. You can do eyelid lift, any kind of eyelid lift with it. Of course, it is very good for mild cases, for young patients. Okay, this is ideal. This is ideal. Who does not really need surgery or bloody surgery and so forth. Now, and you can, for example, this patient, you can do her the right eye. Before you do the lift, you show her, stop and let her patient see immediately. You have immediate good results. Sometimes patients do need to have, like this patient, more than one session because she had a lot of kind of dermatochalasis. It is not good for the patient who needs quick results, quickly, or he wants it to have it all and one go. Okay, but if the patient has good time, you good time, then it's very, very useful. This is both eye treatment. Is small important trick is that I learned is that you wipe out the carbon as you go out. With white gauze. This is sorry. This is a typical patient who need it most. This is a dermatochalasis patient. He is 8 years and above, and he is on aspirin. He is in bleeding tendency patient. He is not fit for any surgical condition. I mean surgical interference. And he had this kind of actually the right eye first. We did his right eye first, and he came after a month, and we did his left eye because he has chosen to do one eye at a time and so forth. So really, it gives you much useful results. All what he needs is to take off kind of this dermatochalasis above his eyelashes. Okay, this was bothering him. And this is a typical patient. Also, after the procedure, you would like to put the patient, to give him photo block or a kind of sunblock. I use photo block 50 for 3 or 5 days, especially for young ladies and so forth. Sometimes it do 10s. So this is also a kind of non-ablative blepharoplasty. This is an example by Plexer. This lady has done the lower lid. The lower lid, she was the minimum surgery, and this was the minimum. The wrinkles. If there is a wrinkles, it will do very well. But if there is fatty herniation, it's not suitable. Okay, this 1 month. It's also brow lift, upper and lower blepharoplasties, and this is Plexer soft surgeries actually. And also we tried to do another procedure is that we augment. I call it blepharoplasty with plasma augmentation. we are doing the, for example, these patients with very bad dermatochalasis, they need to have their blepharoplasty done, but still you are not, at the end, you are not really satisfied, or the patient is not that satisfied. So you can do touch up, call it touch up, or another go in the clinic, and it does very, very good job. Also, this patient who had blepharoplasties, but there is wrinkles here and so forth, and you want to do that as well. So and also sometimes I call it any leftover blef job. Okay, this is like after you want to remove the site of the scar here and so forth. Okay, this bump, you cannot, you don't want to send the patient another to theater, but you can do this kind of soft ablation by Plexer. Combined surgery is very good. Sometime to augment, and at least you don't have to remove a lot of the skin. I mean, if you really want to tighten the skin, sometimes you are aggressive and you will end up in ectropion or whatever, or kind of lagophthalmos and so forth. This is very useful that you don't really slip into this kind of, so we do it combined surgery plasma, combined surgical, conventional surgery and plasma in the same day. Okay, and this is also the same condition. Look at this lady. This lady had a lot of dermatochalasis in the upper lid and little wrinkles here, but no fatty herniation. So what I did is conventional blepharoplasty in the upper lid, and the lower lid is just Plexer, just plasma exeresis, and it ended up, I mean, nicely. Okay, and also another case, it is much safer for the lower lid to be done by plasma than surgery if there is no fatty herniation. Also, you can use the benign lesions for benign lesion around the eye, for example, like this nevus or mole, okay, especially if you think it is normal. Also for xanthelasmas. Xanthelasmas, it's a miracle. You can do it and it gives you very good results. Even I have got much worse than this patient, and I have done, they are very good, all in one session now. Okay, you don't need to do 2 sessions for these cases. You completely eradicate xanthelasmas, wherever they are extensive. Also for cyst of moles or anything around the eyes, okay, and also for scar revisions, like this chap, and for scar, my scar. I did this kind of direct eyelid lift, and just happened to be my neighbor, and actually is not happy with the scar. I'm not happy. What I did is that I smoothened that scar immediately. I don't have to use anticolloids and so forth, and by Blixer, and gives you a very nice scar afterwards. Yes, you can use it for kind of very irregular folds, also neck folds people, and removal of tattoo, and also for eyelashes, apparent eyelashes. You can use it as a surgical tool, cutting tool like symblepharon, cutting encaloblepharon, dissecting pterygium, revision of filtering lips, whatever you want to do. It's a very useful tool in the clinic. This is a girl who had done actually in one of the Gulf countries, blepharoplasties, and it's not happy with this kind of lift up kind of wrinkles, okay, and we did it, and this is the results. At least she is happy with now. And also this lady who had got wrinkles, smoker's wrinkle here, and also frontal forehead wrinkles and so forth. So I call it full face kind of exeresis. Of course, it's not suitable for cases where you need to have to take off the fatty herniation. If you have fatty herniation, you have to do conventional blepharoplasty. Okay, the philosophy behind this is that if you really at the age of 30s and 40, between 30 and 40, and you have little wrinkles, plasma exeresis is the best for you. It gives you very good results. Okay, and you don't have to do anything else. But if you have a case very advanced, like people who come to us 50s, 60s, and they have a significant amount of dermatochalasis, you have to either tell them that they need several sessions of plasma exeresis, or they have to do the conventional blepharoplasties, and then you augment it by plasma exeresis. Okay, in summary, plasma sublimation is a new innovation in the world of aesthetic medicine. It offers an added tool to the hand of the surgical procedure. The tool can be used to treat a wide range of complaints, from wrinkles to scars and skin imperfection. It uses a plasma sublimation, called sublimation, extremely precise. Okay. The swelling subsides in 2 to 3 days, crusts fall in 5 days, redness usually goes away, itchy sensation, some pigmentation, usually you combat by photo block or sunblock. Finally, it's a new innovation in the soft surgery. I would consider it as a greatly needed tool in the hand of oculoplastic surgeons. And thank you again. I am very proud that I speak to you, and very proud again that I know at least 2 generations, at least, of view ophthalmologists from the time of Dr. Tawfiq Kayed, you know, the people I visited in Sana'a University, and Dr. Mahfouz Bamashmous now, in office and all others. Thank you, Dr. Tariq. Thank you, Dr. Mahfouz. And I'm very pleased to be with you. Pleased to be with Dr. Isam and other colleagues.
شكرا دكتور محمود. شكرا.
Thank you, Dr. Mahmoud. Thank you, Dr. Isam, and thank you, Dr. Tarjini. Any question for these nice lectures? Dr. Marwan.
Good evening, Dr. Mahmoud, and Dr. Isam and Dr. Tarjini. Thank you so much, and nice to see you again. Dr. Mahmoud, in cases of ptosis in children, or any case with you are going to do the surgery in general anesthesia, how much is the amount of the resection? Which type do you use, Berg or Beard rules to detect the amount, especially in children, in which you would bend to detect the amount of levator resection?
It's a very good question. This is always people are scared because the general anesthesia, as I told you, when you do a local, you are doing the ptosis if you are doing adjustable suture. But if you are doing in general, actually, you have to have at least measurement, some idea about the levator function, okay? And then actually, I use the gabbing method. The gabbing method is a kind of how much really the eyelid gap usually you take by the ruler caliber, by the caliber. Actually, if you have good levator function, you would like to put it actually at 6 or 7 gap, okay, not more. But if you have poor levator function, you have to put it more than 6 or 7, okay? This it comes with experience, but the gabbing method, I find this is very useful, very useful. Usually, some people are putting 6 as a guideline. I put a 7, my guideline, and usually you are not mistaken. There is a calculation that every 6 millimeter, depends on the levator function and the amount of ptosis. Okay, but the gabbing method is the best actually. Okay, yani each case should be considered in its own merits.
Any question? Prof. Isam, corneal neutralizations أول مرة نسمع عنها، فبالتالي معلوماتنا فيه كلها ضعيفة جدا.
It's a new procedure. هي يعني التكنيك جديد بقاله في 4-5 سنين. هو معمول علشان إنقاذ الحالات الصعبة. زي ما قلنا بالنسبة لنا احنا هتبقى حالات التروما، حالات الكيميكال انجريز، حالات الاوكيولار سيرفيس ديزيز السيفير تايبس منها. في المستقبل، وهو ده اللي هم يعني بيتكلموا فيه علشان البوست ريفراكتيف سيرجري، في بدء حالات تظهر كومبليكيتد باللوس اوف سنسيشن نتيجه المايكرو كيراتوم. لكن احنا ما عملناش اي حاله بوست ريفراكتيف سيرجري الحقيقه. احنا كل ال8 حالات اللي عملتهم لغايه دلوقتي وكلها تروما وكيميكال انجري واوكيولار سيرفيس ديزيز. النتائج كويسه قوي سواء عندنا او عند الاخرين. اي هوب يعني هي برضو سلاح جديد معانا بنعالج بيه حالات ما كان لهاش اي حلول تانية. يعني الحالات دي كانت حالات ميزربل كلنا شفناها وكله حضراتكم عارفينها. ما كانش في اي لها امل تاني، فاحنا بنفتح باب امل جديد لهؤلاء الجروب من المرضى. والتيكس تايم على الاقل 3 إلى 6 شهور. العمليه عمليه طويله زي ما قلنا 2 ساعتين. في حاجات بتساعد فيها زي النيرف جرافتنج اللي بنجيبه من بره او القطرات اللي فيها نيوروتروبيك فاكتورز. لكن الحقيقه احنا تجربتنا في ال8 حالات لغايه دلوقتي احنا سعداء بيها.
شكرا بروف. Any questions؟ شكرا دكتور محمود، شكرا دكتور عصام، ثانك يو دكتورة ترجيني. نلتقي مرة أخرى إن شاء الله، وإن شاء الله يكون في صنعاء إن شاء الله.
إن شاء الله.
شكرا، يعطيكم العافية.
Thank you everyone.
يعطيكم العافية، شكرا.
في ريبورتاج بسيط وحفل تكريم إن شاء الله.
إذا ها نحن أيها الحضور الكريم نأتي وإياكم إلى ختام اليوم العلمي السادس للجمعية اليمنية لأطباء العيون. إذا بعد أن طفنا سوية في محاضرات هذا المؤتمر المبهرة والممتعة، ونتمنى أن الجميع قد اكتسب معلومات جديدة أضافت إلى مكتبته العلمية الكبيرة لتكون فائدة في الحياة العلمية والعملية القادمة بإذن الله. قبل أن ننهي نتوجه بالشكر لكم، أولا نشكر حضوركم واهتمامكم، وقبل أن نبدأ بحفل التكريم هناك كلمة سيقدمها الدكتور طارق الدعيس نيابة عن الجمعية اليمنية لأطباء العيون. ليتفضل الدكتور.
بسم الله الرحمن الرحيم، الحمد لله والصلاة والسلام على رسول الله. هي ليست كلمة، هي كلمة شكر لحضوركم أعمال المؤتمر العام السادس، كما هي رسالة اعتذار. احنا كنا مخططين ومجهزين المؤتمر في عدن، لنا 6 أشهر أو 5 أشهر نعمل في عدن. طبعت كل الأدبيات، البطائق، الشهادات، الدروع، الشنط، كلها كانت في عدن. بلغنا في اللحظات الأخيرة يوم الأربعاء عصرا أنه تم الإلغاء، وفي خلال ساعات استطعنا والحمد لله أن نقيم مؤتمر في صنعاء وننقله، نغير البرنامج العلمي، نطبع بطائق، شهادات، دروع، أشياء كثيرة. فهناك شيء من التقصير، نعتذر للأطباء الذين قصرنا في حقهم، نعتذر عن أي تقصير. كما أن نحن نشكركم حضوركم، نشكر المحاضرين المحليين والدوليين، نشكر الشركات الراعية، والسلام عليكم ورحمة الله وبركاته.
شكرا لسيادتكم دكتور طارق الدعيس. الآن نبدأ في فقرة التكريم. ليتفضل ممثلو الجمعية اليمنية لأطباء العيون للتكريم. الأستاذ الدكتور محفوظ ومشموس، الدكتور محمد الشكيل، الدكتور محمد إبراهيم، الدكتورة فائزة المقطري، والدكتور طارق الدعيس. أولا وبداية نبدأ بأطبائنا الكرام من محافظة عدن، الأستاذ الدكتور صالح باصالح رئيس المؤتمر، ثم الدكتور أحمد علي رئيس اللجنة العلمية، الدكتور صالح زين رئيس اللجنة التحضيرية، إذن الدكتور أحمد علي رئيس اللجنة العلمية، الدكتور صالح زين رئيس اللجنة التحضيرية، الأستاذ محمد بايزيدي من شركة إيفرست لتنظيم المؤتمرات، نبدأ الآن بتكريم المحاضرين، وترتيب الأسماء في التكريم الآتي معتمد على ترتيب تقديم المحاضرات كما هو في الجدول العلمي للمؤتمر. بداية الدكتور إبراهيم الحمدي، الدكتور محمد الحميري موجود، الدكتور عبد الرحمن الحمادي، الدكتور عادل حميد، الدكتور عادل حميد، المعذرة منكم دكتور، هذا سمرنا. الدكتور نبيل طارش، الدكتور صديق السلام، الدكتورة آسيا الزراعي، الدكتور عبد المغني البراق، الدكتور مطهر الشاعر، الدكتور عمرو الميسري، الدكتورة فايزة شمسان المقطري، أكيد نكرم الدكتورة، الدكتور هاني الجشاري، الدكتور عبد الله الفقير،
Grammarly makes communication at work.
الدكتور خليل الخطيب. الدكتور محمد صادق الأعور. الأستاذ الدكتور محفوظ بامشموس. الدكتور محمد ياسين. الدكتور صالح الديب. الدكتور طارق الدعيس. الدكتورة أروى الطل. الدكتور مروان فرحان. الدكتور محمد العنسي. الدكتور محمد الشكيل. الدكتور محمد إبراهيم. نكرم اللجنة التنظيمية الرائعة بقيادة الدكتور صهيب الأديمي. الفريق المنظم بقيادة الدكتورة بلقيس النويرة، فريق تايدنج. ليس أخيرا طبعا المهندس المتألق مبارك العامري. طبعا لا ننسى من كان لهم الفضل بعد الله في إنجاح ودعم هذا المؤتمر من الشركات والمؤسسات والراعين، منهم الرعاة الماسيين، شركة فيجا فارما للأدوية، شركة ابن القادري، مؤسسة البصرة الخيرية العالمية، الرعاة الفضيين، مؤسسة الفلاح التجارية، شركة أوكيديا بمجموعة الرشيد، مؤسسة سام الطبية، رعاة المشاركين ناتكو فارما، مؤسسة بازرعة التنموية الخيرية، شركة الجزيرة والخليج، الجيش للتجارة والأدوية، مؤسسة صادق البرحي، المؤسسة المتحدة للأدوية، مؤسسة الرمال للأدوية، مؤسسة مزدان. مؤسسة الرمال للأدوية. مؤسسة مزدان. شركة سيمنز. شركة تهامة. مؤسسة المدينة الطبية. شركة نشوان فارما المحدودة. مجموعة الجبل للتجارة والصناعة والاستثمار. مؤسسة الرباح التجارية. أخيراً شركة الملك. إذا نكون إلى هنا وصلنا إلى ختام المؤتمر. نتمنى أن نراكم بإذن الله في مؤتمرات قادمة. طبتم وإن شاء الله ليلة سعيدة لكم جميعا بإذن الله. في أمان الله.